Okay, it looks like we are live streaming. I'm going to turn it back to my good co-chair, Senator Anwar.
Thank you, Madam Co-Chair. And I would ask Representative Claire Desditra, who's our ranking member, if she has any opening remarks or comments.
Thank you, Mr. Chair. Looking forward to a long conversation today and hearing all the speakers. So hopefully we'll get through this as quickly as possible for everybody. Thank you.
Thank you. And I don't see Senator online right now, Senator Heather Summers. She's going to join us shortly. And that brings us to the first person on our list right now to testify. I think the Senator Looney, I don't see him here, so he's probably going to join in shortly. There's another meeting going on, but I see Commissioner Nancy Navarrete with Demas, Commissioner, who's here. Welcome, Commissioner. Thank you for joining us.
Good morning, Senator Anwar, Representative McCarty Vahey, and members of the Public Health Committee. I am Nancy Navarrete of the Department of Mental Health and Addiction Services. Thank you for the opportunity to provide testimony on HB 6913, an act concerning opioids, and SB 9, an act concerning health and wellness for Connecticut residents. Demas has also submitted written testimony related to HB 6914, 6915, and SB 1211. In my written testimony, I've provided a narrative of the work that Demas has engaged in to address the ongoing opioid crisis. I am very proud of all the creative work being done in the substance use prevention, treatment, and recovery space. I also want to do more in order to stop these tragic overdoses. I am counting on your partnership and the partnership of a multitude of stakeholders, many who are in this room, to make this happen. In brief, the following is a sample of what Demas, in partnership with other state offices and community entities, have done to address the crisis. Provided in-person, person-centered opioid use disorder treatment, including outpatient, residential, and inpatient care. In 2022, we served 24,000 people with medication-assisted treatment, on pace to increase again this year. In 2022, almost 20,000 people served in residential and inpatient levels of care. We've utilized state and federal funds to implement evidence-based prevention, treatment, and recovery practices. We oversee the ADPC, the Alcohol and Drug Policy Council, and the Opioid Settlement Advisory Committee, which provides us a vehicle to coordinate service delivery using data from public health, consumer protection, law enforcement, and OCME. We've provided training and funding for providers to implement medication-assisted treatment, which you may know as MAT. We've distributed 30,000 naloxone kits. We funded outreach to communities, including prevention activities across the lifespan. We've implemented multimedia campaigns to educate citizens about opioid misuse, risks, and available help. We funded providers to meet people where they're at with mobile MAT, street outreach, recovery coaches or navigators, harm reduction messaging, 24-hour treatment hotline and transportation, a web-based treatment capacity website, which is front-facing. And as an example, we've treated or connected with 10,000 people just with the recovery coaches that are placed in the emergency rooms. SB 9, Section 4 establishes 3 harm reduction sites in Connecticut. Demas is supportive of harm reduction centers and provides funding for harm reduction sites in Hartford, which have been very successful. These centers provide access to naloxone, harm reduction information, supplies, recovery support, and connection to treatment. The centers collaborate with shelter providers to ensure that local programs have an adequate supply of Narcan, and staff are trained on overdose recognition and response to harm reduction best practices.
Excuse me, Commissioner, but your time is up. Thank you.
Please, Commissioner, continue. We really want to hear. As a question I wanted to ask you, please continue.
Thank you. The harm reduction centers do not allow or encourage use of controlled substances on site due to federal prohibition of the practice. Demas is concerned that language in SB 9 attempts to supersede federal law. Current federal law prohibits knowingly opening, leasing, renting, using, maintaining any place, whether permanently or temporarily, for the purpose of manufacturing, distributing, or using any controlled substance. SB 9 defines a harm reduction site as a medical facility where a person may safely consume controlled substances. Demas respectfully requests modification of this language until such time the federal government amends current law to allow this use of harm reduction centers. SB 9, Section 5 establishes an advisory committee to oversee the pilot of harm reduction centers. The ADPC membership includes many of the stakeholders mentioned in this bill. Demas respectfully requests the committee consider substitute language that utilizes the existing ADP subcommittee structure and process for this purpose. This structure, which allows for expert consultation and feedback, maximizes expert input and avoids duplication of committees and efforts. SB 9, Section 6 establishes a non-lapsing opioid antagonist bulk purchase fund. The department has made it a priority to make naloxone available to hospital emergency departments, treatment and recovery support providers, harm reduction service organization, and others. Demas employs an efficient system of purchasing naloxone directly from a distributor who mails it directly to the organizations who request the product. The ADPC has an existing prevention subcommittee monitoring the saturation rates of opioid antagonists as well as cost and availability. If in the future action as described in Section 6 is needed, the ADPC will forward recommendations for such action to the Public Health Committee. At this current time, Section 6 seems unnecessary. HB 6913, Section 1 of this bill is unnecessary due to current law and systems in place. Current law has established record retention periods of 7 or 10 years, depending on the healthcare entity. Standard clinical practice includes developing a client-driven discharge plan prior to a patient leaving a level of care. The discharge plan identifies community self-help clinical supports along with appropriate referrals. Effective individualized discharge planning and community-based peer supports, warm lines, access line, assist thousands of individuals serve to remain connected or to reconnect. The process as described in Section 1 of this bill would not be operational, costly, and drain clinical resources. Demas would like to express serious concerns related to HB 6913, Section 4. Demas has worked tirelessly to improve access to treatment for individuals with opiate use disorders. Vans providing medication to individuals living with substance use disorders have been an effective approach, reaching populations who often struggle with social determinants of health that limit access. Section 4 limits access to life-saving medication and discriminates against people with substance use disorders. So happy to take questions or discuss, further conversations.
Thank you
with
so
the
much,
committee.
Commissioner. Commissioner, I'll ask us a few questions and we're trying to limit our questions to 5 minutes per legislator between the back and forth. So I will ask questions fast and then how is Rhode Island able to do this with their funding when the federal government is not allowing that?
So Rhode Island currently has some legislation, which actually I believe expires in March unless something is done about that. They have not been able to bring anything up because of some community opposition, and they have been unable to find a brick and mortar building in order to bring this up.
And opioid settlement funds are probably the best source for this because opioid settlement funds are about saving lives and this saves lives. And we feel that's a good way to be able to address this for the funding of these.
So the opioid settlement funds still will be going through a state agency, so decisions will be made by the committee, but the actual contracting will be done by the State Department, Demas in this case. And so we'll continue to talk with the AG and other entities to see what we are and are not able to do.
The challenge we have is that despite a number of interventions, we have not had a major dent in the number of deaths. We are still losing about 4 people every day. Unless we do a very focused harm reduction strategy that is suggested in this bill, it's almost like the federal law is coming in the way of saving lives of our citizens. So we need to find a way to address that.
I agree. It's a very serious issue. There are people dying every day. And as you can hear from my testimony, we have attacked this from all fronts and will continue to do so. And we'll continue to watch the federal law so that we can be on top of best practices.
So I will yield to my other colleagues if they have a question. And otherwise I'll continue my co-chair has a question or comment.
Commissioner, thank you. I want to say thank you and that I do have a lot of questions and interesting conversation, which I will engage with you offline, just so that we can continue today to hear from the members of the public. But I want to thank you for the work that you're doing and appreciate your willingness to remain in dialogue with us.
Thank you so
Mr.
much.
Chair.
Seeing no other questions, I will continue some of my other questions. Do you think that some of the harm reduction work that is going on right now, there's an interest in some of the municipalities to create similar models outside of the federal restriction? How does Demas feel about supporting all of those things that Demas is doing, but have them in harm reduction centers, except the harm reduction centers are not engaging in what the federal law is restricting?
If I'm understanding what you're saying correctly, that would be a model similar to Connecticut harm reduction centers in Hartford.
Correct.
And yes, we love that model. We think they do good work and we would love to continue to expand that model.
Okay, and I think that model is helping a lot of people. I've seen that firsthand, looking at some of the people who are benefiting from this. That may be one way to get moving, and then we can start to see what are the ways around, because I know that the state of New York and the city of New York has been able to create a model that may be beneficial, and we may have some people who will testify to that later today and then see what are the opportunities. But I just want to make a comment that Demas has been a partner, and Demas has been doing all the work that you can do within the federal restrictions, which are unfortunate. But because we are losing people, it's important that we start to figure out how we can do the best for our community, and we will work with you like we always have. And we thank each and everyone who's part of Demas, who's a partner in our efforts to save our community.
Senator, I appreciate those comments and yes, look forward to continuing conversations.
Thank you. Thank you so much. And we have Representative Cleardis Dietra, who has a question or comment.
Thank you, Mr. Chair. Thank you, Commissioner, for being here. I don't know if the co-chairs asked you this, but how do you feel? Do you have an opinion on the harm reduction centers that have been opened in New York City and the work that they've done?
They are doing great work. We've actually been in contact with them. We want to learn from other entities that are doing this successfully. I know that they are doing their work with philanthropic funds, so it's not with federal or state dollars. That would be one of our concerns, that whether it's a private nonprofit or state government that is in receipt of federal funds, that there might be some sanction against that as well.
Oh, so that's more of the issue with the funding, that
That's
New
one
York,
of, that's
well,
one of the issues.
New York City doesn't use any state or federal funds.
No.
Okay. All right. Thank you, Commissioner, and I will follow up with more questions later. Thank you, Mr. Chair.
Thank you. Seeing no other questions or comments, we want to thank you for being here this morning.
Thank you.
And with that, we have the next speaker on, that is Ms. Sarah Egan, who is Office of Child Advocate. Welcome. Thank you for being here.
Good morning to the committee. My name is Sarah Egan. I run the state's Office of the Child Advocate. And I'm here to testify on 6913, an act concerning opioids. I did submit written testimony, so I'll just highlight a couple of brief points. We come at this from a family advocacy position, a child advocacy position, and a child fatality review position. As I've shared with some of you throughout the session, the OCA co-chairs the state's child fatality review panel. And we know that in a recent 3-year period, there have been multiple infants and toddlers that have died from fentanyl overdose, which is a new phenomenon that we've never seen before at the Child Fatality Review Panel. And it's one of the tragic consequences of this massive public health challenge that looks like most folks are here to talk about today. I want to be really clear that from our perspective, we are not looking for more families to be separated. when they don't have to be. What we are looking for is how to meaningfully, realistically, robustly, and vigorously address and reduce barriers to adequate care and treatment for caregivers who have the medical problem of opiate use disorder. We know that there are tremendous barriers to treatment in Connecticut, around the country, for parents. We talk, if not weekly, daily, with people doing this work in the community every day with families, and they are telling us that there are big gaps in our service system for caregivers. And I think this bill is an opportunity, before it gets amended and passed out of committee, to specifically include strategies to address some of those barriers to treatment for caregivers. I wanted to highlight a couple of them for you on page 2 of our testimony. Number one, we hear about it. I know we hear about it in every committee. It's the how do we reimburse and pay for medication-assisted treatment and other treatments. If we are underfunding that care, then we are always going to have waiting lists and access problems. Nobody looking for medication-assisted treatment in Norwich or New London should have to go to Manchester for care and treatment. Every day, what I'm really thinking about is, what does a parent do who has 2 or more children and who is ready for and willing to be in treatment? What if they have no transportation? What if they don't have childcare support, right? What if they need basic needs support? How are we going to address that constellation of needs? So looking at reimbursement rates, amending the state Medicaid plan to provide Medicaid reimbursement for community health workers, looking very specifically and having the state agencies report back to this committee on the kinds of barriers that we're talking about, including the need for expanded programming for caregivers with children, same-day access to medication-assisted treatment, gender-specific programming, expanded access to residential programs for pregnant and parenting people with substance use disorder, including residential programs for parents who have more than one child or a child over the age of 7, the development of family-centered medication-assisted treatment, and the co-location of substance use treatment services with prenatal, maternity, and perinatal care. There are other examples in other states of that model. We are always in our office.
Excuse me, Miss Egan, but your time is over. Thank you.
Thank you.
Thank you. I have some questions, and then
Yes.
perhaps that first, thank you so much for your office and the work that you and your entire team does. And about a couple of weeks ago, we had the opportunity to read the entire report that your office had sent, and which was a pretty painful report, because if somebody had asked 5-6 years ago that are we going to see a report where children are impacted by unintentional overdose because of fentanyl lying around in the homes, I would have never believed that, but it's happening and many children have died. And when you look at the entire case, you know that there were opportunities lost. So on the opioid bill, we look forward to identifying ways to not only prevent deaths, but also prevent deaths of our children, not only adults as well. So we value your testimony. If you want to complete the last couple of sentences,
Yeah.
that would be helpful.
Thank you. Just the last couple of things to highlight. We always want transparency and accountability for how these investments are made, right? The work that the Deems Commissioner talked about is great. I do think that there's a role for this committee to be reviewing, I would say at least semi-annually, how these investments, I mean, this is a field that's constantly changing, right? With new progress and new victims. Right? So how are we making progress? What's the most innovative? Where are the gaps? And constantly revisiting not just our successes, but where it's not working and where we need to fill the holes. So I think there's a role for this committee going forward. We would also recommend amending the membership of the state's opioid settlement committee to specifically include members with expertise and lived experience supporting children, including infants and toddlers affected by the opioid crisis.
Please keep your comments and it's for the people in the crowd over here, please. Thank you.
And finally, if the committee believes it would be helpful, the OCA is available to assist with any amended language for a final bill. And that's it. Thank you so much.
Thank you. Seeing no other questions or comments, we thank you so much for being here. We really appreciate you and your office. Thank you.
Thank you.
Next person on our list is Senator Fazio. Senator Fazio, you're on. Welcome.
Thank you, Mr. Chairman. Good morning. Chairs Anwar and McCarthy Vahey, ranking members Summers and Claritas Dietra, and distinguished members of the Public Health Committee. Thank you for the opportunity to testify today in support of HB 6894, an act concerning certificates of need. Certificate of need laws constitute a significant barrier to entry in the medical field when we need to be expanding healthcare access in our state. These laws reduce competition for existing providers and run the risk of a drop in quality of patient services. The FTC said in 2008 that by their very nature, con laws create barriers to entry and expansion to the detriment of healthcare competition and consumers. HHS in 2018 recommended that states eliminate their con laws entirely. While I submitted SB 170 that would explicitly call for rolling back con laws in our state, like 15 other states have done successfully, I think this bill would at least move Connecticut in a positive direction by streamlining the process and reducing costs. The evidence has mounted that states with con laws see an increase in costs, a decrease in access, and a drop in quality of care. A George Mason University study found that states who repealed their con laws saw a 6% decrease in healthcare costs in just 5 years. A second study from George Mason found that these laws reduced the number of hospital beds in states like West Virginia by about 99 beds for every 100,000 people in the population. And a study from the Journal of Risk and Financial Management found that mortality rates from surgery are significantly higher in hospitals in con states. Connecticut's con laws have been restrictive of access and competition. Just last year, our state approved a certificate of need to Hartford Healthcare and Yale New Haven Health to build the first proton therapy center in the state. But soon after that, the state denied an application from Danbury Proton to establish a similar facility about 50 miles away. That's jobs and that's access. Several other healthcare providers in our state have reached out to me unsolicited to vouch for the costliness and difficulty that con laws create. And perhaps the best evidence of how con laws restrict healthcare access is that at the height of the pandemic, when access was most important, the governor waived their con laws in order to ensure that there was adequate access. So while I believe that con laws need to be rolled back sooner, I think this bill is a good start and will put us in the right direction. Thank you, and I would appreciate or be open to any questions.
Thank you so much for your testimony. We appreciate you being here. Seeing no questions or comments, we'll move on to the next person on our list, which is the Executive Director for Office of Health Strategies, Dr. Deirdre Gifford. Dr. Gifford, you're on. Thank you so much for being here this morning.
Good morning, Senator Anwar, Representative McCarthy Vahey, Senator Summers, Representative Claritas Ditria, and distinguished members of the Public Health Committee. I'm Deirdre Gifford, Executive Director of the Office of Health Strategy. Pardon me. And I'm here to offer very brief testimony on House Bill 6894, an act concerning certificates of need. HB 6894 directs the Office of Health Strategy to evaluate the Certificate of Need program and report to the committees of cognizance regarding any proposed changes by January of next year. As you all know and have just heard, CON is a regulatory program that requires certain types of healthcare transactions and providers to obtain approval before making major changes. The program is established in statute since about 1973, and the statute details the type of transactions that require CON approval and the criteria that OHS is to use in evaluating those applications. You may also be aware that last year, Public Act 22-118 established a 16-member task force of this body to study and make recommendations on the CON process. The task force produced its report in January of this year and is available on our website. And last year's task force was also a follow-on to another task force report on Certificate of Need that occurred in 2016 and 2017. It's referenced in our testimony and available online. I highly commend that report to those of you with interest in this topic because it does a very nice job of reviewing the national landscape of the CON programs and gives a significant amount of history about Connecticut's CON existing program. As the new executive director of OHS, I look forward to hearing from stakeholders such as yourselves about the CON process, to reviewing the task force reports, and to engaging with our newly constituted OHS team on the CON program, and that work has already begun. So I'm happy to take any questions. I'd like to acknowledge the team from OHS who's joining me here today, and I thank them for all of their hard work on the CON program over the years.
Thank you so much. I'm just used to calling you commissioner, so I'll just continue to call you
That's fine.
commissioner. Commissioner Gifford, thank you for your testimony. And I just wanted to mention that we had the conversation that you have just taken on this new role as the Executive Director of Office of Health Strategies. And amongst your various priorities, CON and looking at the areas of opportunity is one of your priorities. So we feel that you're internally looking at a number of these policies right now to see what can be improved on. And then you're also looking at long-term ways of addressing this. So in our conversation, we discussed that there's going to be a much more comprehensive bill next year on CON, because we feel that we all need to have a deeper dive into this. And then with your leadership, we are looking at areas of opportunity. Is that fair?
It is, Senator, and thank you. I would note that there are some recommendations from this year's task force that are included in one of the governor's bills. They're relatively minor changes. They're not of the kind of scope that I think is anticipated in this bill, but agree with you and appreciate that with a largely new team at OHS and with me as a new executive director, this is an opportune time to examine the process from soup to nuts and make further recommendations.
Good. Thank you. Seeing no other comments or questions, we thank you so much for being here this morning. Thank
You're
you.
welcome.
And the next person on our list is Irene Haynes. Representative Irene Haynes is here. Welcome, Representative. Thank you for being with us this morning. Your mic is not on.
You'd think I'd know how to do that. Chairman Anwar and Representative McCarthy Vahey, Ranking Member Summers and Claire DeCitra, and the distinguished members of the Public Health Committee. Thank you for allowing me to be here today to submit support. The support I'd like to extend to Senate Bill 1073, also Senate Bill 1210, as well as House Bill 6605. Just a couple of quick comments in regards to the Senate bills. The first one, 1073, the act requiring the administration of epinephrine by first responders. I think that's a great bill. And I think what we just have to make sure we do is make sure that EMRs also have that opportunity to be trained and be able to administer the EpiPen. The EMRs are generally the first people in a lot of situations that end up getting there to the scene. So you want to make sure that that EpiPen is administered right away. The next bill, Senate Bill 1210, is the task force to study issues regarding rural health. And again, I'm here for EMS purposes only. And I think that we have to make sure that when we look at rural health, that we also look at emergency response and include that in our, in our study there, and make sure that we include that. The rural areas of Connecticut are far from hospitals, and we need to address how we're going to deal with emergency response there as well. But I'd like to put my most of my time to House Bill 6605. I'm currently a municipal leader as well in my town, and I've become well versed in the problems with the emergency medical response system in our town as well as other towns, and talking with other municipalities and in the state of Connecticut. It's a very complicated problem. I understand that, but as a municipal leader, public safety is my first priority. That is, when you dial 911, a trained emergency medical provider answers the call, gets to your side, delivers prompt medical attention, and gets you to the hospital for your care. In order to have basic life support services in my town, an ambulance service must get an operator's license, also known as a primary service area designation. That license gives them the exclusive right to perform basic life support for my town. If that organization does a fair job at answering the calls, meaning get to at least 50% of those calls, they keep their operator's license. Unless the municipality deems it unsatisfactory and schedules a hearing with the Office of Emergency Services to discuss the current organization's performance. The Office of Emergency Services has one hearing officer to hear the entire state's situations with their EMS services. That's a problem. So what this bill does, I'm going to summarize, what this bill will do will give the opportunity to the municipalities chief elected official to work with OEMS in putting together emergency service providers within their own town. So it gives them the opportunity to replace if the current service isn't doing a great job. I don't want to be number 9 or number 10 on a list that they only get to 80% of their calls. As the CEO of the town, I can't have that. I want 100% of the calls answered. So when we deal with OEMS and we have to go to a hearing and we can't get in to get that hearing, and meanwhile, we have a problem in our town that we're not getting to our calls, or we have a service that's going out of business, I'm stuck. I'm held hostage as the town for not being able to go out and find a different service that's going to do a better job for the town.
Excuse me, Representative, but your time is up. Thank you.
Any questions?
Thank you so much. So Representative Haynes, thank you so much for your testimony and the work that you're doing. What you're saying is that as a municipal leader who is responsible for the well-being of your citizens, this part of the law is restricting you to be able to get the best service for the community that you represent.
Correct. And I think one of the things too is that if there's people out there that I know they're coming will be opposed to this bill, we're not trying to replace OEMS. We're just trying to work with EMS. We want EMS to help us with our emergency plan. We don't want to not exclude them and say, I'm going to go and just hire my own people. I want to get an emergency services plan in my town with OEMS's help, and then be able to go hire that service that's going to do their best job for my town.
And I'm going to ask this question. If the part of the bills that we are looking at today is also trying to fix many of the inherent challenges the EMS system is facing in our state. If those issues are resolved, perhaps many of your concerns would go away. Is that a fair way to look at it, or not quite?
I believe there's going to be I think what has to happen is people have to realize that emergency medical response is in crisis right now. It's time to call 911 on 911. We don't have enough people. We are not funded properly. And I know this firsthand. I am now working on getting my EMR. I took the class, I passed it in town. Now I have to go take the state tests. I spent $650 to take the class. I'm spending $88 to take the practical test, and I'm taking $140 to take the written test. That's almost $1,000 just to become an EMR. The paramedics and the EMTs spend even more. Nobody pays that but the person who says, I want to help my town. That's a lot of money for the training. So just that alone there could be some help there. The other thing that we need is OEMS and more staff of OEMS to be available. We have a service in town that's affiliated, not in town, I'm sorry, but in the state of Connecticut that I'm aware of, that is affiliated with one of our best hospitals, and they are expanding their service. And all they want to do is buy 10 ambulances, and OEMS has to get to that case to approve buying those ambulances. We have a need, they're trying to fill the need, but because OEMS isn't staffed properly, meaning enough, not that they're not properly, they are properly, but they just have so much work to do because EMS is in crisis. So we need more staffing there. We need more resources. Medicaid. And then another question real quick, the equipment that you need to do this service is very expensive. There's a breathing device called the Lucas device. It costs $20,000. When an EMT goes out to a call for a Medicaid call, they get $238. That's it. So for $238, that's a lot of calls to get that Lucas device paid for. So there's so many different things that we need to address, and that I hope that we can address a lot of these items. But if we can help work with OEMS, with our municipalities, I think we can have a better relationship with OEMS, and we can certainly lighten their load. So I think this bill is really great, and it gets us to the next step.
Thank you so much, Representative Haynes. It's been great to work with you in the process of this bill
Thank
in the
you for your
last
help.
many months. And we look forward to ongoing conversation. And we have Representative DiCaprio, who has a question and comment.
Thank you, Mr. Chair. Representative, could you just elaborate a little bit on the funding issues? Was it the Medicaid reimbursement levels that is the primary concern, or were there other things?
Yes, so Medicaid right now is obviously in the state, and right now the amount of money that the carrier gets, the EMT service gets a reimbursement of $238 through Medicaid for that particular call if they were to take somebody. So in my town, because I'm on the other side of the river and I'm in the middle of the woods, that's like a 2 to 3 hour call if we go to Middlesex Hospital, which is the closest hospital for us. If we have to go to Yale because the person has complications or they have a physician that needs to see them at Yale, that's a 4 or 5 hour call. And meanwhile, they're only going to get $238 for that call to help them. Gas alone is $238. So it's not doing anything for them. Again, the equipment and everything that's necessary, the training, all of that, I mean, all of those things cost an exorbitant amount of money. AEDs, which are all over buildings now, they're upwards of thousands of dollars, $7,000 to $8,000. It's very costly equipment, but we're not getting the reimbursement rate to be able to keep some of these people afloat. And that's part of the reason why you're seeing a lot of EMS services going under, because they don't get the reimbursement rate. Medicaid care is a little bit higher, but not much, $400 or $500. A regular insurance call could be $1,000 or more, but that's private pay and you don't get a lot of that. And our population is aging. So therefore you're gonna have more people on Medicare and Medicaid. So we definitely need to do something, at least with Medicaid in our state, which I think is, this might be in another bill. That's not in this one.
Thank you.
Thank
Thank
for
you
the
so much.
question.
Thank you. Seeing no other comments or questions, we thank you so much for being here. We look forward to ongoing conversation. The next person on our list is Representative Greg Haddad. Welcome, Representative. Yes, please go ahead. And you may want to start and then yield to your.
I will
Yes.
do that exactly. Thank you, Senator Anwar and Representative McCarthy Vahey. I'm Greg Haddad. I represent the 54th District and I'm the chair of the Higher Education Committee. I'm here to testify in support of Senate Bill 1067 concerning adequate and safe healthcare staffing. Our committee has looked at the staffing shortages for nursing as well and come up with some initiatives to help expand the pipeline for nurses, for new nurses. But this is not the crisis that we face with the shortage of nurses and the subsequent impact on patient care won't be resolved by recruiting new nurses alone. We need to address important issues of retention. And as a result, I am here to support this bill. In the interest of time, I'm going to share my time with John Brady, and I'm going to ask him to deliver his testimony about initiatives that we can implement to help retention.
Thank you, Representative. And hello, good morning to chairs, the ranking members and the members of the committee. My name is John Brady. I'm a registered nurse and I'm the vice president of AFT Connecticut. I'm here to support SB 1067. I've submitted written testimony with several studies and citations to them, and I'll try to summarize that. We are in a healthcare crisis and a patient safety crisis. The AFT staffing report says, healthcare workers, unions, and advocates have been warning of a looming staffing shortage for years, long before COVID-19 entered the picture. We must address how we got here if we are going to recruit the next generation of healthcare workers. The fact of the matter is that we do not have a shortage of nurses. We have a shortage of nurses able to continue to work under the present conditions. SB 1067 begins to address the retention side of this crisis. It builds on current state statute, first enacted in 2008, that requires each hospital to have a staffing committee to collaborate in preparing a staffing plan. Our experience shows these committees often have little involvement in the staffing plan currently. This bill will strengthen the staffing committee by allowing nurses a voice on who the members of that committee are. It increases transparency by requiring the hospital to post the staffing plan and make it available to the public. Starting in 2028, it will require staffing plans adhere to patient safety limits accepted as best practice that have been shown in numerous studies to lower mortality and increase nurse retention. It will codify into law a nurse's ethical responsibility. It will allow a registered nurse to object to an assignment that, in their professional judgment, is unsafe and will protect them from retaliation. Finally, it will end the practice of mandatory overtime, which leads to overtired nurses and nurses leaving the profession. This bill will increase the retention in nursing and the safety of our patients. Today, you will hear from many nurses. The bedside nurses will speak in favor of this bill. The administration nurses will speak against it, but they will offer little as an alternative other than the status quo.
Excuse me, Mr. Brady, but your time is up. Thank you.
I look forward to working with the committee to move this bill forward, and I'd be willing to answer any questions either now or offline.
Thank you so much, Representative Haddad and Mr. John Brady. I wanted to ask you, right now, there are two bills that we are looking at. One of them has been, of course, about the physical well-being of the nurses because of the abuse that we have addressed in this committee. But this one is the one that is impacting every single day, every single nurse who's a bedside nurse in the state of Connecticut. Can you speak a little bit about the ratios and why you feel that they are necessary?
Yeah, so the ratios would not start until 2028, which is important. I think it gives time to work into it. I think they're important because right now there are ratios in hospital staffing plans, but the ratios like for a med surg unit might be 1 to 5 to 9. And to be honest, I'm not even sure what 5 to 9 means. Is it you pick a number in between there? The ratio should be 1 to whatever the minimum safe number is based on best practices. And I think we need to hold hospitals accountable to that. Right now, they're not. And right now, frankly, the staffing committees in most hospitals, many of the people on the staffing committees don't even know they're on the staffing committee because they can use any committee and they can just show them the plan once it's written. And that's not how this statute was designed to be. It was designed to be a collaborative process.
Thank you. I just want to share, bedside nurses are one of the most important parts, if not the most important part of healthcare. And that's the part that is suffering the most right now. And we cannot, any of the hospitals or any place cannot get enough bedside nurses anymore. So thank you so much for your testimony. We appreciate you. And thank you, Representative Haddad. And we have Senator Marks who has a question or comment.
Through you, thank you. Mr. Brady, it's good to see you.
Good to see you,
So I know that we're going to hear from some of the management in the hospitals that if we can't find the nurses now, how are we going to find the nurses in 2028? So how would implementing this change in staffing, what do you think it will do to the people that are actually going to be at the bedside?
Good. Thank you, Senator. So there are about 86,000 registered nurses in Connecticut right now. There are about 44,000 who practice in Connecticut. And about 23,000 practice at the bedside. So we have enough nurses. It's a matter of the nurses being burned out and not being willing to work under conditions where they go home crying because they feel like they haven't done a good job taking care of their patients. We're never going to get enough nurses. You never fill that bucket fast enough because it's leaking out by just training more nurses. We can't ramp up fast enough. We need to do the retention side. And if we improve the conditions at the bedside, nurses will stay in the profession. The brand new nurses will stay in the profession. And we're losing nurses under the age of 44, the fastest, which is very scary. Nurses will come back to the profession. And I do think if Connecticut passes this, I think we'll have nurses cross the border from Massachusetts, from Rhode Island and New York to work in Connecticut if we have better working conditions than those states do.
I agree. Thank you.
Thank you. Seeing no other questions. No, you have Representative Wieland who has a question or comment. Representative Wieland.
Thank you, Mr. Chair. And I'll be very brief. You briefly, you mentioned other states and how their working conditions or their policies may influence our choices and impact the effects of the legislation we put forward. The California has a patient ratio legislation on the books already that's been in place for a while now, I believe. So can you speak to how that may be effective and whether or not we should be looking, to replicate that here?
Yeah, thank you. And I referenced that in my written remarks, a study that shows the California, I'm trying to find it now, but the California experience, you hear a lot of both sides. But when you look at the studies, it shows that they've increased nurse retention, they've decreased mortality. There's questions about whether they've saved money. It's very expensive to retrain and recruit a new nurse. There are estimates between 40,000 to 100,000 per nurse. So yes, you may have to hire more nurses and pay more nurses, but you save all of that. So sometimes there's a potential for that too. California has ratios right now. Oregon is on its way to getting it, I think, this session. State of Washington is moving closer to it. And Massachusetts has it for the intensive care unit where they have a 2-to-1 ratio.
Thank you very much for that answer, and thank you, Mr. Chair.
Thank you. Seeing no other questions or comments, we thank you for being with us today.
Thank you.
And for many of our people who want to testify who are online, you will get an invite to be promoted to the panel as well. So you can start to converse with us when it's your time. So please accept that invite. If you do not and you continue to stay as an attendee, you will not be able to testify. So just a reminder, you will get an invite. Please join that and be part of the conversation. The next person on our list is Mr. Tom Goldenberg. Mr. Goldenberg, you're on. Welcome.
Can you hear me okay?
Very well.
Thank you. So dear Honorable Senator Anwar, Honorable Representative McCarthy Vahey, and members of the Public Health Committee, thank you for allowing me to give this testimony. In my written testimony, I've asked for certain provisions to be introduced to our state legislature to ensure that our state's response to the opioid crisis includes community input, is transparent and respectful to underserved communities of color. Specifically, I asked for 4 things. One is that our drug-free zone laws be amended to include methadone clinics and safe use injection sites in terms of proximity to a school. 2, that there be a public hearing mandated by law before safe use injection sites are opened in any municipality. 3, that there be a public hearing mandated by law for any planned methadone clinic before receiving its state license to operate. And 4, there be a public hearing by this committee on the state's response to the opioid crisis in New Haven, specifically at John Daniel School. So, what I would say is that our state needs to reconcile with the, I would call it, uncoordinated response to the opioid crisis. This is very evident in New Haven. We have a major methadone clinic with documented incidents of frequent drug dealing and violence, including a murder, about 330 feet from an elementary and middle school. New Haven also has a methadone treatment organization that purchased property for expansion in an underserved Black residential neighborhood without any notice, any public notice, without any, even the mayor and the city administration did not even informed the local elected official, the alder. So we need to learn what our best practices in dealing with this epidemic and implementing them. I mean, we have laws about proximity to schools in terms of advertising alcohol, advertising cigarettes. We have drug-free laws. And here is a school that is 330 feet away from a clinic where there is just frequent drug dealing, which I have witnessed myself over the last several weeks, and incidents of violence. That is why I'm calling for the drug-free zone to be amended, because we've had a methadone clinic expand without any public notice. I think this is a common sense ask that we have a mandated public hearing before methadone clinics open. I mean, with liquor licenses, there has to be a public notice. And if there's public disturbance caused by it, we act swiftly in taking that away. So I'm asking that we take the same approach to methadone clinics that are really coming in and not giving any notice to these communities. And they're often residential Black communities. So I fundamentally agree that we can have both, that we can have public health and we can have respect for underserved communities. It just requires us to learn from what is working effectively and to incorporate that. The last thing I'll say with the use of safe use sites, I believe that this should also be subject to public notice if a municipality wants to do this. I have heard from multiple sources that the city of New Haven is considering safe use sites, but there has been not a word to the public about these conversations. And so I would say that if a city wants to establish safe use sites, then there should definitely be a public notice and opportunity for a mandated public hearing.
Excuse me, Mr. Goldberg, your time is up. Thank you.
Thank you. Thank you so much for your testimony. Seeing no questions or comments, we thank you for joining us this morning. And we'll move on to the next person on our list, which is Olivia Rinkes. Welcome.
Thank you. And thank you and good morning to the members of the Public Health Committee for the opportunity to testify. I'd like to testify this morning in strong support of SB 1211, an act concerning a pilot program for a mental health crisis center in Connecticut. I'm strongly in favor of any move away to increase mental health resources that are non-carceral in nature. I'm strongly in support of this, but I would like to add a few comments that I would like to see that these resources are made affordable and accessible to all residents, regardless of insurance status or provider. And I would also like to add that these resources need to be, we need to ensure that these resources are non-coercive and consensually based in nature. It's been found that forced hospitalizations are not helpful for the mental health reasons that needs that they're being forced into treatment for, and resources need to be consensually based to ensure that everyone is ready to access the services they need. Thank you very much for the opportunity to testify.
Thank you so much for a very meaningful testimony. We truly appreciate you sharing your thoughts. We will put that into our consideration. Thank you and for your work. Seeing no questions or comments, we will move to the next person on our list, which is Ginny Ray Clay, who is here. Welcome. Thank you for being here in person.
Sorry about that. Good morning. I am Ginny Ray Clay, the Executive Director of the Social Equity Council. Senator Anwar, Representative McCarthy Vahey, Senator Summers, Representative Clarides Dietrich, and members of the Public Health Committee. Thank you for the opportunity to offer testimony regarding House Bill 6915. The Social Equity Council recognizes the need to prevent and reduce youth cannabis use. That's a mouthful. However, we are testifying in opposition of Section 1 of this bill, as it would reduce the amount of cannabis tax revenue earmarked for the Social Equity and Innovation Fund, and thereafter undermine the ability of the Social Equity Council to invest much needed resources and funding in communities that were and still are disproportionately impacted by the war on drugs. Public Act 21-1 established a dedicated fund for social equity and innovation. Per the statute, each year, the amount of sales excise tax dedicated to that fund is to be increased. 60% in fiscal year 23 through 26, 65% in fiscal years 27 and 28, 75% in fiscal year 29 and thereafter. Section 1 of the bill reduces the amount of cannabis sales tax revenue earmarked for the Social Equity and Innovation Fund, and instead allocates it to the Prevention and Recovery Services Fund. The adult use cannabis market just opened in January, and there are already proposals to decrease the amount of resources dedicated to this fund. We are concerned that the state will continue to chip away at this funding, as the bill calls for a 10% reduction in fiscal year 24, 25, 26, a 15% reduction in fiscal year 27, 28, and a 15% reduction in fiscal year 29 and thereafter. The Social Equity Council was created to ensure the adult use cannabis industry is grown equitably, and that revenues generated in this industry are returned directly to the communities hardest hit by the war on drugs. These revenues are desperately needed to support broad-based economic development in DIA communities where there will always be a need, but not enough resources. Community reinvestment of cannabis tax revenue in itself is a great resource to support youth in Connecticut by creating programs that enable access to opportunities such as before and after school programs, mentoring, life skills training, leadership, and empowerment. These would greatly benefit, enrich, and stimulate youth creativity and reestablish programs that have been successful and are no longer funded, including creative arts, dance, summer jobs, park and recreation league programs.
Excuse me, Ms. Clay, but your time is up. Thank you.
Thank you so much for your testimony. We appreciate you and all the work that you're doing. I think my co-chair has a question or comment. Representative McCarthy.
Thank you very much. I just wanted to thank you for being here with us today, and I am grateful for the good and important work that you are doing and will be doing going forward. And I think your testimony was very helpful, and I look forward to talking with you more. I hope that we can meet together. I think these are all very important goals, and we need to figure out the best way to meet them together. So I look forward to talking with you in the future.
It will be
Thank
my
you, Mr.
pleasure.
Chair.
Thank you.
Thank you. Seeing no other questions or comments, we move on to the next person on our list, which is Stephanie McGuire. Stephanie McGuire, welcome. Thank you for being here with us this afternoon now. 3 minutes ago.
Good afternoon, Senator Anwar, Representative McCarthy Vahey, Senator Summers, Representative Claritas Ditria, and distinguished members of the Public Health Committee. My name is Stephanie McGuire. I'm a neonatal advanced practice registered nurse, having practiced for 45 years as a bedside patient caregiver in an intensive care setting. I serve now as chair of the Connecticut Nurses Association Government Relations Committee. Thank you for the opportunity to testify on behalf of the Connecticut Nurses Association with recommendations to immediately strengthen nurse staffing in Connecticut because we simply can't wait. We're heartened that the legislature is hearing the voice of the nursing workforce and working toward meaningful change to retain nurses through Senate Bill 1067, an act concerning adequate and safe healthcare staffing. We ask that the legislature prioritize finding those solutions that can be implemented without delay because the urgency is real. We recommend providing immediate definitive action to redesign and strengthen the present hospital staffing committees while providing transparency and accountability for their actions. Bedside nurses must have a clear leadership role in addition to their equal voices. Not only must nurses' roles be well-defined, but also the reporting responsibilities of the committee. We support posting staffing plans as described in the bill to increase the transparency of a dedicated staffing committee focused only on the crucial task at hand. The sheer number of heartbreaking written testimonies today paint the pictures of nurses' experiences, but I hope it also resonates loudly that many of them submitted anonymously and that they, for some reason, didn't want to share their name. Retaliation protections are foundational to the success of our approach. Nurses need to feel safe sharing their voices and concerns. Another element of our approach is to establish accountability through DPH oversight to collect reliable and timely reporting that would support future evidence-based modifications. Unfortunately, we've experienced that staffing committees are not likely to be successful without heightened oversight, accountability, or penalties for not meeting staffing planned ratios. We propose that all three be included into Senate Bill 1067 and that a future working group review, evaluate, and make recommendations to the Connecticut General Assembly. Our written testimony submitted by the Executive Director of CNA, Kim Sander, is a detailed strategy to make an immediate impact on staffing and to improve the workplace environment. I urge you to review our solutions-oriented approach, and I certainly am happy to take any questions.
Thank you so much for the work that you do, and thank you for the work that the CNA do as well. We hear you. We are here listening to your testimony and then also the concerns that all the bedside nurses have raised as well. So we thank you for that.
We appreciate it.
Senator Marks has a question or comment.
Thank you, Senator White. Hi, thank you for being here. So are you in favor of the actual staffing ratios in 1067?
So we consider at this point that there are other strategies to boost that before we get to 2028 and the ratios. In other words, we want to see those committees strengthen and show those improvements now. And we believe that can happen so that at points along the way, through that reporting system, we can see the documented status of the staffing and overall general satisfaction from the nurses as well. We know that is directly related, right? So consequently, incrementally in 2028, we may be at a point. I couldn't predict that, but I know that there is a big spot for improvement in what we have, and we need to focus on what we can do right now. You also spoke with Mr. Brady about the educational pathway. We need to give those future nurses that chance to develop and be at that point by the time we start talking about those kinds of ratios being implemented. It could be a conversation for the future. I'm not sure it's realistic to do it right now.
So would you want it taken out of this bill? Because right now it is in the bill and it says that it gets enacted in 2028.
I think that we would prefer to see how we progress over time. So you can see that we've had an oversight portion of this built into the plan so that that can be monitored and considered. So could it be a future part? That remains to be seen. So I'm not sure that now is the time to include it with a pinpoint 2028. 5 years is a long time.
Thank you.
Thank you. This is very helpful. I have Senator Gordon who has a question or comment.
Thank you very much, Mr. Chairman. And Mrs. McGuire, it's very nice to see you, and thank you for all the work that you and others and all the nurses do. I appreciate it as a state senator, but also as a doctor working with nurses day in and day out. A question I have is, as you know, there's many parts and aspects of this bill that you're testifying on. What would you consider the most important part of the proposal, one that this committee should really focus on and try to see what we can do to be of help? Thank you, Mr. Chairman.
Well, thank you. I do appreciate that question. And I think really what it reflects on is the interconnectedness of the three main aspects of our approach. One is obviously addressing the staffing issues. The other is the retaliation protection. And lastly, the accountability portion of it is quite large, which does not exist as we know the bill or the present law. So consequently, I appreciate the fact that that interconnectedness will only really support the pieces that we've brought together.
Thank you. Thank you so much for your testimony. Seeing no other questions or comments, we will move on to the next person on our list to testify, which is Kathleen Garrity, who is on Zoom. Welcome.
Thank you, Senator. Thank you to you, Representative McCarthy-Vahey, and the members of the Public Health
Ms.
Committee.
Garrity, we can barely hear you. Can you speak a little louder and come closer to the mic if you don't mind? Can you? Yeah, there you go. Thank you.
Thank you, Senator. Thank you for the time today before the Public Health Committee, to you and your co-chair, Representative McCarthy-Vahey, for allowing me to testify today on Raise Bill 1228. My name is Kathleen Garrity, and I'm the Executive Director of the Connecticut State Dental Association. Given the number of witnesses you have today, I will keep my oral testimony specific to Section 5 of this proposed bill, which enables us to remove significant barriers preventing dental assistants who are facing the challenge of completing competency exams. There are several dentists slated to testify today on this issue, as well as numerous written statements submitted to the record by both dentists and their dental assistants. The lack of DAs is a critical workforce issue facing the oral health care professionals in Connecticut, and ultimately impacts patient care and the time it takes for a patient to get an appointment with their oral health care provider. CSDA members rely heavily on our dental teams to provide integrated, quality, effective, and efficient care for our patients. When all team members are fully utilized, we see more patients and provide more care. Dental assistants perform essential functions in our practices, both the private setting as well as public health. Aside from providing chairside assistance to the dentist, DAs are able to perform infectious disease control, example being sterilization of equipment, and radiation health and safety assessment, taking x-rays. To clarify the role of a DA in the area of x-rays, a DA is charged with setting up the patient for the exam, taking the X-ray, reviewing the image for clarity, and then sets the image for further review by the dentist. Section 5 of the proposed bill requests a study to assess the feasibility of offering a radiographic competency assessment. Based on the urgency of this matter and the critical shortage of our profession is facing, we humbly request that Section 5 be amended to allow us to move forward to establish an assessment for this area. This legislation was contemplated in a previous session by this committee, and language is included in Raise Bill 6147 this session. The establishment of this assessment would allow those DAs who are already on the job to increase their skill set and perform more functions in the practice, moving them forward in their career, improving patient care, and enabling our dental teams to improve functionality. Many practices are small businesses, so this level of professional development builds a stronger team, encourages employers to invest in their staff, and gives employees more job satisfaction and a higher pay grade. 78% of DAs consider this a career, not just a job. The infectious disease assessment that began in Connecticut 3 years ago was crafted, written, and vetted by the UConn School of Dental Medicine. The actual assessment is administered by the CSDA in concert with UConn. UConn faculty has already drafted the assessment exam in the radiographic area. We believe that a successful partnership can continue, and we can have this assessment available as soon as it passes through this committee and is signed by the governor. There is no budget implication for the state of Connecticut. This assessment is critical for the future of rural healthcare in Connecticut. I thank you for your time and leadership on this issue, and I welcome any questions you might have.
Thank you so much. Seeing no questions, or we have a question or comment from Representative McCarthy.
Kathleen, thank you for being here with us today and for the time that you spent with me last weekend to help explain this. And just to make sure that we're all on the same page, essentially you are testifying today to ask for amended language in the workforce bill. And I don't have my numbers off the top of my head here.
This is to amend Raise Bill 1228, and there's specific language that was also included in Raise Bill 6147 that was proffered by Representative Cook.
So thank you. So in 1228, rather than study the issue, you're asking for language that has been discussed by DSS and DPH that will help to address the needs related to the exam for radiologic exams for dental assistants.
Correct. Correct. Yes, that assessment is available to be put in place immediately, and it would remove barriers so that people could, continue in this area and move to complete all their competency exams without going through a national certification process, which is economically and otherwise challenging for most of our DAs.
Thank you. And I just would add that Senator Summers has also been an advocate of this as well. And so I think it's something that we will certainly be taking into consideration as we look at potential S language for this bill. Thank you very much, Mr. Co-Chair.
Thank you.
Thank you. Seeing no other questions or comments, we will move on to the next person on our list.
Mr. Chairman?
Yes, sorry, I didn't see you, Senator Gordon. Thank you.
Oh, thank
Go
you.
ahead.
Sorry. Thank you, Mr. Chairman. I just wanted to ask a quick clarification point. This proposed amendment or proposed language being thought about, this would actually do something meaningful now, especially in rural parts of the state, to help with workforce issues. If I don't know if Kathleen is still on testifying or not, or she's off.
I'm still here. Can you hear me?
Yes. Thank you. It's nice to see you again. I just wanted to clarify and make certain that I heard you correctly, but I think it's a very important point, which is worth supporting. Which is doing something now with what you're proposing to do, especially with changing some of the wording, and which really changes the action, would do something in the short term to be of help, not wait to study something and see what we can do later from a workforce point of view, especially being of help in rural parts of the state where there are a lot of workforce issues, and to really then help patients get the care they need locally when they need the care. Thank you, Mr. Chairman.
Senator Gordon, that's exactly the intent of what we are proposing. These are for people that a lot of them do not have the opportunity to go on for extensive post-secondary schooling. Some of them have GEDs, and a lot of them are single parents, young people who are looking for a career path. And this is not just a sustainable career path, but obviously it's a well-paying job, well-established hours, et cetera. So we thoroughly encourage it. And I do agree with you. It will address a lot of the workforce shortages that we're facing in our rural communities as well.
Well, thank you very much, and it's very worth supporting. Thank you, Mr. Chairman.
Thank you. Seeing no other question or comment online and in person, we will move on to the next person on our list, which is Roseanne Sylvia, who is here, I believe. Welcome. Thank you so much for being here with us this morning and now afternoon. If you can turn the mic on.
Co-chair Senator Anwar, co-chair Representative McCarthy Vahey, and ladies and gentlemen of the committee. My name is Roseanne Sylvia, and I am here to speak in support of Raised Bill 1073. On July 6th, the day after his 57th birthday, my brother Eddie Rubinowitz arrived after work and began trimming the bushes outside my front door. Minutes later, I noticed something was terribly wrong. He came into the house after realizing he was stung by bees, looked into my eyes. We were no more than 6 inches apart. He said, "What if I'm allergic?" I said, "Eddie, you're not allergic. All of us kids," he's one of 4, were stung by bees as children growing up. Within minutes, Eddie became dizzy, and I lowered him to the floor. I called 911 at 5:07 p.m., explaining my brother was stung by bees and is suffering from anaphylactic shock. I had the dispatcher on the speaker, and I was monitoring his breathing. The first responders from the New Britain Fire Department arrived within minutes, as the Station 7 firehouse is less than 1 mile away. I immediately asked where the epi was and how come they were not giving it to him. They did not answer me at first, and they proceeded to tend to him. I asked again, and they stated they did not have an EpiPen. One of the first responders told me the paramedic was on the way with an EpiPen. The minutes seemed like hours as the first responders were performing artificial respiration. The paramedics arrived at 5:19 p.m. according to the run report. Administered epi, initiated CPR, and advanced life support. The paramedics worked on him for over a half hour before transporting him to John Dempsey Hospital. My brother was placed on life support, and the hospital followed a protocol of cooling the body and trying to minimize organ and brain damage. No neurological tests could be run until this was complete. For 6 nights and 5 days, I stayed with my brother, constantly praying along with family and friends. Upon completion of the tests, it was evident that Eddie suffered severe brain damage to his kidneys and liver from the period of low oxygen and low blood flow from anaphylactic shock. On July 11th, we met with the Yukon medical team. We were informed the damage that had been done was irreversible, and he would be dependent on the ventilator. We made the decision to stop life support later that day. Eddie's heart stopped at 6:50 a.m. on July 12th, 2022. Eddie's immediate cause of death is documented as complications of anaphylaxis. I previously served as an EMTI for New Britain Medical Services and have had a lifelong career in healthcare. I know the EMS system is designed in tiers that allow for first responders to arrive ahead of advanced life support to begin care when minutes count. Epinephrine has been required in schools, camps, and other settings since 2014. Since 2019, organizations can work with a physician to train staff to administer epi in the workplace and other settings. Since 2020, ambulances from basic to paramedic level are required to carry epinephrine. So how is it that first responders, as part of the EMS system and surrounded by requirements, availability for epinephrine in so many different settings, do not have the training, nor are they able to administer epinephrine? It never once occurred to me as I was monitoring my brother's vitals, encouraging him to hang on, knowing he needed epinephrine. It never occurred to me that it wouldn't get there fast enough.
Excuse me, Miss Sylvia, but your time is up. Thank you.
If you want to just complete your sentence, please.
We will never know the outcome if the first responders administered epi upon arrival. Not knowing is heartbreaking and haunts me daily. Our mom's heart is broken and will never mend. Eddie's aunts, nieces, sisters, family miss him dearly. Lastly, Eddie worked in Anthology Senior Living in Farmington. He loves his job and the senior citizens that resided there. The residents loved him and were devastated to learn what happened. He made a difference in this world. I hope he can continue to make a difference with his story. We must pursue change so that first responders are able to administer epinephrine. This will make a difference. This will save lives. Passing this law, Eddie's Law, will keep my brother's purpose and legacy alive. Thank you all for your time.
Thank you so much for your testimony. We appreciate you, Ms. Sylvia, for being here and sharing your painful story. And this was one of the reasons we had proposed. And then I think the fact that you have spoken today will help some of my colleagues who were hesitant about it to be more understanding of why this is necessary. I can just share in less than 30 seconds, in one of my towns, somebody had a similar reaction, and the fire department came, did not have epi. Police came, did not have epi. Ambulance came, did not have epi. So 3 first responders came and did not have epinephrine, which is one of the easiest life-saving medicine, which takes care of protecting an individual in less than a second, few seconds. So, and that's why we had to put a bill to make sure that people would not have that challenge going forward. So appreciate you being here and thank you for this. Seeing no other comments or questions, Representative D'Amico has a question or comment.
Just real quick, Mr. Chair, thank you for the opportunity. Ms. Sylvia, thank you very much for coming. You got my attention the other day. I read your email about this. I almost fell out of my chair. So you got my attention. I know you got the chair's attention. So hopefully we'll correct this year. Thank you. And my condolences to you.
Thank you very much.
Thank you. All right, moving on to the next person on our list is Mr. Gregory Allard. Welcome. Thank you so much, Greg, for being here.
Welcome. Thank you for having me. Good afternoon, Senator Anwar, Representative McCarthy Vahey, and distinguished members of the Public Health Committee. My name is Greg Allard, and I am the president of the Association of Connecticut Ambulance Providers and the vice president of American Ambulance in Norwich, Connecticut. I have submitted written testimony, and I'm just going to summarize some of the points made in that today. I did provide testimony on 3 different bills: Senate Bill 1228, Senate Bill 1229, and in opposition of Senate Bill 6605. And that might be actually a House bill. Senate Bill 1228 is asking to study a number of different health care professions, and we were looking simply to see if EMS could be added to that. We need help in finding pathways to attract talented individuals to our workforce. Senate Bill 1229 talks about data and the need for data. We don't disagree with that in any way, shape, or form. We just feel as though the data doesn't necessarily need to have legislation to manipulate it. There is a full-time epidemiologist on staff within the Office of Emergency Medical Services. There are also several regional coordinators that are there, and there could be a few more. There are some openings within that department. However, I don't think that department gets or those jobs don't get the qualified candidates because of funding. They're considered durational and they're not permanent. If they were made permanent, I think we would be able to get much more data out of that department. And I also encourage anybody looking for data to reach out to the epidemiologist and or the data committee of the AMS Advisory Board. Senate Bill 6605 talks to the PSA issue, primary service area, and their responders. And honestly, I do believe that we as an association believe that if the legislation were to go through as written, it would certainly destabilize a system that's already complex. Adding the municipality rule, if you will, over the PSARs could lead to a new PSAR every municipal election, which will create confusion, lead to miscommunication, not to mention the difficulty with EMS organizations such as mine having to prepare for fluctuations within their operations on that type of basis. So we oppose that. Again, I did provide written testimony and be happy to work with the committee and others to answer any questions or to help move along any legislation. So thank you.
Thank you so much for your testimony, Mr. Allard, and thank you for the multiple conversations that we have had to be able to write some of these bills. Seeing no questions or comments, we will move to the next person on our list. Thank you. Next person is Dr. Harvey Carson. Are you here? Okay, we'll come back to Dr. Carson. He has a few people who are going to be with him in the testimony. So we're waiting for an interpreter and also some of the people who are going to join. We have next person on our list is Frederick Dombrowski. Welcome, Mr. Dombrowski. Thank you for being here.
Thank you so much for the opportunity to be here, specifically to talk about potential amendment to SB 1228, an act concerning state healthcare workforce. We're asking that you would include legislation specifically regarding the counseling compact. To Senator Anwar and Representative McCarthy Vahey and the members of the committee, we thank you so much for all the wonderful work that you do, especially eating during your lunch. Thank you so much for the time that you're giving us today. We are greatly appreciated. So my name is Dr. Fred Dombrowski. I am a proud Connecticut resident. I am a department chair and professor with the Clinical Mental Health Counseling Program with the University of Bridgeport. I am a proud member of the Connecticut Counseling Association, and I am the president of the American Mental Health Counselors Association. And specifically, we're here today to talk about the benefits of adding language regarding the counseling compact to Senate Bill 1228. Specifically, the counseling compact is an interstate compact or a contract among member states allowing professional counselors licensed and residing in a compact member state to practice in other compact member states without the need for multiple licenses. Speaking on behalf of the American Mental Health Counseling Association, the board of directors of the American Mental Health Counselors Association fully endorses passage of the counseling compact by state legislators. AMCA advocates for over 130,000 licensed clinical mental health counselors, also known as licensed professional counselors here in Connecticut, in the United States who are licensed to assess, diagnose, and treat mental health disorders. The members of our board emphatically endorse the counseling compact because it provides for greater individual and family access to mental health services offered by licensed counselors, consistently high standards of public health safety in participating states, continuity of care for patients who need continuing mental health counseling when patients or counselors relocate or travel to other states. Also, military personnel and spouses to maintain their licenses to practice when relocating so that their services are readily available to the public. Also, increased mobility for fully licensed clinical mental health counselors and state licensure that is preserved and strengthened in the respective participating states. The counseling compact is supported by our members of the American Mental Health Counselors Association. Currently, there are 19 states which have signed on to it and 19 states which are seeking pending legislation. So our professional organizations, not only the American Mental Health Counseling Association, but also the American Counseling Association and the National Board for Certified Counselors. Also, my students who are going to be working in Connecticut and also the surrounding states to help improve the mental health care which is being provided. And ultimately for the Department of Defense and military families who are asked to move relatively quickly to be able to meet the needs of people across state lines. There's a ton I could talk about, but I would like to turn it over to you if you have any questions.
Thank you so much for your testimony and thank you for being within the timeline as 3 minutes. I just wanted to share, we agree with you. The challenge that we have is that the laws that need to be written for compacts are very complex because you're trying to adapt to some of the other states and then going into so many regulations. The counselors regulations or every professions regulations are in so many different parts of the Connecticut statutes that you have to really go into each and every statute to change the language. And that's logistically a very big challenge. And in the past, just so that you're aware, we did a compact for physicians at one point. We're still working on it about a year later. So it still needs to be fixed. We are doing the physical therapy compact this time, and we are hoping that it'll go through, and we already know that there are challenges with it. So it's a logistical challenge. It's not a policy challenge because there's so many parts to this law. So we appreciate what you're saying. We'll try to see if it's theoretically possible during this session, but it's one of our priorities. But it's the challenge of the law, writing it down at so many different levels and changing the statutes. That's the issue.
Thank you so much. I appreciate your willingness to find ways to meet the mental health needs of the members of the, people living in the state of Connecticut, as well as our professional counselors. We do respect that this is a very three-dimensional process, especially considering all the state laws. Just with that said, I just want to indicate that Connecticut's licensing for professional counselors is in alignment with what is written specifically for the Counseling Compact. So it's a good fit. With that said, though, I can imagine there's a bunch of other things to respond to. Thank you so much.
Thank you. Seeing no other comments or questions from anyone in the committee, we will move on to the next person on our list, which is Shauna Edwards, number 18. Welcome.
Good afternoon, Mr. Chair, Madam Chair, and other members of the committee. Thank you for the opportunity to testify today. I serve as the Chief Nursing Officer here at St. Mary's Hospital in Waterbury, and I am with you today to testify in opposition of Senate Bill 1067, an act concerning adequate and safe healthcare staffing. I've been a nurse for 25 years in an acute hospital setting. In that time, I served in multiple distinct roles, ranging from direct caregiver to Chief Nursing Officer. One common theme that resonates in all my roles is the ability to use my professional judgment as a nurse to make decisions to support the necessary care at the time. Patient care is dynamic and requires a level of flexibility to meet the needs of the patient. Nursing judgment consists of having the awareness of the entire situation and making timely decisions that incorporates the best care for the patient at the time. That being said, we need to support and invest and strengthen the current workforce by developing programs. I have significant concerns that Senate Bill 1067 will mandate rigid staffing ratios at St. Mary's and every other hospital in Connecticut. The reason for my concern is simple. This mandate undermines the professional judgment of nurses and jeopardizes the care St. Mary's can deliver our patients and removes the nurse from the patient care decision-making. Additionally, the consequences that come with the proposal are devastating. There is no question we are facing unprecedented times, nationwide healthcare workforce shortage. St. Mary's Hospital and every other hospital in Connecticut are not exceptions. Our focus should be on increasing the nursing pipeline in Connecticut by introducing innovative strategies and care models that support the nurse at the bedside and provide safe care. St. Mary's Hospital does have a staffing committee, and I support staffing committees in the hospitals. Having responsibility for nursing care at St. Mary's Hospital in Waterbury gives me a unique perspective of what is necessary to care for the patients in my community. I know that decisions regarding patient care should occur at the bedside, not by rigid mandate that undermines the professional judgment of nurses. These decisions must not be achieved through a formula-based ratio. This proposal would increase wait times for all types of health services, including life-saving procedures such as treatments for heart attacks, strokes, chemotherapy infusion, diabetes management, and will force hospitals to send patients to other hospitals to receive care. I ask that you not take away the professional judgment of nurses like me and reject this proposal. Thank you for your consideration of my position.
Thank you, Ms. Edwards, for your testimony. I just wanted to clarify, could you tell me what is the makeup of the committees that you have for staffing at your hospital?
So the staffing committee consists of roles of nursing managers, nursing directors, staff nurses, assistant nurse managers, and that's the makeup of the committee.
And so we are proposing that half of the nurses should be bedside nurses, because when nurses go into administration, they may not necessarily remember the bedside nursing and the challenges associated with it.
Yes, and that's really the intent of the meeting is to have, we are a small hospital, so we typically have 4 nurses on the committee. The committee is only about 8 people. So that's the intent of the committee, and we are looking to even increase that.
And as we look at this, we are talking about the implementation in 5 years. You don't think that in 5 years that the healthcare systems would be ready to be able to address the needs? It does not make sense to me.
Excuse me?
In other words, the implementation of the ratios in the bill is from 5 years from now, recognizing that there's a healthcare workforce challenge that we have. So what you're suggesting is that even for the next 5 years, the hospitals will not be able to ramp up their plans to take care of their most important part of the healthcare system, their nurses?
What I'm saying is that some of our plans are very similar, but I'm saying we don't mandate ratios. I'm saying that we improve our funding for programs to support pipeline into the nursing force. And we support their well-being and all of that. That's what I'm proposing.
Okay, thank you for your testimony. I know some of our colleagues have questions. I just want to make a comment that a nurse, I have yet to come across a nurse who is a bedside nurse at this time who is against this policy. So that's something that I would like to learn more about. With that, I have my colleague, Senator Marks, who will have a question or comment.
Thank you, Chair. So I was going to ask about this staffing committees too. How effective do you feel the staffing committees are?
So the staffing committees are, they are a new venture here at St. Mary's Hospital as far as having the nurses be a part and really understand, give them the opportunity to have a voice. So I think they're an effective way to have a collaborative, interconnected meeting to share issues.
Okay, so when you
I
come
still
out of-
think we have a lot of work to do with them, but I think it's a great vehicle to start.
So when you come out of the staffing committee, do you have the med surg floor should be staffed this certain way? What's usually the outcome after you have a committee meeting?
So we have a few different, we don't, the mandate, I think, is for 2 staffing committee meetings a year. So this talks about not just the staffing ratios, it really talks about the other things as well. Float guidelines, vacation guidelines. So there's a lot that this committee may be a little different than some traditional committees.
Okay, thank you.
You're welcome.
Thank you. Seeing no other comments or questions, we'll move on to the next person on our list. And we are going to go back to number 15, which is Dr. Harvey Corson, who is with a group from the Connecticut Association of the Deaf. And with him is Sandy Nzinga, and the interpreter is Keith Wins. Welcome to the committee. And we would ask our CTN colleagues to keep in mind that we are going to be using a communication with sign language. So when you show people, make sure that you're showing the sign language and the interpreter as well. Thank you. Welcome. We appreciate you all being here. And Kathleen, I will just request that we don't take the 3-minute time for this, please, if you could help us. Thank you.
Thank you, Senator.
Begin now? Okay, hi. Hi, Senator Anwar and Representative McCarthy Vazzi. I appreciate the opportunity to speak before you, the members of the committee here today. I want to tell you that I'm Dr. Harvey Corson, chairperson of Connecticut Association of the Deaf Legislative Committee. I want to say that I commend you all, people of the committee, that you have this bill number 1228 about that you're raising discussion of in this public hearing today. It's important to prepare for the future. We can't assume that everything will continue as it is going on right now. When the future arrives, that's why it's a good thing to plan in advance. It's always good leadership, and it's a good line to be prepared for life. So I want to share with you that we now, with COVID pandemic that we recently experienced, and at the aftermath, we see the impact and the effects that in the healthcare service provision, about the impact is to provide sign language interpreters for the deaf, blind, hard of hearing, and those individuals. Now, the numbers of the availability of interpreters has diminished dramatically because of the very varying factors. For example, the impact, for example, of times where we see an increase in the number of people in need of healthcare services. They're aging out. The interpreters are aging out. People are moving out of the state. And so the numbers of interpreters is diminishing to the point where the supply of skilled people working in the field in healthcare interpreting, that it's the same for a lot of different fields, but especially true for interpreters working with deaf, blind, hard of hearing. So I'd like for you all to consider our committee's proposal and the amendment in the language on page number 1 and line 5. The last words on that sentence, line 5 is proficiency. It's an interest in healthcare. In the healthcare professions, we'd like to propose an amendment, comma, including interpreting through the American Sign Language for deaf, blind, and hard of hearing individuals, as well as for Spanish, for individuals who use Spanish as their major language, period. That will include those interpreters because we need them as well as part of the workforce in healthcare. So I hope you consider that proposal, the language change for this bill. Number 1228. Thank you.
Can I ask a question?
Certainly.
I just wanted to also say that thank you for raising the awareness for us. We should have thought of this, and we are going to make sure that we adjust the bill to address this need. We were not aware that this need was there, and your advocacy is very critical at a very critical time. We will improve this bill for the healthcare workforce, as you have suggested, to make sure that we create a pipeline of interpreters for various communities. And thank you.
Thank you.
Thank you. I had the opportunity to meet with the folks at LifeBridge after we had raised the bill, and they too recognized the importance of assuring that we had an adequate workforce in this area of interpretation, as they are involved as well. And I would like to thank you very much for coming here today to bring this to light for all of us and assure you, as Senator Anwar said, that we will be taking this into consideration as we move forward on this bill.
Thank you. I'm very much aware of the people at LifeBridge and the hard work that they do. I've worked with them for many years. Thank you.
Good. Seeing no other comments or questions? Thank you. We'll move on to the next person on our list. Oh, yes. I think Sandy is next. If Sandy wants to come, welcome. Actually, wins. Keith, wins. You want to press your button? Thank you.
Thank you all in this public hearing. My name is Sandra Nzinga. Right now, I'm the president of the Connecticut Council of Organizations Serving the Deaf. I'm the coordinator of 25 different deaf organizations in this umbrella group for a variety of different things, political issues, recreational issues, a variety of issues. I coordinate all of them with these agencies. I'm here to kind of support what what Dr. Carson just mentioned. And I know it's a big problem in communication access right now in hospitals. Right now, I recognize that Keith Vinci, he came to give testimony, but realized that with the awkward, there was no available interpreters. The legislators tried to find someone, but they couldn't access an interpreter for this meeting here. So we talked, so I couldn't address you today. So if I came here for emergency, or if I went to a hospital for emergency or went for a health issue, you know, the hospitals don't provide us, can't provide the interpreting. And many deaf people suffer because they can't access an interpreter for our medical issues and our medical services. So many people look at us and say, nah, don't worry about it. You don't need an interpreter. You don't need an interpreter. Yeah, but to be honest with you, yeah, right now, I need an interpreter for my communication access. Sign language is my life. I'm a human. I can't speak very well, but I have the same rights and privilege that all of you should have to get medical care. Now, you couldn't get an interpreter for today. You know, most people don't know how to get an interpreter. So this is a big problem. We need to support the workforce. Like I said, we're losing interpreters, maybe roughly 80 interpreters all over the state for all of the needs, the deaf needs of the deaf persons. So not enough. It's a very serious issue. It's important that the Department of Public Health, consider this need for this bill and also oversight. There's no oversight right now for interpreters. You know, if they're not qualified interpreters show up, but a non-qualified person goes to a hospital, oh, well, you know, that's all right. They can sign. How do you screen that? How do you know if they're saying something basic signs or just ABCs, or really are skilled to really interpret a very complex language for medical services? So please consider this investment in the workforce development for services and oversight as well. Thank you for listening to me today. Thank you so much.
Thank you so much. for your testimony. We appreciate you being here and we hear you. We understand you. We respect what you're telling us. Thank you.
Thank you.
Seeing no other questions or comments, we appreciate you being here with us today, Sandra, and also Keith Wins for your the interpretation for us. Thank you.
Thank you.
Okay. Next person on our list is physically here, Victor Vaughn. Oh, actually, sorry, you're going to testify. Sorry about that. Mr. Vaughn, if you want to wait for a second, sorry about that. Mr. Wynn, sorry about that. Please go ahead.
Yeah, I'll be very short. I'm the president of, my name is Keith Vinci. I'm the current president of the Connecticut Registry of Interpreters for the Deaf. I came here at the request of Harvey Corson and Sandra Nzinga to assist in giving some testimony. You know, I'm very sad today because the situation today really relates back to, the situation today really relates back to what happens in the 1970s when we couldn't get interpreters at all. We had to set up an agency under the state that functioned to support the needs of deaf persons, and interpreting was one of those major needs. And over the years, whatever happened, and the support for the agency dwindled, even though the agency functioned pretty much self-sufficiently. Because when I ran the interpreting department, we were gathering enough money to cover the cost for interpreting. Now, for whatever reason, the agency was cut, closed down, interpreting department was lost. And now the state's paying 3 times what they were paying before for interpreting services when they can get them. And as Harvey Corson said, right now, the interpreter availability is minimal. And as you see today, I'm here. You were stuck with me interpreting today instead of getting somebody who's really proficient, does it every day. I'm a retiree. I'm an old guy now. So, you know, you would have been served better with an interpreter if you were able to access them. So in support of what they said, and in support of the need for deaf persons, we really have to reevaluate our approach to deaf services and how we operate in general. So I support their bill, and I support your efforts to even be here, because there have been times when nobody showed up for things, and now you're all here. So I appreciate that. Thank you very much. And I'll cut myself short.
Thank you. And seeing no other comments or questions, we will move on to now Mr. Victor Vaughn. Welcome, sir.
Good afternoon. Chairpersons Anwar, McCarthy, Vahey, Vice Chairs Kushner, Marks, and Parker, and Ranking Members Somers, Clarities, Ditria, and distinguished members of the Public Health Committee. My name is Vic Vaughn. I'm a past president of the APTA of Connecticut. And in addition, I was a representative to the PT Compact Work Group that convened in the fall of 2021. I'm here to testify in support of Senate Bill 9, an act concerning health and wellness for Connecticut residents, and specifically to Section 20, the portion related to the PT Compact. The APTA of Connecticut supports this legislation for 3 specific reasons. First, physical therapy provider staffing in Connecticut was challenging pre-pandemic and has only worsened since the pandemic. Many provider organizations need temporary staffing to fill positions vacated by therapists who are on medical leave, maternity leave, or while waiting to hire a more permanent employee. Currently, filling those positions involves hiring a therapist from a traveling company, which requires that therapist to obtain a Connecticut PT license. That's a process that can take a number of months. In the meantime, the rest of the staff in the organization is overloaded, or patients simply don't get seen. Joining the PT Compact would expedite that process substantially and allow PT practices to obtain the temporary help they need in a much more timely way. Second, the utilization of telehealth rose substantially during the pandemic and has proved that it has a valuable place in the provision of healthcare.
However, using telehealth services means a provider must be licensed in the state where the patient currently resides. Joining the PT Compact would essentially solve this problem, especially for those who live near state lines, or for those of us with older patients who travel to warmer climates in the winter. Third, the ability to obtain compact practice privileges can be considered a licensure benefit for Connecticut PTs. Knowing one could work short-term in another compact state without having to go through the full licensure process is very attractive. As a former faculty member in 2 of the 4 PT schools in Connecticut, students have expressed an interest in starting their career with a traveling PT company. This would allow them to do that while maintaining their Connecticut professional roots. With the exception of Maine, all the other New England states and New York either have joined the compact or currently have legislations introduced to do so. This would facilitate the ease of therapists working across these neighboring state lines. Lastly, as a member of the PT Compact work group, it was clear that following our examination of the pros and cons, we unanimously supported Connecticut's move to join the PT Compact. I would like to make one additional comment, if you can. It came to us on some information that came to us just yesterday from the executive director at the PT Compact, which is not in my written testimony. Apparently, there is a requirement in the compact for FBI background checks, and that language is not currently in the bill, and we cannot move forward. We would not be able to issue or accept compact privileges if we don't have that added, and so I would respectfully ask that that be amended. I will also refer you to testimony submitted by our executive director, Jim Leahy, where he more carefully and fully addresses that issue. So I'd like to therefore, as a representative of the APTA of Connecticut, respectfully ask that this bill be passed out of committee and have us move forward towards joining the PT Compact. And I want to thank the committee for recognizing this as an important issue and being willing to take it up. And I'd also like to thank you for the opportunity to speak before you today, and certainly willing to entertain any questions.
Thank you so much for being here with us. And we also heard this morning about the opportunity to fix the bill a little bit for that part. Actually, the physician compact also needs that we passed, and we're cleaning some of that language too. So we have a little bit of an experience. We'll be able to hopefully fix the PT compact as well. Representative McCarthy Vahey has a question or comment.
Thank you, Mr. Chair, for the indulgence. And I just wanted to say thank you, Vic, to you. And I will tell you that you and those who work with you, including Mr. Leahy, did a great job this year. We heard from many members of this committee and the General Assembly about the importance of this. So we're looking forward to getting that done.
Well, thank you.
Mr.
Thank you
Chair.
to the committee for this. This is important. I know there was a lot of support, but we need to move this forward.
Absolutely. Good. Thank you so much. Seeing no
Thank
other
you.
questions
Have
or
a good day.
comments, we'll move on to the next person on the list, which is Megan Kapler. Welcome, Ms. Kapler.
Hi, thank you. My name is Megan Kapler, and I'm an organizer with the Direct Action Group Prescription Addiction Intervention Now, or PAIN for short. I'm proud to be here today supporting the Overdose Prevention Centers Bill, SB 9. Our organization was founded in 2017 by the artist Nan Golden to target the toxic philanthropy of the billionaire Sackler family, who ignited the opioid overdose epidemic with their blockbuster drug OxyContin. We expose the institutions that have accepted their donations for years, and through direct action, we've successfully pushed many museums and universities to refuse Sackler funding and cut ties with the family. PAIN's protests were recently portrayed in the Academy-nominated documentary, All the Beauty and the Bloodshed, which made its streaming premiere just this past week on HBO. Our group was intimately involved in Purdue Pharma's Chapter 11 bankruptcy proceedings and watched as Connecticut Attorney General William Tong fiercely battled the Sackler family and their privately owned company, Purdue Pharma in court. And while Purdue Pharma was famously a Connecticut-based company, they used a loophole to have the court process take place in our New York judiciary in order to wash its hands of the millions of overdose deaths while paying pennies to their victims. So while I come here from out of state today, I certainly have skin in the game. Members of our group PAIN helped to form the Bankruptcy's Ad Hoc Committee on Accountability in order to fight on behalf of those who no longer can fight. Our advocacy ultimately forced a public confrontation with the Sacklers in Congress during the winter of 2021. And we stirred up enough drama to secure an additional 1.5 billion in settlement funds from the Sacklers themselves. So money that we fought for tooth and nail in court needs to be spent properly, or it may as well be wasted. And that is why today we asked the Senate of Connecticut to use their power and pass SB 9. We must see your state fight as hard toward harm reduction and overdose prevention as you have fought against the Sacklers. We did not fight as a group this hard to see opioid settlement dollars misspent on unproven methods of treatment or worse, law enforcement. And after over 50 years of a war on drugs, we know that arresting and imprisoning people does nothing to change their circumstances. In fact, a person's risk of overdose death increases 40 times after being released from prison. Treatment and services rooted in the principles of harm reduction are called evidence-based because they're proven to work in the field with real people who use drugs. In other words, harm reductionists are our experts here. Last year, the first two overdose prevention centers in America opened in New York City and saved over 700 lives. Imagine how many lives these sites could save in Connecticut. These are sites of wellness, safety, compassion, and health. Please fund these sites with our opioid settlement dollars. That money belongs to the people, and help Connecticut lead the way so that we may show the rest of the country how to end an overdose crisis and pass this bill. Money that was secured due to the loss of life should go directly towards services proven to save lives. Thank you for allowing me to speak today.
Thank you so much for your testimony. Ms. Kapler, I just wanted to thank you for your advocacy to be able to help be part of the movement which was able to get the opioid settlement fund. I just want you to see if you can repeat this because you were part of that fight. The intention was to be able to use those funds to save lives, and the harm reduction centers would be the appropriate place for that investment from your perspective.
Yeah, and our group has also visited overdose prevention centers in Paris, as well as the sites in New York City, and they're not just a place to save lives, but also a place to introduce people to healthcare and treatment. And so they're centers of basically safety, and they provide incredible resources to participants.
And what would you say to the situation where state of Connecticut would say that they cannot use these funds because the federal law prohibits them? How does that change the intention and the use to save the lives?
Right. So now we see the two sites in New York City are not being allowed to use opioid settlement funds, even though the Opioid Settlement Board directly suggested that use of funds to fund them. So they rely on private funding right now, and they are very close to closing their doors, despite saving over 700 lives, reducing needle litter in their community, and making their communities feel much safer. So they are at the risk of closure right now because they don't have access to these funds. And also the opioid settlement funds that we have collected right now as a country are around $54 billion. So you know, the couple of millions proposed to this act is a drop in the hat, actually, in relation to that large amount of money.
And I think we will need some of your advocacy to change the federal laws here, because right now, if the federal government restricts us to be able to save our citizens, then we have a bigger problem. And that's what we are seeing right now for these funds not to be used. Good. Thank you. Seeing no other questions or comments. Oh, we have Representative Palm. Please go ahead.
Thank you, Mr. Chair. I just want to say to you, ma'am, thank you so much for your advocacy. That film was astonishing. I think it should be required watching for everybody on this committee. And for those of you who haven't seen it, I just want to say that for an artist as prominent as Nan Golden to be as candid as she was in that movie was astonishing. And the bravery and creativity that she and all the people at Payne showed was really astonishing. And I would urge my colleagues to watch that film. Thank you.
Thank you so much.
Thank you. And Representative Claritas Dietrich has a question or comment.
Thank you, Mr. Chair. Thank you for your testimony. I and some of my other colleagues had heard that the New York City centers did get financial support from their Department of Public Health?
Yeah, so they basically, these centers, because they're operating as needle exchange, which are, legal in the state of New York City, they get funding for that portion. However, they do have to carve out the specific funding for the overdose prevention center where people can, come and use pre-obtained drugs. That is carved specifically out, and that has to be privately funded. So of course, if the state funding was fully released, they would be able to, for instance, they close at 8 and we know that drug use takes place 24 hours a day. They'd be able to open their doors, keep their doors open and be open on weekends. But yeah, they specifically have to carve out the OPC funding to use private funding.
Okay, thank you for that clarification. Thank you, Mr. Chair.
Thanks.
Thank you. Yeah, Representative Zupkus has a question or comment.
Thank you, Mr. Chair. Good afternoon. I'm not as familiar with these places. And I guess my question is, do they offer drug prevention programs at these places also?
Yeah, so the two sites operating in New York City, when you arrive, there are health professionals on site. Should you arrive and want access to treatment or detox, for instance, you work with that professional who can get on the phone immediately and get you to those forms of treatment.
But if you don't, and you're just going there to have a cleaner, healthier drug use, it's optional. So coming to that place, there's nothing there that tries to get people off of the drugs. They can just come there and use.
Right. Yeah. So there's no coercion happening in the places to get people to stop using drugs. It's ultimately about drug use happens. And for a lot of people entering the sites, they're long-term drug users, and they basically need access to safely using so they can have their drugs tested and have access to clean supplies. And so the purpose is to keep them alive. Yeah.
Thank you. I agree that drug use happens, and it probably, unfortunately, will happen as long as we're on this planet. But I thank you for answering that question. Thank you, Mr. Chair.
Thank you.
Thank you. And I think we will have, I'm looking at the list of people who are going to testify. We anticipate people from On Point are going to be testifying as well this afternoon, if not evening. Seeing no other questions or comments, again, we thank you for being here and thank you for your advocacy. And please go after the federal government to change some laws.
Yes, thank you.
All right, moving on to the next person on the list. I think Tanya Harris is not here. Deirdre Elston, you're on. Ms. Elston, go ahead.
Hi, can you see me?
I cannot see you, but I can hear you.
Okay, great. Okay.
We'd like to see you.
Yeah.
There you go.
Well,
Good.
I do apologize. I am in my car driving my children around today. Representative McCarthy Vahey and all of the rest of the members of the Public Health Committee. I'm of course here to speak in support of State Bill 1067 in regards to adequate staffing. I have been, again, my name is Deirdre Elston. I live in Ridgefield, Connecticut, and I am a critical care nurse at Danbury Hospital, part of New Advanced Health System. You know, I feel that it's a very important, as a nurse with 20 plus years of critical care experience, I can tell you firsthand on many different levels and in many different settings that staffing is one of the key, is quite difficult to deliver safe patient care when the staffing ratios become, inappropriate. I had the good fortune of working in California in 2004 at the University of California, San Francisco Medical Center when they did pass the safe staffing law. And, from firsthand experience, you could see how it affected not only how the nurses approached their job on a daily basis, but and this might seem to some as a secondary effect, but in fact, the amount of satisfaction that a bedside RN has in their position is directly correlated to the level of care that they provide, and the level of consistent care and the engagement in that care and the collaboration with the rest of the healthcare team. It is extremely important for the bedside nurse to be able to have time throughout the course of their day to adequately read a patient's chart and to become very familiarized with their disease process if that nurse hasn't seen this patient before. And what I saw in California was a staff of nurses. I had been working at UCSF from 1998. And when the law came into effect, you saw an entire group of nursing staff who could now take the time to communicate adequately with family, take the time to know the intricacies of their patient's very complicated course and expected outcome and plan of care, and be able to implement that plan of care, be able to appropriately communicate with the rest of the healthcare team, not running from place to place and trying to juggle 20 different tasks.
Excuse me, Miss Elston, but your time is over. Thank you.
Oh, okay. You're welcome. Thank you so much for hearing me.
Thank you so much for your testimony. We appreciate your perspective, and then thank you for sharing a little bit about California, where we hear sometimes concerns that the hospitals were closing and they were going through challenges because of that law, but looks like for the nurses it became better. Is that fair?
It certainly did. And I do just want to underscore the idea that nursing morale is very important for retention. And I do think that would go a long way in reducing hospital costs if we aren't constantly losing nurses.
Agree with you. Thank you.
Thank you.
No other comments or just the questions or comments? I love the sunroof of your car though. I think it's very good.
Yeah, it's a Ford Explorer. You gotta love it. Thank you.
Thank
Take
you.
care.
Next
Bye-bye.
is John D'Angelo from the Bristol Hospital. Welcome. Thank you for being here with us this afternoon.
Thank you. Good morning, Mr. Chair. I'm John. I'm a Marine Corps combat veteran who spent the last decade in emergency care between EMS and nursing. Recently promoted from staff nurse just 2 weeks ago. I've come to speak in opposition of Bill 1067 on mandated patient ratios, a proposal to manage hospitals from the department level. I'll start with the frustrating confluence of factors I leave in coming here. The last 3 years, healthcare has wrestled the rapidly changing environment with the emergence of COVID. But even prior to the pandemic, the care continuum was strained. Our teams treat the entire range of problems across the life cycle, from minor aches and pains to heart attacks and strokes, feverish kids, victims of murder and rape, intoxicated homeless folks seeking shelter, elderly slip and falls, and tragically unexpected diagnoses. We oscillate seamlessly from room to room, one moment grieving with parents beside a dead infant, the next apologizing for wait times, treating patients to the best of our ability with the personnel we project to need. However, our communities often don't see it this way. Care is strangled by the ever-looming threat of liability and the lattice work of red tape surrounding reimbursement, where payment for rendering services we can't refuse is gated by metrics like patient satisfaction. There isn't another service in the world where you can abuse the provider and still demand a fashionable spa feel. During the pandemic, nurse graduates were harder to find, and many veteran nurses left or were forced from the bedside. Post-pandemic, those of us remaining are facing more patients with less and greener staff. All the while, regulatory standards remain virtually unchanged. The very nature of this bill assumes the landscape I described, where various state and federal constraints to supply, coupled with increasing demand, makes for limited service. What will a ratio do except further limit these services? If mandated ratios were to work as advertised, I'm curious why they're not lower still. Why 5 patients when I could care better for 3 or for 1? Perhaps we offer this wisdom to those at Doctors Without Borders, huddled in a Yemeni bomb shelter overrun with cholera-stricken kids to better serve them. California has in fact had ratios instituted for years, helping to furnish studies showing their myopic shortcomings, yet nurses don't speak of a land of milk and honey. In 2022, a nurse in Santa Clara ER shot himself in front of a colleague in their supply closet. The problems in healthcare remain. Today, directly on the heels of COVID, you've come to rescue us by seizing hospital operations from nurses. The same nurses who worked shift after shift during the pandemic are now being told how to staff their unit as if it never occurred to them more nurses might lighten the load. Has it ever occurred to this committee that it may be precisely these patchwork legislative measures that got us here? Where are the proposals to liberate hospitals from their fiscal and compliance burdens, to reduce barriers to entry for nurses to improve our pipelines, to market to the growing number of nurses who left the bedside, to bolster our workforce through incentives as simple as lowering taxes for healthcare heroes? Our state's most creative solution to the problems of modernity manifests in the writing of incomprehensible laws, turning industries into funhouse mirror versions of themselves, and then blaming them for struggling to stand up straight. To do this in healthcare in the wake of the pandemic is nothing short of audacious, but to the credit of my noble profession, despite the outcome here, we will continue on as we always have. I appreciate the opportunity to express what those of us providing care and who oppose this mandate are seeing, and I'm grateful for the time of all those in attendance.
Thank you. Do you mind if you just ask you a couple of questions? Thank you for your testimony.
Sure.
I just want to clarify, you're talking about 1067, right?
Yes, namely the staff ratios.
Okay, okay. And I also heard you're saying that we are not doing much for the nurses. We are actually, a number of the bills and Senate Bill 9 is looking at this, and then other bills are trying to increase the number of nurses in our state. And there was funding that was given to the hospitals for providing help and support to the nursing staff during the pandemic. So looks like it did not get translated down to the nurses. Is that what you're suggesting?
Largely, it's been my experience is that things often don't trickle all the way down, or it's too little too late. Like in the case of this, where we are trying to address staffing concerns where we're already facing a critical shortage of nurses. And despite the 5-year window, we'll continue to face this. We're losing 2 million years of experience a year nationwide with nurses leaving as baby boomers. That's not something that we're going to get better with in the few grants to local hospitals or incentives to nurses. People are running from the bedside.
Okay. We thank you for your service and we thank you for your testimony. Thank you so much.
Thanks.
Next person on our list is Kristen McKay. Welcome. Oh, that's not you. Okay. And Kristen, well, I don't see Kristen McKay online. We have, next is MJ Mukarski. Welcome. Online, yes.
Yes, hello, everyone. Thank you so much, and good afternoon to all members of the committee here today. My name is MJ Mukarski. I'm a resident of Wallingford, Connecticut. I work in the field of public health, and I have a very strong interest in harm reduction. The opinions that I'm sharing with you today are my own, and they do not reflect the position of any organization that I am affiliated with. I am testifying today in support of Senate Bill 9, Sections 4 and 5, Sections 6 and 9, HB 6913, Section 2, and in opposition to HB 6913, Section 4. I support this position for numerous reasons, but primarily because harm reduction centers are essential public health resources and work to not only protect, but also increase the quality of life. Secondly, naloxone or Narcan is a life-saving medication that should be widely available to community members. Narcan saves lives, and restrictions on such interventions delay harm reduction. Thirdly, mobile methadone clinics are valuable additions to healthcare, public health, and harm reduction. Controlling the transport of buprenorphine and methadone not only restrict individualized pathways to recovery, but may further stigmatize people who use drugs. I'd like to take this time to give you a deeper understanding of my position on the subject. Healthcare as it stands today is incredibly complex and can lend itself to the othering of key populations. Harm reduction works to actively dismantle that existing stigma, the othering, and the discrimination placed against individuals who use substances or individuals who are living with a substance use disorder. The opioid crisis in the country and within the borders of Connecticut has resulted in tremendous preventable death in recent years. proving that immediate need for harm reduction and equitable Narcan distribution across the state. The following data were pulled directly from the Centers for Disease Control and Prevention. Across the country, there were 86,000 overdose deaths in the 12 months ending in September of 2020. And 1 year later, in 2021, there were over 106,000 overdose deaths. This loss in human life is entirely preventable through the use of harm reduction and through other public health intervention. Harm reduction in theory and in practice works to reduce the negative consequences associated with drug use, while also supporting a movement for social justice built on a belief in and respect for the rights of people who use substances. Harm reduction is the development of non-judgmental, safe, and equitable resources designed to meet individuals where they're at in life. It is essential that legislative powers protect all individuals that they govern. Harm reduction serves people who use substances according to their personalized needs, as is the case for many other forms of medical care. I am in full support of a system that increases the safety and reduces the harm of behaviors that do and will continue to exist in our community. We are asking for equitable care, we are asking for respect and dignity, and we are asking for access to life-saving resources. Thank you so much for your time today, and I respectfully ask for your support.
Thank you so much for your testimony. Please keep your comments and other things low. It sounds because we don't want that to happen here. We appreciate your testimony. This is very helpful. And I just want to confirm, do you have a written testimony too?
I did submit a written testimony, yes.
Okay, good. Because we wanted to look at, you mentioned about 3 bills and some sections of it. We want to look at some of those sections in more detail. Seeing no comments or questions from my colleagues, we thank you again for being here today and your testimony. And next we go on to Dr. Robert Green, who is here physically. Dr. Green, welcome.
I hope walking from my chair to the seat doesn't cut my 3 minutes. Senator Anwar, co-chairs, and honorable members of the Public Health Committee. I am Robert A. Green, MD, by medical training. I am an American Academy Board certified orthopedic surgeon. I am also the chairperson of the Credentials Committee of St. Francis Hospital and Medical Center, one of 5 hospitals of the Trinity Health of New England Hospital Group. As an aside, I have with me sitting in the audience, Mr. John Baker, who is the director of the Medical Staff Office at St. Francis and Regional Medical Staff Director for Trinity Health of New England. Mr. Baker is a certified credentials expert with almost 20 years of experience in the medical credentialing field. He is also available for any questions you might want to ask. I have been a member of the Credentials Committee of our hospital for 20 years and the chairman for 10 years. I'm with you today to express concern regarding Section 16 of Senate Bill 9, an act concerning health and wellness for Connecticut residents and specifically addressing board certification. I've reviewed Section 16 of the bill. By Joint Commission standards authorized by the Center for Medicare and Medicaid, the majority of initial applicants and their appointment to most hospitals are recent graduates from residency training programs. These applicants are not expected to or required to be board certified. They are required to be board eligible. This requirement implies that they have met the basic requirements of the American College of Graduate Medical Education to practice their specialty, no matter what the specialty. The hospital's credential committee has a responsibility to the hospital board of directors, the medical staff executive committee, and most of all, to the public, the citizens of the state of Connecticut, to hold all healthcare providers to the highest standards, in particular, the physicians who organize and execute their care. While board certification is not required of initial applicants, a credentialed practitioner is required to obtain specialty board certification as defined either by their specialty or by Joint Commission standards, usually within 5 years of completion of training. Commercial insurers accept, quote, board eligibility, unquote, on initial application in order to be a participating practitioner, but will require board certification for continued participation in their plan and to ensure that their members are receiving quality care. The question arises about unintended consequences of legislation that is imposed without full knowledge of the scope of the issue. A physician who has been in practice for a period of time longer than the average 5-year base period, who is recruited by another hospital or desires to work for or at a different hospital, should be expected and required to meet the standard of their specialty board and be certified.
Excuse
would
me,
be
Dr. Green,
unrealistic-
but your time is up. Thank you.
Dr. Green, I was going to ask you if you could complete your testimony.
Thank you. I appreciate that. It would be unrealistic and improper for a hospital to privilege a practitioner who has met the time criteria without requiring board certification. I am also a member of the Medical Examining Board of the state of Connecticut. We have always been expected to put the interests and well-being of the citizens of this state first. I do not see how this legislation will satisfy that standard. In fact, I believe that this change is in direct disregard to the safety of the citizens of Connecticut. Hospitals and insurers have a right and a responsibility to establish standards for practitioner credentialing that is assuring the public of the highest standards. Finally, in establishing credentialing standards, they should be reasonable and not arbitrary in order to restrict the competent practitioners from practicing their profession. Every professional organization sets basic standards for its specialty. For example, attorneys must pass the bar. Dentistry has specific requirements as well as engineers for licensing. In medicine, the first step is the MCAT, a standardized test to assure that candidates meet the requirements necessary to be successful in medical school. In an attempt to not discriminate, standardized testing is the norm. All applicants should be able to meet the minimal requirements of their professional specialty. All Western countries impose educational requirements to practice a profession. Medicine is one of the strictest. Finally, the credentialing requirements are not what needs to be diminished. What needs to change is a consensus for assuring the competency in medical care by practitioners. We are asking that you withdraw Section 16. It is against reasonable standards of care. I'd be happy to entertain any questions.
Thank you so much for your testimony. It's very thorough, very detailed. We appreciate it. And I think you have submitted a written testimony as well.
Yes, I have.
Perfect. This was going to help us improve the bill. We appreciate your coming in and telling us this important information in person.
Thank you. I appreciate your listening.
Thank you. Seeing no other questions or comments, we will move on to the next person on our list is Peter Wolfgang is not here. Mr. Wolfgang? I don't see him right now. We'll move on to Mr. Jeff Shaw. Mr. Shaw?
Good afternoon, Senator Anwar, Representative McCarthy Vahey, Senator Summers, Representative Claire DeStitria, and distinguished members of the committee. My name is Jeff Shaw, Senior Public Policy Advisor at the Alliance. The Alliance is the statewide association representing community nonprofits. Thank you for the opportunity to testify on Senate Bill 1228, and that concerning the state's healthcare workforce. We respectfully ask the committee to amend the legislation and add a provision that will extend the grace period for new graduates of the behavioral health workforce. Connecticut's nonprofits are facing a workforce crisis after 3 years of the COVID-19 pandemic. The workforce shortage for behavioral health providers is getting worse, with most nonprofit providers reporting between 15 and 30% vacancy rates. Staff are leaving for higher paying jobs in private industry and private practice where they can deliver behavioral health services remotely, and school districts are hiring clinical staff away from community-based nonprofit providers. Currently, when a student graduates from an accredited master's degree program with the qualifications to apply for associate licensure, to be a licensed professional counselor associate, LPCA for short, or a licensed marriage and family therapist associate, LMFTA for short, they must wait for their application to be processed by DPH before they can see patients under the supervision of a fully licensed clinician. Usually, these new graduates have just completed an extensive clinical internship. Unfortunately, these new graduates often experience delays of several months while they wait for their applications to be processed. During this period, they are unable to work, which also disrupts the continuity of care with patients they saw during their clinical internship. The associate licensures are relatively new. In 2019, legislation passed that allows new graduates to become licensed upon completing graduate school rather than having to work as an unlicensed practitioner while completing the required hours of counseling experience needed for full licensure. The timing of this licensure change also coincided with the COVID-19 pandemic. As part of the efforts to support the healthcare workforce, a grace period was part of the COVID-19 pandemic Executive Order 7V, which allowed for temporary permits for certain healthcare providers, including LMFTAs and LPCAs. Of course, that executive order has expired. Additionally, there are challenges around staffing. As an example, for mobile crisis services, one provider shared they had to decrease staffing coverage during the peak high volume time for about 8 weeks before the student can be hired as a full-time employee. Simply put, there has been a grace period during the associate licensure. There should have been a grace period during the associate licensure transition period to allow newly qualified staff to continue practicing. A grace period also has the added benefit of giving DPH time to process applications. So please amend Senate Bill 1228 by adding a grace period that authorizes clinical licensure to allow for new graduates to continue to work during the period of time their applications are being processed. Thank you for the opportunity to testify on this proposal.
Thank you, Mr. Shaw. Do you have a written testimony?
Yes, I submitted it.
And then
this
you've
morning.
outlined some of these changes and suggestions?
Yes.
Okay, we appreciate you being here. Thank you for your testimony. Seeing no question or comment. Next person on our list is Leah Ward. Ms. Ward, you're on. Thank you for being here.
Great, thank you so much for hearing me. Dear Senator Anwar and other esteemed members of the Public Health Committee, I'm testifying today in support of SB 1228. My name is Leah Ward, and I'm a nurse practitioner providing palliative and geriatric care to long-term care residents of Connecticut. I support legislation allowing senior nurse practitioners to collaborate with junior nurse practitioner colleagues. While searching for work as a new grad in 2019, I signed a contract for a temporary locum provider at a residential treatment facility for teens. The prior nurse practitioner was forced to leave quickly when it was learned that the psychiatrist on the campus had declined to sign paperwork to be her collaborative. And she was concerned that without this document, she could not earn independent practice. I was hired through an agency to replace her, and a physician through the same agency was hired to be my collaborative. He was difficult to reach, frequently didn't return calls, and at one point could not be reached for 5 weeks until the agency was able to contact him. He had not saved my number and dismissed voicemails and texts as spam, though he was being paid and under contract to collaborate with me. I was realizing that there were many safety concerns in the facility and that I needed more guidance. So I tracked down an addiction medicine nurse practitioner and local professor with 23 years of experience, Linda Kowalczyk, through a neighbor who was her student. I invited her to breakfast, and thankfully she agreed to meet with me. I explained the safety concerns of the facility, which included being forbidden to use the EKG machine for cardiac symptoms caused by drug overdoses and interactions. She quickly provided advice for safe practice, discussed concerning cases, and instructed me to find out where the Narcan was kept, as this had not been reviewed in my 2-day orientation. I discovered that the facility, though treating addictions, had no Narcan on the premises, and that the psychiatric team had forbidden keeping it on campus due to fears of being inspected on the appropriate training for its use by DCF. Eventually, at my urging, they did correct this, but continued to forbid the use of the EKG machine for the same reasons. Linda was very important to my survival in those 7 months. After entering the specialty of palliative care, all interactions with my collaborative physician were brief and lacking the depth of evidence-based practice for the specialty that was needed. For that, I had to reach out to APRN colleagues. While I'm certain that collaborative physician relationships can work if both parties are dedicated, I was not fortunate enough to find that level of dedication. and therefore am more apt to trust my APRN colleagues who take the time to teach, mentor, and express compassion for someone who is learning the profession. One such.
Excuse me, Ms. Ward, but your time is up. Thank you.
Okay, thank you so much. I was just going to say I owe a debt of gratitude to APRN colleagues who are the reason why I am who I am today. And I pray that one day it could be possible for such leaders to be the collaborators for their junior colleagues. Thank you for hearing me.
Thank you so much. Can I ask a couple of questions? This
Of course.
Narcan incident, what year was that?
That happened in 2019, just prior to the pandemic.
And you mentioned you're in Connecticut right now, I presume.
Yes, yes, I am.
But you said that the physician was in Texas.
No, I didn't say that. He was in Massachusetts and hired through the same locum agency that I was working for, just to be my collaborative. But he was not located at the facility. He was supposed to be available by phone, but that was a major problem and a major barrier to safe practice. There are so many barriers for safe practice with obtaining a collaborative physician. It could be difficult and expensive to do so. And my predecessor was pretty much chased out of there by not having somebody available willing to sign to be her collaborative at that time.
So the collaboration was going to be via phone. I'm trying to understand this.
Yes, sir. So a collaborative physician may not always, in all instances, be located at the same place. And so there may only be collaboration by phone. And when I went on to work for home-based palliative care practice, we were all remote and doing house calls. So a lot of times the physician that you would collaborate with was not located close to you at all, or maybe even out of state. It's actually quite common that you're collaborating with somebody who's quite a distance away instead of somebody at the facility. It depends on the type of practice that you're in.
Okay, so that's a problem right there. But this was during the pandemic or pre-pandemic?
It was just pre-pandemic.
Okay.
And I imagine things got worse during the pandemic because everybody was stressed to the max. I think more support would increase the numbers of collaboratives in the state if APRNs could be allowed to do that and decrease current hardships associated with finding a collaborative physician. At times that can be difficult and expensive.
Okay, thank you so much for your testimony. I have Senator Gordon who has a question or a comment.
Yes, thank you very much, Mr. Chairman, and I appreciate your testimony. As a doctor, I've served as a collaborator with many APRNs over the years, and I know a lot of my colleagues do. So I've not really seen it to be as much of a problem as I think it's being made out. One of the questions I have for you, though, is you're asking to see about having an APRN already licensed and established here in Connecticut to serve as a collaborator for a new APRN or an APRN who's coming in from another state. Is that correct? Through you, Mr. Chairman.
That is correct.
And a quick follow-up, wouldn't that be a change of scope of practice? And we have a scope law in place through DPH. And if that's something that's being asked, wouldn't that then have to go through the scope process? Would be my understanding, if I'm correct, through you, Mr. Chairman.
Please go ahead, Ms. Ward.
It could be a change in scope. I am going to encourage any legislation needed to make that happen. It is unofficially happening already. Throughout my career, it's always been APRN colleagues that I reached out to and had detailed and in-depth conversations with. One such colleague changed my life forever when he assigned me as expert reviewer for publishing companies of hospice and palliative literature across the world, and was the reason I am who I am today. And I am praying for the day when such leaders as him could be my official collaborative and not just the unofficial collaborative.
Thank you, Mr. Chairman. Just one final comment is I'm glad you were able to find some colleagues who have helped make a difference in your career. I've been appreciative to have those types of mentors early on in my career. I would just say that if DPH has a scope review process, that we do look to follow it to be consistent as opposed to trying to bypass an established DPH scope process. Thank you, Mr. Chairman.
Thank you, Ms. Ward. Thank you for your testimony. Seeing, Representative Denning has a question or comment.
Thank you, Mr. Chair. Hi, I'm Keith Denning. I don't know if you know my history. I was a nurse anesthetist, and collaboration is important there too. Talk to me about how difficult it is to find a collaborator, or how you even arrange to find a collaborator once you've graduated from a program.
So thankfully, some of that burden was taken off of me because the residential treatment facility was hiring me through an agency, and they could be a little bit of an advocate on my behalf. And so because there was not anybody there willing to be a collaborative physician, they insisted that they hire somebody through the same agency to do that. But unfortunately, he wasn't there. He wasn't very accessible. It became Linda Kowalczyk, a local professor in addiction medicine, APRN, who was really my true collaborative and helped me to survive those 7 months. For a lot of my colleagues, it is very difficult or expensive to find a collaborative when they open their own practices. For me, it might be near impossible because only 0.4% of physicians in the United States today are trained in the specialty of hospice and palliative care. So it would be really hard to find a physician who is qualified to supervise me or even believe in what I do, because medical schools are still teaching that hospice and palliative care are a form of giving up on a patient. So I run into physicians all the time who don't even believe in my specialty.
Thank you. Next question is, you talk about expensive. Do you have to hire your collaborator?
Well, it depends now. If you're in a practice, they will absorb that cost. But if you are opening your own practice, your own business, well, then of course, any expenses would be incurred by the business owner, which is the APRN opening the practice.
And when you collaborated, they were there with you all the time. So easy access. This is normal that collaboration means working together. You feel
no, it depends on the type of practice. This was a small residential treatment facility in a rural community. There was no physician there, and the only way to get an official collaborative was to pull one from an agency out of state. Then when I worked in home-based palliative care, we all work from home offices and then go out in the field and see patients at their houses. So there would be no way to have anybody under the same roof as you. Collaboration in those type of home-based settings is done exclusively remotely over the telephone. So those interactions are going to be very brief and certainly lacking the depth and breadth of evidence-based practice that would truly be necessary to be a safe clinician in all instances.
Thank you for your testimony. I agree with Dr. Gordon that this should be taken under review by the Department of Public Health for a scope of practice review. Thank you.
Senator Gordon, do you have another question, or it's your hand raised from previous questions?
No, I re-raised my hand, Mr. Chairman. If I can just ask a quick follow-up question. I thank you for indulging me. Did I hear the testimony correct that you said that medical schools and training programs for doctors don't, I forget what words you said, do a good job teaching about or believing in palliative and hospice care? I can tell you, I've been a blood and cancer specialist for 30 years. I don't take that lightly, because I can tell you medical students, residents, fellowship, doctors in fellowship, even those who are still practicing for many years, do take it very seriously. It's long been and continues to be a well-known and respected subspecialty of many types of disciplines. So I just want to make certain I heard your testimony correct, because that's not the actual case on the ground for medical care throughout this country, including in Connecticut. Through you, Mr. Chairman, thank you.
That has been documented. Connecticut a few years ago had one of the lowest, actually the lowest hospice utilization in the whole entire nation. And when they tracked it back to how this could possibly happen, considering we had the very first hospice in the nation, they found that it's because we have a lot of the top medical schools in New England, and a lot of them are really not offering much opportunities to the med students for any specific training in hospice and palliative care unless they just happen to seek it out. But there was very little training. And I know that when I went through my nurse practitioner program, there was less than 5 minutes of training in my future specialty of hospice and palliative care. So it's not unusual that there will be very little or nothing in our medical and nursing schools. And so this affects utilization, it affects the practices of future clinicians that go on to graduate and don't understand the specialty very well. And that's extremely well documented.
Thank you, Mr. Chairman. I would disagree. I don't think that's the case. And I think the reality on the ground for medical care in this state, if you look at it in our practicing in it, especially as a doctor, is very, very different. And I respectfully disagree and want that on the record. Thank you.
Thank you. Seeing no other questions or comments, we thank you for being here with us today. We'll go to the next person on our list. And as we move to the next person, I just wanted to make a comment. Through this committee, we have a bill to look at how we can improve palliative care and hospice through our state, and so that no nurse or nurse practitioner would ever say, or a physician would say, that they had 5 minutes of palliative care education in their training. Next is Zina Huxley Riker. Sorry, I tried all options. Zina, no. Moving on to the next person on our list is Susan Jonke. And I don't think, now there are a number of people who are being requested to accept the invitation to become a panelist from attendees. If you would just accept that, you'd be able to testify. Seeing nobody there, we'll ask Mary Seidner. You're on, Ms. Seidner.
Thank you. Senator Anwar, Representative McCarthy Vahey, Senator Summers, Representative Claritas Ditra, and distinguished members of the Public Health Committee. Thank you for the opportunity to submit testimony in enthusiastic support of HB 6915, an act concerning cannabis use prevention efforts related to youth. My name is Mary Seidner, and I'm the Executive Director of the Lyme's Youth Service Bureau, serving Old Lyme and Lyme, and I'm also the Vice President of the Connecticut Youth Services Association. Legal retail marijuana is now here in Connecticut, and the 103 youth service bureaus are feeling the impact. And you may not be aware that this is National Drug Facts Week, a week-long health observance that inspires dialogue about the science of drug use and addiction among youth. My YSB is implementing several prevention activities in our high school and middle school right now, every day this week, as part of Drug Facts Week. And I'd like to share a few facts using our survey data from my community. Here's a fact. The average age of first use of marijuana in my community is 14.1 years old, which is typical for Connecticut. And we are working very hard to keep this number from going even younger. But unfortunately, we know from the legal states that this should be expected. And this is greatly concerning to us because a young person's brain chemistry is changed by high potency THC, sometimes permanently. Here's another fact. By 12th grade, only 20% of students in my community feel that regular marijuana use is harmful. This is a sharp decline in the perception of how harmful marijuana is. And it's supported by comments made by our recent high school youth focus group, where students shared their perceptions that marijuana is, quote, no big deal, and is, quote, almost kind of healthy. Also very concerning is that youth in my community who've used marijuana in the last 30 days report they often use THC to cope. This is something we do not see with alcohol. THC is doing lasting and sometimes irreversible damage to a person's mental health when they start early. The youth service bureaus in Connecticut are providing community-based, boots-on-the-ground prevention work throughout the state in a climate of legalization and an emerging commercial industry. We applaud the Public Health Committee for considering this bill, which will have a positive impact on the youth and families of our state. Specifically, Section 3 of the bill establishes a Connecticut Alcohol and Drug Policy Council, and we urge the future chairpersons of that council to include at least one member of the Connecticut Youth Services Association when considering subcommittees, and we recommend the inclusion of prevention professionals from Connecticut Prevention Network. Thank you.
Thank you. We appreciate your testimony. You have submitted a written testimony as well, I presume, right?
Yes, I have.
Thank you so much. We appreciate your insight. We will look into this. Seeing no questions or comments, I am sorry. We are juggling between in-person testimony and remote one. So for in-person, I think Keisha Johnson, you're here. Ms. Johnson. Keisha? No, okay. Keisha Johnson, going once. Anybody wants to become Keisha Johnson? Sorry. I know there's a long list. This would be one opportunity. Diane Kelly. Welcome, Diane.
Good afternoon. My name is Diane Kelly. I'm the Executive Vice President of Yale New Haven Health System. I have the honor to serve as the Chief Nurse Executive for Yale New Haven Health System, and I'm also a registered nurse of 38 years. On behalf of Yale New Haven Health System, I want to thank you for providing the opportunity to submit a testimony in opposition to SB 1067, otherwise known to me as the nurse-patient ratio. Through Bridgeport, Greenwich, Lawrence and Memorial, Westerly, Yale New Haven hospitals and their affiliated organizations, which include 30,000 employees, of which over 7,000 are registered nurses dedicated to direct patient care. My first point this afternoon is we all agree on the same goal, and that is we all want patients to receive exceptional care. The issue at hand is how do we achieve this goal collectively? We find ourselves facing the question as we all face both a national and statewide healthcare workforce shortage. Mandating rigid staffing ratios will not fix the healthcare shortage. In fact, it could very well undermine some of our progress toward new models of care that will be needed in our future. Ratios will not take into account how we might use a technology in creative ways as the industry continues to explore these opportunities. It also does not take into account many members that are very important to the healthcare team. My second point is nurse-to-patient ratios are indeed a critical framework to how care is organized. You will hear, and I have heard this morning, how hospitals and nurses work together to achieve safe staffing levels. Every hospital in Connecticut, and of course, Yale New Haven Health System, has staffing committees. What I'd like to be very specific about and emphasize is when you hear the word the hospital and the nurses have a committee, what that specifically is referring to is the nurses are working with nurses. They're coming together to ensure safe patient care. This important function is not something that is delegated outside the nursing profession, nor do I believe it should be. Yes, ratios are an important component of how we structure care. I completely agree with that. Yet they cannot be used as a number in isolation from other very core factors. Specifically, I'm referring to is the measure of acuity, which is another way of saying the severity of illness that can change rapidly over one shift, 1 hour. This hands-on assessment process is in the hands and professional judgment of the registered nurse. My third point is the importance of finding solutions. Last year, Yale New Haven Health System entered into partnership with 4 local universities to help more qualified nursing student candidates become enrolled in subsequently employed workforce. Through this partnership, we intend to graduate more than 500 additional nurses over the next 4 years. In closing, I would like to say that we have more in common than we do differences in this topic.
Excuse me, Miss Kelly, but your time is up. Thank you.
Thank
Happy
you.
to
But
take questions.
yeah, but if you can finish your last couple of sentences, we really value your testimony.
You know, it was just say putting state regular mandates will not enhance this communication and this collaboration. I think this is something that we as in healthcare and nurses need to work together.
So, Ms. Kelly, I thank you for being here. I appreciate you being here.
Pleasure.
In the committees that are formed,
Yeah.
It's fair statement to say everybody is a nurse, but it's also fair to say that majority may be nurses who are now in administration and not necessarily the nurses who are bed care.
Actually, no,
Bedside care.
no, that it's actually not a fair statement to say, with all due respect. We are required to make sure that committees are 60% frontline nurses. So we're just by the virtue of how this has been established. So for instance, I'll give you 2 examples. Greenwich Hospital is a smaller organization, and I know they have about 8 bedside nurses, and they have 1 nurse leader to those 8 bedside nurses. They meet every other month, and the leader actually alternates with those 6 to 8 nurses so that they get a different leader to kind of work through problems and make sure they're getting different perspectives. Yale New Haven Hospital, much larger facility. They have a staffing committee of 20 bedside nurses, and they have 2 to 3 leaders that are dedicated to this group, and no more than 2 are meeting with the same group. So it is majority of frontline nurses. We recognize the wisdom of that, and we believe in it. And if I may add that I think you asked the question, what comes out of those committees, and do we listen to that people? You know, Yale New Haven Health System earlier in the year, the bedside nurses asked, we want flexible scheduling. We want more control over our scheduling, and perhaps that would alleviate some of these shortages. And we were able to do that, and things do come out of the committee, and we do listen to that. So I'm glad that I had the opportunity to share that.
And where do you stand on the mandated overtime that the nurses have to endure?
You know, this is an interesting one because at Yale New Haven Health System, we actually don't enact mandatory overtime, but I'm going to answer this question right now as a professional registered nurse. It's almost like you're asking a nurse to be able to leave the unit if there isn't a good replacement. I mean, mandatory overtime is usually, in my experience, if somebody hasn't come in, somebody hasn't relieved you. It's not just to be covering full shifts. I've not used a lot of mandatory, but I would hate to take that one lever away, which none of us want to use, and no one should abuse it. But I do think that you would be saying to an organization and a nurse that's leading the nursing division and saying that it would be okay to leave a patient uncovered. It's against what we are about. It's abandonment, quite honestly. So
I would push back a little bit gently, and I will just say that to you as here's the reality, because if somebody's worked for 12 hours and a nurse who has taken care of, I'll use the ICU. If you have 3 or 4 patients in the ICU, you'd be surprised if that nurse can even take a break to use the restroom. And that's a reality. I'm not joking. I'm an intensivist, so I know this. And so for 12 hours, they're running, not being able to even drink or eat, and then not use the restroom, and then being told that you got to put another 8 hours. It is endangering them, and it's endangering the patients. Actually, I feel rather than the nurse abandoning the patient, the institution is abandoning the nurses. So again,
I would like to just respond to that, if you don't mind, because I share with you that nobody wants to be in that position of asking someone to stay a 12-hour shift, 3 shifts in a row. And I would say that every other solution is tried to. And like I started with that, you know, Yale New Haven Health System, we don't practice mandatory overtime. We do not practice it.
Good.
So I wanted to be clear that we're not in disagreement of what's right, because again, I started with, we have more in common than we don't.
Yeah.
And I think it's important that we stay focused on that. Thank you.
And I would just add a couple of other thoughts.
Sure.
We wanted to put this in for not 2 years, 1 year, 2 years. We put it 5 years from now, because we recognize that there are all your hospitals are looking for nurses, and there are not enough nurses. We are looking at other bills that we have that is going to create more nurses in our system, in our state. And when that happens, we expect our healthcare systems at that time to know that there is a deadline in front. And that's critical. Our patients deserve it, and we want to have a plan of action.
I'm glad I had the opportunity to speak to that because I actually was happy to see that date because I thought it was very mindful of both sides. And I think that's really important. But what concerns me about that is mandatory ratios have unintended consequences. And regardless of their today or tomorrow or 3 years from now, the unintended consequences are that if you're not able to maintain your ratio by 1 or 2 patients that come into the emergency department, those patients really need to go to another facility. Now, that doesn't take into account the acuity of that patient that comes in. You may be caring for patients that are waiting to be discharged. We have sometimes people are waiting 2 or 3 days till we can get them in a safe discharge. They do not require an acute level of care, but we have no choice because everybody deserves a safe discharge. If you have somebody coming in and needing your services and they are very acute and you have a state mandated ratio, the very acute patient needs to go find their care somewhere else. That is a consequence that other people have experienced. That was a problem in California. When you look at the literature and you read the articles on both sides of it, people have to make a different direction of their healthcare and where they're going because the acuity is so critical about the number in front of you is blind to that.
Thank you for your testimony. Appreciate you. I know Senator Marks has a question or comment. Senator Marks.
Hello.
Hi, thank you for being here. I do work for Yale New Haven Hospital. I am a registered nurse. I am a visiting nurse now, and we do have mandatory overtime, just so that you know that once a week, we must take mandatory overtime, and it is used as staffing. It is used to staff because we are so poorly staffed. It's so hard to find nurses. So
I should have been more careful to say acute.
Okay.
I apologize for that.
All right, but a nurse is a nurse.
No,
and
I did VNA work
tired.
too. I'm with you on that.
Yeah, and I hope that I'm still here, where that I'll be able to ask the nurses from Yale whether or not they have mandatory overtime, because I'm guessing they probably do. But so
let me qualify that. I know that answer very specifically and asked to run the reports on it because I had a board member ask me that question, which I was very pleased. So I don't, I just want to say I don't take that question and the answer very lightly. The question was, Diane, are the acute in the hospital, or are they doing mandatory overtime?
So
And I
running
took
the numbers, what does that mean?
So I went to see if we are because we have to document if it's a mandatory overtime situation. And so I didn't just take it by word of mouth. I just said, because I was just asked a few months ago about that case. so.
Okay, and there is past precedents that if you say, no, I'm going home, it's not abandonment. I mean, that is, I will say that's making the nurse.
I'm glad to hear that. Thank you for that clarification.
Yeah, we're not abandoning the patients. We're going home, so we're not abandoning.
Yep.
It doesn't even have to be a family. You just might be exhausted
Yeah.
and you need to go home.
I don't know.
So it's not abandonment. It's saying you can't do anymore and you need to go. And it's management's problem then to find the staffing. But you did say that the staff ratios had unintended consequences.
Yes.
Can you tell me what poor unsafe staffing, what kind of unintended consequences unsafe staffing has?
So mandatory ratios are the unintended consequences, my statement was. If you have a ratio.
No, but I'm asking you, do you feel that unsafe staffing also has unintended
Well,
consequences?
yes, I do.
Yeah, I do too.
Yeah,
And I
no,
sometimes
I
think
do.
those
But I
unintended.
also believe that we all want safe staffing. I don't think that is isolated to our bedside nurses. I've devoted my entire career, the majority of my career was developing a patient safety program. I'm passionate about patient safety. So when people want to talk to me about, am I doing something consciously to be in harm's way of a patient? I'm not. And I do not believe my administrative colleagues are doing that either. I heard one of our staff nurses talk earlier about, we've all gone through collectively really hard times together. And I feel like we're being divided right now. And I feel like this topic is dividing us at a time where us in healthcare cannot be divided. So I do believe in safe staffing and I believe in patient safety care.
I don't think ratios is, requesting ratios is what's dividing us, but, but so if you believe in safety, then we all know if you don't have enough nurses at the bedside, then it's that clients that might fall, or it's that clients that might get the wrong medication, or it's that clients that won't get his blood pressure taken every 4 hours because you're so busy and you can't possibly get in there, whose then vital signs are changing, that you're not there quick enough to see that. And then that nurse is reprimanded. They are disciplined because they did something wrong. So not only is the unsafe staffing bad for the patients, it's also bad for the nurses. And I would just question, and you and I could talk about this for hours, and if you ever want to have me to your office, I'd be happy to sit and
I
speak
would
with
welcome you to do that.
But I haven't been asked yet by anybody at Yale to go talk to them, so I'm still getting my paycheck though.
But you know, I don't think those are that we take this really seriously.
Yeah, and so do I.
You would never hear me as the chief nurse executive have retribution to somebody for speaking their truth. I wouldn't do that. So I can't let those comments pass by me. That's not who I am.
Okay. I hope that when you have the safety committee, I just wonder if those nurses truly feel that they can say what they are
Mr.
really
Chair, I'd like to
thinking
call a
about
point of order.
going on the floor.
You're
Oh.
challenging the testifier. Please, Mr. Chair.
Okay, well, she's not doing it anymore. She's just questioning, completing a question. Go ahead, finish your
Just
question.
curious if they get, do you feel they feel safe about meeting with in the safety committee?
I do. And here's why. We have a non-punitive reporting process, as I hope you know. You can report anonymous, you can report it with your name on it, you can report anything. We really work to have, the hallmark of a safety committee is the culture of safety. And we encourage it. We're trained on it. I actually when I hear people come to my office from the chief nurse executive, I'm very careful to make sure people feel comfortable. And the first question we ask is, was the environment safe? Was it conducive? How do we help you? And I feel like that mission and purpose of safety is getting lost in what we do. It's huge amounts of resources, which this isn't about, is really devoted to a safe and culture of safety.
Thank you.
Thank you.
Thank you.
I just wanted to make a quick little comment and we'll close this part of the conversation. Nobody in healthcare wakes up in the morning to provide less than perfect care.
We agree on that.
And administration and the people doing hands-on work, everybody feels the same way. There is a workforce shortage that is putting a lot of pressure on the existing workforce. We are looking at that. We feel that if we were as a state able to put our resources into it, we'll be able to address this. It'll take a few years to do that. That's why we have a 5-year timeline for that. And we do feel that ultimately, if we do this right, the formula would work out well for the ratios. And that's why we want to give you enough time to be prepared so that it's not happening tomorrow, which was the initial legislation.
Yeah.
So, but we appreciate you coming here. We value everybody who comes here and everything that you speak from your perspective is of value to us. Thank you.
Thank you.
Oh, Representative Kennedy has a question.
Thank you, Mr. Chairman. I just want to thank you, Ms. Kelly, for being here. Did I say that right? For being here today. I appreciate your expertise. And respectfully, Mr. Chairman, if I may, and I do say this of the utmost respect, we have 217 people here to speak. And I really would like the opportunity to hear from all of those individuals and hear from they come from all walks of professionalism. I'd like to have the opportunity to hear from them. So if we could keep our debate to simple questions, maybe 1 or 2, so that we can hear from all these people today. And I do thank you for that.
With your comment. Next is Alex Tenisic. Danbury nurse. Not okay. Moving on to William Moffett. Welcome. Thank you for coming here.
Thank you. Good afternoon, members of the Public Health Committee. My name is William Moffett. I work with the Connecticut Harm Reduction Alliance, although I'm speaking from my own personal experience today. I'm in support of Senate Bill 9, specifically sections 4, 5, and 6. Sections 4 and 5 cover a harm reduction center pilot program. Now, I think a lot of the times in our discussion of our overdose epidemic and of substance use disorders, we get so caught up in statistics and in clinical and policy language that we forget the people who are affected by this. So I want to briefly talk about one of those people, my father, Bill. My father, Bill, died 2 years ago. I had discovered that he and my mother were IV drug users. Now, I was born and raised under the shadow knowing that they were alcoholics, that they had used crack cocaine, but their internalized sense of shame was so strong that for 33 years, they kept it from me. And when I discovered it, I didn't respond with love and compassion. I initially responded with anger, with frustration, with confusion. I kind of, let my mother know I figured things out. She went off, and I tried to force my father into a detox. I don't know if you've ever been around someone who's going through opioid withdrawal. It is painful. What I ended up doing was putting this man through days of misery. I saw sides of him I'd never seen before. And eventually he went to a seizure, got sent to the hospital. Long story short, he died. I should have met him where he was. I should have helped him get clean equipment. When I looked through the house, the amount of used and reused paraphernalia, it was very sad. I wish that he didn't grow up in the shadow of the Nixon drug war. We didn't live in a war where his condition was vilified, was stigmatized, barriers upon barriers, to the point where he couldn't even let his son know the truth of his disease. These centers work. It's not a mystery. Aside from New York and Rhode Island, this year will be the 20th anniversary of the Vancouver Insight Center. I'm sure a lot of you are aware of this center. They've had, I think, over 9 million visits. Not a single person has died. But in this discussion, it's not just about life or death, recovery or use. It's about treating people as people. The thing that we use a lot is that the opposite of addiction is connection. What is the intervention? What did I try to do to my father? I tried to deprive him of connections, to force him to do what I wanted. The same way we as a state do that. We need to, these work, and they don't just provide people with resources to get in recovery. They give them a sense of hope. They give them a sense of meaning. They give them control over their lives. I wish I gave my father control over his. Thank you.
If you guys can please keep your applause in your hearts, and you probably may not hear the applause that is coming from my heart, but I want you to hear it. It's very powerful and very meaningful, and I hope the people in the state of Connecticut in all levels hear what you said. I don't have a question because you should have the last word on this one. Thank you. Thank you. Next is Marilyn Anthony. Welcome. Thank you for being here.
Hi. Well, I gotta tell you, we have been really triggered on the safe staffing comments, so I'm gonna try and stay focused. Good afternoon. My name is Marilyn Anthony, and I've been a registered nurse for 32 years. The past 25 of those years at bedside. I'm also a preceptor of new nurses. I work on a telemetry floor tagged as intermediate ICU. It is a monitored floor, which means my patient's cardiac rhythms are to be continuously watched. Well, imagine the worst has happened. You've had a stroke, chest pain, a possible heart attack, and you are admitted to my floor. You are sick, scared, unclear of what is happening, and very vulnerable. As your nurse, I must immediately invade your personal space, revealing those vulnerabilities while doing my best to maintain your dignity, a task that requires all of my care and attention. Are you on any medications that could cause problems? Are your blood pressure, heart rate, and electrolytes imbalanced? Let's begin testing. Stress tests, MRIs, CAT scans, x-rays. maybe a cardiac catheterization, and blood sugars. I mustn't forget your blood sugars before each meal. And I work 12 hours, so that's 3 times a day just for one patient. Doctors are calling me for stat blood work, EKGs. Has your patient walked today? Are they urinating, having bowel movements, making sure you're measuring all the fluid that's going in is coming out? Families, and don't forget to talk to the families, to update, reassure, try to calm. When you combine these tasks, they become physically, mentally, and emotionally exhausting. Now multiply that by 5. I'm the bridge. I'm the bridge between the doctor and the patient, the family and the doctor, the patient and medication, patient and testing, and most importantly, living and dying. It all goes through me times 5 patients all day long. Time and time again, I am part of the most vulnerable, scary, sad, joyous, intimate moments of my patients' lives. I became a nurse because I wanted to shepherd people through these most difficult times with compassion and care, to give my fellow humans the time and attention they deserve. But this has become simply impossible when we are spread so thin. The more balls we attempt to juggle, the higher the likelihood one will fall. Except in this instance, the balls is someone's life. So now imagine it isn't you who ends up on my unit. It's your parent, your spouse, your child. Would you want me, the bridge to everything, to be spread so thin? Would you want them to be patient number 5? I'm extremely good at my job, but no one can provide the kind of care you would want for your loved one when a patient-nurse ratio gets up to 5-to-1, 6-to-1, even 10-to-1 on night shifts. The time required to complete even the base level becomes mathematically impossible. In closing, I want to make it clear, we're patient advocates to our core. Safe ratios is not about our comfort. It's about the comfort and quality of patient care.
Thank you. I know, applause in your hearts. You can touch your hearts like this. Maybe that's one way to do this. I just wanted to say, you remind us why nursing is such a most beautiful profession and why we all love nurses. So thank you for your testimony. Representative Cook has a comment.
Thank you. Thank you for being here. I know that we have, to Representative Kennedy's conversation, I know that we have hundreds of people that deserve to be heard today. So I want to say this now and early, and I want it to hold fast for the entire rest of the day. You all rock. And we could not do as family members without you when our loved ones are in your care. I have a daughter who's a nurse, and you see the tearing on all sides and fronts. The staffing ratio should be 1-to-1 in my world. I get the complexity of this conversation, but I just thought that it needed to be said now. And so for the entire rest of the day, you can pass it on to everybody else, that I want to make sure that you know that we appreciate everything that you all do, because you are, in fact, the lifeline in every case between our loved ones and us. And I know that it's not easy on you, and you guys have been through the gamut over the last few years. And I know that there was a ceremonial thank you heart sign that was out everywhere, but sometimes you just need to hear it again. So thank you.
Thank you.
Thank you. Representative Zupkis.
Thank you, Mr. Chair. And thank you.
I'm sorry.
I actually live right out in Prospect, but Waterbury Hospital and St. Mary's, I go to both. But I guess my question, and I, ditto to what Representative Cook said. I could never be a nurse, so thank you for doing what you do. But one question, if there's one thing, because the ratios, I get it, and I know that you're overworked and all of those things. But even putting ratios in place and all of these things is not going to have more nurses come.
Actually, they will.
You do. So, well, my question to you is, if there's going to be one thing that we could hire, because there's a shortage everywhere, whether it's nurses or social workers or psychologists, like everywhere.
There's a shortage at bedside. There's not a shortage of nurses. If you could guarantee a safe environment, where a nurse isn't leaving feeling that they have done harm as opposed to help, because they had to abandon their fifth or sixth patient because someone else needed something more intense. You know, your CNO kept saying something about acuity. We're never given that opportunity. I work as a charge nurse on our floors, which it's a charge nurse with a full assignment. How is that even safe? But I digress. I have called multiple times to our illustrious, what they call bed control, the wizard behind the curtain, and mentioned that the acuity on my floor is so intense that we need to slow down the admissions or get more help. And I don't get that call. I don't get that say. You know, so this little, you know, caveat that they keep saying, you know, that, you know, if you do a ratio, you take away the ability to do an acuity. They don't do acuity now. I work 12-hour shifts. I have the staffing office call me at 2:00 in the afternoon and say a nurse has to go home because the census is dropped. Really? We can't just have a good day where everybody gets cared for.
So I guess, and so that's why I'm asking the question, right? So, if there was one thing to bring more nurses in,
A safe,
whether it's
safe environment,
so that not salary, not any of that,
a safe environment,
a safe meaning
that
a
they are-
ratio.
They are guaranteed a ratio. Once upon a time on this unit that I worked at, I'm sorry.
Well, that's okay, because I only have a couple minutes.
Okay.
And so if it is the ratio, if that's what it is, and we still can't get nurses in, or what do we, and you mentioned about not doing more admissions. I don't, and maybe, I'm not a nurse, but I don't know how if somebody came to the hospital through the ER or something, how you could not admit them.
Well,
know?
you
And
know-
then we have the overcrowding of the nursing, I mean, of the ERs.
Right,
So
and I'd like to answer that.
vicious.
So once upon a time, you know, when we were a nonprofit small hospital, I floated for 10 years, so I went to each floor. In our specialty units, they always had a nurse, like an ICU. They had one nurse on each side with a crash bed. So they were one-to-one with what they call a crash bed. So that at any moment, if something happened, you know, they had a bed available. When I worked on telemetry once upon a time, and we were a smaller unit, it was the same thing. You had your beds available. You had your crash beds. They staffed accordingly so that if and when the ER started to ramp up, they had the staff available. Now they cancel staff based on, oh, the ER is quiet. They don't behave as a hospital. They don't behave that any minute something terrible could happen. So if you staffed up so that you were always prepared, and it's like walking into a restaurant and you see 17 open tables, but one waitress, how
Yeah.
great is your service going to be?
Not good, because I see that.
Exactly.
But thank you, Mr. Chair.
Rep. Mara.
Thank you, Mr. Chair. Thank you very much for giving your testimony. I really appreciate it. And I think one of the great things about having these public hearings is we get these very differing views, but I'm trying to understand how I can have someone come in and a nurse come in and talk about staffing committees in which there are frontline nurses on the staffing committee. And then and her saying that that's the best way to move forward. And then you coming in and saying that, I don't, are you saying that the staffing committees don't work? Or like, is it a difference in the hospital? Like it just maybe a staffing committee at one hospital better than a staffing committee at another hospital? What are we dealing with? Why would the hospital not think to make the staff appropriate if that's kind of the number one reason to draw nurses in? I'm trying to understand the conflicting issues here. Thank you.
Because it's their budget. Because I've asked, man, I've been so vocal. I've been on the front page of the newspaper. I've been on frontline PBS, and the only thing that it's generated for me is I get invited to every meeting at this hospital. And I have the CEO's phone number, you know, he wants me to text him every time something goes awry. The bottom line is money. You know, I was just in a meeting last week with him, and the CEO, and I asked him, why do you guys keep sending nurses home? You're not generating any money because you still have to pay her if she decides to, if she decides to take some time, go home, but pay themselves with their vacation time or whatever. And it has to do with this FEEs or whatever, the floor's budget and how much they're spending. So these staff meetings, these committees, they're just placating. It's slapping lipstick on a pig. They don't pay attention to us. Never. And to generate interest after a while, because we all know that's all it is. That's all it is it's to pick, oh, we had to do the committee. Public Health Department said we had to make a committee. So here's your committee. But do they listen? Absolutely not. Absolutely not. It generates right down to money at all times.
Okay, thank you very much. Thank you, Mr. Chair.
Thank you. Seeing no other questions or comments, sorry, I forgot. Representative Clarice Dietra, I'll be in trouble now.
Oh, yes. Thank you, Mr. Chair. Thank you for your testimony today. You're at Waterbury Hospital, you
I
said,
am.
and thank you for what you do. So do you have anywhere in your contract, does it contractually say anything about mandating?
Wow, that is an interesting statement. So our contract, our union contract states that we cannot be mandated, and it refers back to the state law says if there's a pandemic, you can be mandated unless you have a section in your contract that states you can't be mandated. We battled this out for a year and a half over at Waterbury Hospital because they started mandating us, and they backdoored it by they would mandate me 4 hours on my day off so that they did not have to pay me overtime. They wouldn't mandate me 4 hours connected to my 12 hours because then they'd have to pay me double time. So they attempted to mandate me 4 hours on my day off. I stood firm and said no. Some other floors, it depended on their manager. Some nurses stayed firm and said no, and they were given written warnings, verbal warnings, and everything else. We arbitrated it, and it kept getting put off and put off. Everybody's warnings got expunged from their records. And in agreement with our contract negotiations, I'm our union president. In agreement with our contract negotiations, we kept the language in our contract. We decided to let the arbitration pass at this point so that we could get a contract negotiation under our belt before we are bought out. But they mandated us against our contract.
But I thought you said that per your contract, you're only able to be mandated if it was a public health emergency.
Right. So during COVID, that's what they, because it was
right.
Yeah. But the contract states that because your law states unless you can't be mandated if your contract states you have a clause. Our contract had a clause, but the hospital basically said, we don't care what your contract says, you're being mandated, go ahead and grieve it.
Okay, well, hopefully you did.
We did. And like I said, everybody that got warnings got expunged, but it put up quite a hardship on people that got scared and mandated. I'm 62 years old. You cannot scare me any longer.
Thank you for your testimony. Thank you, Mr. Chair.
These are too many moments to have our heart clap. So thank you so much for your testimony. And I have Senator Looney, President of our Senate here. Welcome, Senator Looney. Thank you for being here.
Thank you. Good afternoon, Senator Anwar, Representative McCarthy Vahey, and distinguished members of the Public Health Committee. I'm Martin Looney, State Senator of the 11th District, representing parts of New Haven and Hamden. And I'm here to testify in strong support of Senate Bill 9, an act concerning health and Wellness for Connecticut residents, and would also like to offer comments in support of House Bill 6894, an act concerning certificates of need. Senate Bill 9 is one of our major comprehensive policy bills offered by the Senate Democratic Caucus in this section, and will work to protect access, first of all, to reproductive services, as well as to protect anyone who seeks services at facilities that provide reproductive health. Will allow our residents to feel safe while accessing their basic rights. According to the Connecticut Department of Public Health, drug overdose is the leading cause of accidental death in Connecticut, and the legislation before you in Senate Bill 9 creates a pilot program for 3 harm reduction centers in municipalities in this state. And this would be where a person may safely consume a controlled substance under the observation of licensed healthcare providers. We need to be more creative and more assertive in taking actions to deal with this chronic problem that gets worse every year. We would become a leader in this, along with Rhode Island and New York, who have created centers like these. Connecticut now sees over 1,000 overdose deaths per year, and the legislation establishes an opioid antagonist bulk purchase fund for eligible entities, which will allow much more free access to Narcan and will also save lives. We are also concerned about our healthcare workforce, and to develop our workforce, Senate Bill 9 establishes a healthcare advisory, career advisory council, which will study how best to promote healthcare professions as a career option to students in middle and high school. And the bill also creates a working group to develop recommendations for expanding the nursing workforce in the state. With Senate Bill 9, also nurses' aid evaluations will be offered in both English and Spanish, creating new opportunities for a large population of state residents. Senate Bill 9 will also create a career pathways program for personal care attendants to increase employment retention and recruitment of personal care attendants. And the legislation will also expand the healthcare provider loan reimbursement program to provide at least 10% of grants to healthcare providers who are employed in full-time and rural communities of the state, help to motivate healthcare workers to serve in our underserved and rural communities. Senate Bill 9 has a number of major policy provisions. And briefly, House Bill 6894 would require the Executive Director of the Office of Healthcare Strategy to evaluate the certificate of need process. In 2021, we had proposed Senate Bill 238, which would have lowered the threshold on medical practice acquisitions from 8 physicians to 2 to be subject to a certificate of need process. And that I think this needs to be evaluated in terms of how we can best look at need and the financial pressures that go into acquisition of physician practices. And that legislation would also have eliminated the current presumption in favor of these transactions taking place that exists when the applications are related to group practices.
Excuse me, Senator Looney, but your time is up. Thank you.
At the very least, the General Assembly should eliminate the presumption and make sure that there is a neutral look at these issues. Thank you very much.
Thank you so much, Senator Looney, for your testimony. Senator Looney, earlier, I know you were in another meeting. There was a question raised that because of the federal laws, the funding, even the opioid settlement fund, is something that cannot be used for the purpose of harm reduction centers. So I think we'll have to maybe offline brainstorm how we can work on some of this, because it's almost creating a barrier and we are allowing our citizens to die and not get the safety net that we're trying to create.
Yes, I think that's right, Mr. Chairman. If one source is not available, we should examine whether or not another unencumbered funding source might be available for that purpose.
Good. Thank you. Thank you so much. Representative Claritas Dietrich has a question or comment.
Thank you, Mr. Chair. Thank you, Senator, for being here today. Do you have any thoughts or ideas with this 3-site pilot program, the cost it would incur?
No, I don't at this point. It's a brand new proposal. I think we need to examine that in detail and try to figure out exactly what the cost would be. I assume it would be would have to be located in space that the entities would be renting from. Could potentially even be a mobile facility. So I think those are all things that need to be investigated, and clearly with a view to making them cost as little as possible.
Okay, Thank you very much for your answer. It was nice seeing you today.
Nice seeing you.
Thank you, Mr. Chair.
Thank you. Seeing no other question or comment, thank you, Senator Looney, for being here. Thank you for your leadership.
Well, thank you very much, Mr. Chair. And again, I wanted to commend this committee for all of the very important work that it does in every session. And some of the most important legislation that we deal with comes from the Public Health Committee. So commend your efforts. Thank you so much.
Thank you. Next person on our list is Brenda Pitt. Who should be here? Ms. Pitt. Brenda Pitt, going once. Twice. All right, next one on the list is Brian Merlin, number 40. Welcome.
Hi, thank you so much for having me here today, honorable members of the committee. I just want to say thank you to the harm reductionists. Fighting alongside you has been the honor of my life. We've tried incredibly hard on these issues, as I'm sure most of you are aware. I wanted to bring up that we don't know if these overdose prevention sites, I'm here in support of SB 9, are legal or illegal in the sense that Safe House in Pennsylvania currently has a DOJ lawsuit, but in New York, they opened with support of 4 of 5 of the U.S. attorney offices. I and Recovery Advocacy Project have attempted contacting the Connecticut U.S. Attorney Office. I was told that only New Haven would weigh in, that other offices of theirs would not make decisions as New York has. I don't know the appropriate means to avoid a Hatch Act violation to talk to the prosecutors. I have talked at great lengths with our congressional delegation here in Connecticut and tried to express my concerns about the conflicting laws on this matter. You know, it's incredibly important to get these centers funded and existing here somehow because it'll greatly reduce loss of life, as I'm sure most of you are aware. New York is up to 819 revivals now. I just wanted to put up a, the number of successes and 0 losses. And so I think, you know, these services, they're not always popular. And I'm saying that broadly with, medically assisted treatment, needle exchange, but we're trying to triage the situation. We're losing a tremendous amount of lives because of what Purdue Pharma and other bad actors have done. And, we need to try to cut through any red tape we can. We've tried literally everything on every level of government. We're pushing for over-the-counter Narcan, as I'm sure some of you are aware. And, if we can't spend the settlement money that many of us have fought very hard for against these firms on overdose prevention sites or centers, perhaps we can set up Narcan temperature control vending machines in every community. I know that is something that is legal, and until we have overdose prevention centers approved, that is something that can greatly reduce loss of life. I saw recently in an article that not every school has Narcan and naloxone here in Connecticut. I think it's incredibly important that we make sure we have enough for a mass overdose situation in each school, particularly after losing a young youth here in Connecticut, and it is negligent to not do so. This isn't our parents' cocaine anymore. Fentanyl is being laced into everything for the most part in terms of, powders, pills and such. And we need to try to save lives. I know that some of these services make people uncomfortable in terms of what works at saving lives. But unfortunately, at the end of the day, we're just trying to reduce losses, and these services, they're not enabling use, they're enabling people to continue living, and they reduce virus spread. People are going to be building relationships with credible providers like Mark Jenkins, John Hamilton, and many of their hardworking staff.
Excuse me, Mr. Merlin, but your time is up. Thank you.
Just wanted to make a comment. Thank you for speaking out. Thank you for your leadership. We truly appreciate you being here, and we hear what you're saying.
Thank you.
Thank you. And seeing no comments or questions, we have next person is Liz Evans. Welcome, Ms. Evans.
Thank you very much for having me, and Senator and Health Committee. It's an honor to be here, and thank you for giving us the chance to testify about this very important issue. I'm here to talk about SB 9, Section 4.5. I also just want to make sure I thank you for your tireless work, because I know a lot of people in public life don't get thanked as much as they should. And I know it's not always. Anyway, I support this bill because I understand personally from years of firsthand experience, the devastation, cost, pain, and trauma that can be averted by overdose prevention centers. As part of a necessary continuum, they can address Connecticut's overdose crisis. I started my career as a nurse, and I worked in an emergency department where I witnessed the revolving door of those living with substance use and mental illness. I left the hospital to go and work in a community in the heart of a low-income neighborhood where I thought I could help, where I thought I had some answers to some problems, but I was very naive and young. And during this time, I had hundreds of experiences that caused me to relearn what helping looked like. I remember one lovely woman, a mother, crumpling to the ground as I had to tell her that her son had died. I was surrounded by a wave of death, and we had to rethink what was possible, how to save the lives that we were surrounded by every day in the community, struggling with pain, trauma, and suffering. That was what defined us. I learned a lot. I met a lot of beautiful human beings, and this led me to support the vision for and eventually to open and to operate North America's first government-funded overdose prevention site in 2003. Later, I assisted other communities around the world, including in New York, where people struggling with SUD can come indoors, off the streets, out of businesses, and where they can use drugs under supervision. Overdose prevention centers are evidence-based, pragmatic, and cost-effective. North America's site has now seen over 4.5 million injections with no deaths. The site was subject to voluminous studies. An internal evaluation alone that cost over $3 million resulted in hundreds of peer-reviewed articles. They showed that there were cost savings of over $14 million in the first 10 years in healthcare spending. We saw 35% reduction in overdose deaths in the community. We had a 45% decrease in public disorder, and people using the site were 33% more likely to go into detox. People who use these sites access primary care, they get wound care, they establish relationships, and they're given hope. And most importantly, no one has ever died in any of these sites, and there's over 200 like them around the world. I'm aware of 2 longitudinal studies that show the average length of time injection drug users remain addicted is around 12 to 14 years, and we have a choice about how we choose to deal with people during this time. At the moment, only about 10% of people living with injection drug use, SUD, are in treatment. For the 90% that are not, harm reduction and overdose prevention centers offer life-saving spaces that are non-judgmental, where they offer therapeutic relationships, and they're aimed at meeting people where they're at. But most importantly for me, people injecting in a safe space, we have fewer mothers who don't need to be told the life-changing news that their son or daughter is dead.
Excuse me, Miss Evans, but your time is up. Thank you.
Thank you, Ms. Evans, or Liz, for finishing your testimony in a timely fashion and for being here. I know you. In the harm reduction world, you're a rock star. You've been the keynote speaker at harm reduction conferences, and people all over the world know your work and respect you, because in Vancouver is the first center in North America that you were a part of that has saved thousands of lives, and you have been part of the initiating On Point as well. You've been instrumental in that too. So thank you for the hard work that you have done, and you're very humble. You didn't even tell people that, and you've come from New York just to talk to us over here in Connecticut because you're hoping we'll save some lives of people if we can save. I want to talk about funding, and that's part of the issue. I think for the most part, it's a common sense approach, and many of the people will overcome that when they look at the data that it's necessary. I want us to be able to figure out how do we address the funding component and a little bit about On Point and the work that you've done.
Sure.
And I just want to mention that we recently met you with Representative Mara, and I had actually gone to New York to visit the On Point Center together and learn, and then we got a chance to spend time with you too.
Yeah. One thing I would say, and this is, I believe that state funding is necessary to operate these sites. I think it's contemplated in the legislation that these are health centers. I think the crack house statute is very specifically about crack houses. And what I think sometimes is confused is overdose prevention centers are healthcare. They're part of a healthcare system. They're an entry point into treatment. And in many cases, they are treatment.
because for the folks that come in and use there, they have no other entry point into care, and they're not coming into contact with healthcare professionals anywhere else. They are misconstrued as crack houses under that legislation, and so I believe that it's contemplated and possible. And if the political will is there for them to operate under the existing laws, the reason New York hasn't had problems is because it's seen and supported by the state as a healthcare facility. I also think that funding similarly should follow. But of course, there's, ways of getting funding through city and state for aspects of the programming that go on in these centers, and private philanthropic dollars can also contribute. So I think you can go for a combination of funding.
This morning, I made a statement earlier and I said, how many more? And then I think in New York, when we reached 100,000 mark, was that everybody said, how many more? And then the political will, the financial will, and all the wills came together to be able to say we need to do this. Sooner or later, we'll all be saying that we need to do this. Some of the people's perspective is its time is already here. So you think that the federal agencies and others also recognize that by the time the laws follow, too many people would have died.
Exactly. I mean, that's what happened in New York. We had a visit from the DEA. At one point, we had coverage on CNN by Sanjay Gupta of the overdose prevention stuff that was going on at our facility. DEA came down the next day, 3 investigators, and they said, good job. And they left. They said it was like a health facility. I think if political will is there, if support is there, if the public understand where they fit into a necessary continuum of services to save lives, there's no enforcement action. There's no desire for enforcement because it's understood as part of a continuum. It's not a crack house.
And that's a struggle. This morning, we heard from the commissioner who from Demas, they're saying that they support the idea, they recognize it, but they feel that they can't cross that bridge because of the laws. But I think there are legal ways to be able to do this without breaking a federal law.
In Canada, we were very lucky with the first one. We had all 3 parties. We had, huge support across party lines. And while the first one existed under an exemption from the criminal laws, the federal drug laws as a study, ultimately many more opened before any laws changed. They became part of parcel of a healthcare delivery system that was understood as essential. No laws changed for them to operate. No laws changed for New York to operate. New York's open. People aren't getting arrested. It's a functioning and important model.
But my colleagues have questions as well. I'll go to Representative Claritas Ditra and then Representative Mara.
Thank you, Mr. Chair. Thank you for your testimony today. I think it's important to hear from people that understand what's going on in these centers to inform us. Do any of these centers take insurance? Do they charge for anything?
No, they're funded through grants.
100%. Okay. Thank you, Mr. Chair.
Representative Mara.
Thank you, Mr. Chair. Thank you so much for coming here. It's nice to see you. Thank you for meeting with us the other day. My question is, in your quick testimony, I know you had to run through it, but can you please explain the services beyond injection services, like the wraparound care,
Yes.
please?
So first of all, I would clarify that supervised consumption sites, of which there are many, many around the world, over 200, look different everywhere. They adapt to the local environment that they're in. It's a service that you offer to a population of people that need to come in off the street. In the context of a harm reduction center that's being contemplated in this bill, my understanding is it's more of a wraparound site, similar to what's happening in New York now, places where you can embed a lot more than just a place where people can bring in drugs and use them in a supervised setting. That, of course, is fundamental. But on top of that, our access to things like showers, things like medical care, things like wound care, referrals, access into treatment and services. And we see huge uptake in those linkages as a result of attracting an extremely often highly marginalized population of people that are currently excluded, and as a result of stigma, dying because they are using in unsafe environments. They're
you know, in the back alleys, they're on the doorsteps of businesses, they're overdosing in washrooms and McDonald's. And these are public disorder issues that are not managed well in a system that doesn't have alternatives. And the alternatives are these sorts of centers that are welcoming and is set up to provide wraparound services for those individuals, very targeted, very focused on not judging, meeting people where they're at and connecting them like a link into whatever they're able to get. And, you know, that kind of welcome is extremely hopeful. And one of the things that I think people who don't understand the incredible power and impact that that has on a person's life when they are met that way with that kind of non-judgmental approach is how it shifts their sense of hope for their life. They think if somebody cares enough about me right now in this moment, when I'm struggling so much to bring me in and care for me, then maybe I should care more for myself. So they're very hopeful places.
Thank you. And can I just follow up really quick? When you talk about wraparound care, can you just focus just a little bit on the primary care and the health care that you do? Because I know there was a mention when we were there, if someone came in and there was an acute medical situation, how that would work. Like if
So
there was a
I think-
wound or
Say that again?
like with a wound, or if they have diabetes.
Oh yeah,
or-
lots of wound care. I mean, a lot of people end up, as Senator Anwar is well aware, into the emergency department and into ICU with deep tissue infections. And certainly as somebody who worked as a nurse, I was horrifically aware of how many people die from drug-related, infections that are related to injection. So we know one of the biggest cost savings to the healthcare system of a supervised injection facility is actually those infection-related diseases, as well as obviously transmission of HIV and Hep C.
Thank you so much, Mr. Chair.
Thank you so much. Would you be able to speak a little bit about the financial benefits the city of New York is benefiting from? I heard that they've saved $45 million from a number of different aspects of the EMS, the emergency room services, the reduction in the deaths, and also every time there was a opioid related death, the entire team had to go, and they've not had to go for the past year or so, and that's saved them millions.
I don't have the numbers, sorry,
Okay.
but it makes complete sense. I mean, that's the other thing. The first study that came out of Insight in Canada was that the injection site reached the population that it was targeted, it was set up to reach. That was the very first paper that was ever published. In other words, the group of people that are highest end system users for 911 emergency drug-related calls will go into a center like this because they're welcome and it's designed for them. And there is no other sector of the healthcare system designed for this population other than the emergency department, which is the most expensive form of treatment available.
I had one more question. I'll have Representative Dauphiny have a question after that. And so Representative Claritas Ditra. No, okay. The question I wanted to ask you was that there is, I forgot what the question was, but I'll have Representative Dauphiny go and no, I remember now. Has the drug activity in the neighborhood increased? That's a common question that people have and across the world, does that cause increased activity? I know the answer, but I want you to be able to.
No, the evidence shows very clearly it does not increase or affect in any way drug-related activity in the areas around these sites. In fact, what we do see is a drop in public disorder, because if you think about it, if people are out in the public using drugs, or if they're using in the doorsteps of businesses or wherever they happen to find a park or wherever to go and use, if they're allowed inside, then they're not in those locations. So it actually is a very, again, in the first one that I was involved in opening, we saw a 45% decrease in public disorder related in the first 6 months of it opening. It was dramatic.
Thank you. Representative Dauphiny.
Thank you, Mr. Chair, and thank you so much for your testimony. I'm sure we have a lot to learn about this protocol and how it's done. And I know that it's gone on in other countries, and I'm very curious to learn more. But one question I do have is, and I understand the mission and the goal, how do we justify those serving these individuals that come in for this service or help service, And then how do we then justify that these drugs are illegal and that we're arresting people right out on the street for participating in these drugs? So in one setting, we're protecting them from that. In the next setting, we're literally saying, no, these are illegal. We're going to arrest you. So I don't know. Can you speak to that a little bit?
Well, I did invite an officer from Victoria, BC to come and speak shortly to you to give testimony about from the enforcement side. And I would love for him to address that because I think what happens often as a result of taking this approach is that enforcement realizes that they aren't experts in the medical care of people struggling with substance use disorder. And as a result, navigate people to these sites for care. And they slowly begin to realize, oh, I'm no longer in the business of arresting people who are sick. I'm not in the business of arresting people that need help. Instead, I'm going to bring people that I pick up on the street who've got issues and we're going to divert them into care because it clogs up the criminal justice system to be arresting people for possession of drugs. And it doesn't benefit anyone because they're not getting the help that they need. And this is an entry point away from enforcement and into care, which is what people ultimately need.
And one more, if I may. So would you say that drugs should be legal then? If we're not wanting to enforce them and we're kind of going into the model of not enforcing anything that's happening as a result being criminal activity, do you think we as a society should be making drugs legal?
I think that the reality on the ground is that enforcement plays a key role in managing the drug problem. However, they can't solve the problem that individuals are struggling with in terms of their drug use and substance use related disorders. Those issues need to be dealt with by people who care about them and have solutions. And enforcement isn't arrest, jail, prison time. It's, deflecting away for the criminal justice system is ultimately the way to go. And that's what we're seeing on the ground. And in many communities where the sites have been open, the police have been working with us as a partner. They've then been able to divert their attention and focus on more serious crimes and actually prevent like the influx of major dealers into the neighborhoods or focusing on other aspects of policing, but not low-level drug users. They basically effectively decriminalized the entire zone around Insight when it first opened because they said there's no point us arresting folks for drug use. It's a shift in focus. It's like these folks don't need arrest, they need help. And this is a step in that direction. So why are we wasting our time plugging up the criminal justice system by arresting people for personal use? And they even made the distinction. Our police force, our chief of police came out with a statement saying there is a distinction between people who use drugs and sell them for their use and people who sell drugs. And so they created this distinction, user dealers and non-user dealers. And then they basically stopped arresting people who were using.
Please go ahead.
One more, and thank you, Mr. Chair. So we just legalized, I guess we didn't legalize, we took the prohibition off of cannabis, right? So, and we also took away many of those that had violations. We erased those, and many of them were selling, using, distributing, whatever that was. So it kind of seems to me like this pathway is the same. I guess I'd just leave that as a comment, but it just seems like that's what we're doing. But thank you.
Can I make one comment? I mean, I do think you don't have to be a rocket scientist to understand how broken the criminal justice system has been over the drug war and see the disproportionate number of people who are poor and of color who have been put into jail for drug-related arrests. So we know that it's not the most effective way of helping people. And I think that policies and programs and solutions that actually try to help people and get them what they need and address the reality of where they're at in their life offer hope,
Thank you. Thank you, Mr. Chair.
Thank you for your questions. Representative Wheelander, followed by Representative Zupkus.
Thank you, Mr. Chair. Thank you for being here today. When you mentioned it just now, and you had mentioned this word earlier in a conversation with one of my colleagues, and that was the word hope. And I was wondering if you could speak to a specific part of the wraparound services that could be offered, and specifically the hope that comes with possibility, and the possibility that comes with hope, and the pathways to recovery that could be offered with that care and the conversation and attention?
So one thing that I find the most hopeful, and the first day Insight opened, I was telling the senator, it felt like I was walking into a church, which sounds kind of crazy, but it felt like a very spiritual place because all of a sudden people who had previously been sentenced to being, injecting with dirty puddle water in the alley on the street and literally being really in danger for their lives came into a lovely, clean space where there was nice music and respectful people and they got treated well. And the hope that that communicates to a person is that your life right now is worthwhile and that I care enough about you to give you what you need right now without judgment. And that is hope. And that gives somebody a sense that, oh, maybe I should care about myself, about my life. And what we saw was a huge uptake of this belief that this pathway called harm reduction, this idea that you can accept a person who's still active in their drug use as a worthy person, can only therefore lead to other better alternatives, right? So more ways of thinking about pathways to treatment. And of course, tons of people who, when they're ready and at that point, might choose to take advantage of those, what we think of as more traditionally abstinence-based treatment models or medication assisted treatment is very popular. But similarly, harm reduction itself is also a pathway for somebody to improve their life. They might moderate their use. They might use less dangerously. They might use differently. And the education they get as a result of access to services that are actually designed for them changes the way that person thinks about their life and their health.
Thank you so much for that answer. I really appreciate it. And thank you, Mr. Chair.
Thank you, Representative Supkis, followed by Representative McCarthy-Vahey.
Thank you, Mr. Chair. Thank you for being here because I realize drug addiction is terrible. And even though somebody is addicted, they are still a human. Everyone is, and everyone deserves respect. I truly believe that. And it is very sad to me. I don't want anyone addicted to anything. Unfortunately, that's not ever going to happen, right? There are always going to be people addicted. And to kind of follow what Representative Wielander was talking about and hope, do these programs, and why wouldn't they? The end result to me would be to get people the help they need when they're addicted to get them off drugs. And I had asked someone earlier, and it was a voluntary process. If somebody came to one of these centers and they wanted help, they could get help. But if they didn't want help, they don't have to receive help. And so I guess I kind of look at this as if we could get people off drugs, which I never is, there are going to be people always, but the more people we could get off drugs, the better it would be. So why would we not in these centers go through like AA or some of those processes that have whatever that those steps are to get people off of the drugs?
Right. So, I mean, my point about the studies that show people who are actively injecting drugs stay active in their addiction between 12 to 14 years is based in the model of a world where those treatment opportunities exist. People can access them if they want. People can choose to go to detox. They can choose to go to treatment. Why people don't do that? It's the multi-million-dollar question. I don't know. But what we do know is 90% of people with substance use disorder right now in the US are not in treatment. Right? So we know a lot of people are not in treatment. Does that mean what I've seen happen over the years is lots of people just aren't at that point. They don't want that right now. They're not in a place where they can, and nor is the treatment system necessarily designed to meet them where they're at. So I see these centers as the entry point into treatment, which maybe sounds counterintuitive, but if you have nowhere to go, you're less likely to start your path and to get onto a road of taking care of yourself. You know, even if the changes that you're making are small, those changes are positive changes. Those changes are good for your health and they're improving the quality of your life.
And I would agree with you. I do believe, however, the mission when somebody comes in, meet them where they are, wherever they are, but meet them, but give them in baby steps or whatever those steps are, a way to in the end result would be to get them off of drugs. And I
We
guess
definitely-
that's kind of where I'm
you know,
So I don't know if this will help, but we built a detox right upstairs from the injection site. So the injection site was called Insight and upstairs was called On-Site. And we made that because the detox system was actually so difficult for people to navigate and so messy and complicated. You had to have a phone, you had to wait 3 days, there was never a bed when you needed one. So we literally put a detox upstairs. So people who came into the injection site and said, I want to go to detox today. We went, oh, okay, come on up. Like literally no intake, like no complicated waiting time, nothing. And as a result of that, tons of people went directly into detox from the injection site. Part of the problem is the way the system is complicated for people to navigate. And so having a place like Insight gave us the opportunity to learn about what the obstacles were for people and try and reshape services to encourage people to get more access points. And then if they wanted to leave and come back, that was fine too. And then we built more treatment programs and beds around that model. Hope that helps.
So thank you. And I believe that's maybe something this committee should look at. If the system we have isn't working, maybe we should look at what we're funding that's not working and try other things. But that's for another day. And my only last question is that when people come into these facilities, do they bring their own drugs that they bought off the street or from their dealer, or do these places supply the drugs?
It's a common misconception that people are supplied with drugs. Typically, overdose prevention centers are people bring their own drugs that they've purchased illegally, typically, and they bring them in. And most sites now have access to drug checking equipment on site. So before people even use the drugs, if they want, they can get them tested to see what's in it. Many sites have varying degrees of medical involvement. Some have like doctors and medical people and nurses, and some don't. Some are more peer run. There's a whole range of ways in which they can be operated.
Right, because I was, again, maybe after this public hearing, I'm curious as to what part does the state pay for, what part, and a concern is if somebody comes in and overdoses, then what happens? Like, are they rushed to a hospital or are they somebody there? So I know my time is out, I'm sure, but thank you for your answers.
Thank you. Representative Clarice Dietra, and followed by my co-chair and then Reddington Hughes.
thank you, Mr. Chair. Thank you again. So to follow up on the question, someone comes in to the safe injection site with their own drugs, and is it always, are you automatically testing the drugs before they inject them?
No,
What's,
no, not at all. Just if people want their supply to be tested, they can have it tested. We usually would ask people, do you know what you've got? Do you know what you're using? And that was really just to kind of know what to look for in terms of signs and symptoms of overdose.
okay.
And
One
then-
would, I'm sorry, but what I'm thinking, why wouldn't you automatically test it for fentanyl? Because if you have the fentanyl strips, wouldn't we want to make sure that it is what it is and it's not laced with something else? I don't know. That's why I'm asking.
Yeah, I think some people don't want to stop and wait to have their drugs checked before they use, frankly. I mean, other people might want to, or they could get their drugs checked at another time, or some people do want to get their drugs checked. It's just not mandatory. You don't make people do that. It's a service you offer and it's available. Generally, you're going to assume, sadly, that fentanyl is pretty much in everything nowadays. It's 85% of the overdose deaths in Connecticut were caused by fentanyl. But of course, we've seen an increase in xylazine and other things too as well being cut. So having drug checking services available is very helpful. And then you can plot trends and then educate people about what's in the drugs, and they can be more informed.
Just feel that would be important to know if your drugs have fentanyl in them, because wouldn't want to.
It's just not a requirement.
And
that's
if
all.
but then you also have the ability, you have doctors on site and you have Narcan there. Obviously,
So the overdose intervention itself is very straightforward. Most of the time, what you're really doing is providing somebody with oxygen and Narcan, and or oxygen and or Narcan. You don't always have to use Narcan. At the site in Vancouver, they only used about 50% of the time because oxygen was enough to resuscitate somebody.
Okay. All right. Thank you. Thank you, Mr. Chair.
Thank you, Representative McCarthy.
Thank you, Mr. Chair. And Ms. Evans, thank you for your testimony. I think that it's been said here before that many of us are in and out, and I'm sorry that I wasn't here for the entirety of your testimony, which I will go back and watch.
One thing that I did hear you say, and I was here for, was something you just repeated in the conversation with Representative Zupkis, was that people stay addicted an average of 12 to 14 years. Was that right?
There's two big longitudinal studies, the only two that I'm aware of. One was in Europe and one was in Canada, and they looked at how long, on average, people who are injecting drugs stay addicted, and it was 12 to 14 years. My point being, it's not simple to say, I want this person to not be addicted. And as many people who will tell you who are in recovery, they've gone through treatment 20 times before it actually, quote, worked, you know? It's not like we all can just stick somebody somewhere and get them out the other side and everything's fine, even if that's what you might want, you know? And it's not that I didn't want that. I was a young nurse who had this idea that I could come into a community and do stuff that was good, you know? And I had this knowledge and these skills, and wow, I learned so much really quickly about how everything I wanted was irrelevant, really. Didn't matter what I wanted, you know, and I had to learn to really listen and to walk beside people who were the experts on their lives, and they taught me an awful lot. And I was very humbled by that.
It is very humbling to face the drugs. They're incredibly powerful, and it's really difficult to deal with. And I give a lot of credit to you and to everyone who is taking this journey and trying to save lives and to help people who are addicted. And so I appreciate, and I will, my one other question, which is one Rep. Claritas Dietra often asks, but I don't think she asked this time, which was written testimony. I did search for your last name and found testimony by Sarah Evans. I'm wondering if you would be willing to submit some written testimony, in particular with the references to those studies. I think that is an incredibly powerful piece of information and a reminder to us that while we are, and we heard from our commissioner earlier, we certainly are doing a lot of things in this state. We're up against some pretty significant numbers. Thanks, Mr. Chair.
Thank you. Representative Reddington Hughes, followed by Representative Cook.
Thank you, Mr. Chair. And thank you for your testimony and all the hard work that you're doing to try to help these people that truly do need your help. I'm just trying to look at the history of the original harm reduction programs that seem to be initially those of treatment rather than those of clean needles initially. It was really more of a methadone program originally. Am I correct on that?
I'm sorry, I'm not sure what centers you're talking about.
That harm reduction programs initially, before like the 1980s, they were seen as programs that were offering methadone for addicts, that they were offering some means of trying to get them off the drugs. And then in the advent of AIDS is when really we had a lot more of the needle exchanges, so that we didn't have people that were spreading HIV.
So I think if we're talking about the history of harm reduction, that's a whole other thing. And that did grow out of the HIV for sure movement. And that
Yeah.
was really to necessitate access to clean syringes to prevent the spread of HIV. That's sort of how harm reduction and the history of harm reduction gets told, mostly through AIDS activists actually in the US. But the history of overdose prevention sites, which are also being integrated into what's being called in this bill harm reduction centers, is kind of conflating two different things together, which is the principles of harm reduction being embedded into a site where also people are able to consume substances on site, is my understanding of the sort of conflation of those two terms. And those sites have existed for over 40 years in many countries around the world, starting in Europe, and most notably in Frankfurt and also in Zurich and Switzerland, as a result of profound public drug use in locations where they wanted to minimize the amount of open injecting that was going on. So for instance, Needle Park is very famous, one of the first injection sites that ever happened, where they brought the drug users indoors and gave them a place to use drugs indoors. And the outcomes from those very early sites in Europe have been, you know, really good. And the statistics typically follow the same types of patterns that we saw in Vancouver.
Thank you. I just want to follow up, and that would be like in the United States today, how many states have implemented these? And what is their success rate?
So there's only
they're only open in New York. And they have had some unofficial sites in San Francisco. One, and they have passed a bill they have legislation in place in Rhode Island to open one, but it isn't open yet.
Thank you.
And certainly conversations have taken place in many other states, and many other cities are looking at it.
Representative Cook.
Thank you, Mr. Chairman. Thank you for being here and for all of you for having the courage to tell your stories. And as we sit around the table, I hope that we all remember that we can't walk the walk that folks that are here having the courage to testify have had to walk. And I think the most important conversation that we can have here is how we can meet somebody in the place that they are, because recovery is not the same for everybody. It is different for each and every person. So if we take anything out of here today, it's the stories of each one of you. And it's to realize that we can put a lot of things on a piece of paper. But at the end of the day, it's about meeting folks where they are to get what they need. And that doesn't happen overnight. And recovery is not an overnight fix. It's not a week fix or a monthly fix. It is a lifelong disease that we have got to figure out how to partner with all of you to help save lives. So thank you.
Thank you. So when you came and spoke, I said that you're a rock star. You are a rock star. Thank you for being here.
Thank you very much.
And we will go back. I had initially called on Mr. Wolfgang earlier, and I think we may have missed you. Sorry about that. We missed you by a little bit. Welcome. Thank you for being here.
Thank you, Senator. Chairpersons of the committee, ranking members, my name is Peter Wolfgang. I am the president of Family Institute of Connecticut Action, and I am here to oppose SB 9, an act concerning health and wellness for Connecticut residents. It is an outrageous attempt to intimidate pro-life people by creating a private cause of action against pro-lifers by anyone who would interpret their counseling or activity as physical obstruction, intimidation, or interference. Connecticut already has laws against physical interference with another's activities. This law is an unnecessary swipe at pro-lifers. The terms physical obstruction, intimidate, or interferes in aggrieved are so vague and encompassing that the bill drafter had to include a special exemption for parents who counsel their own children against abortion. And what about parents and relations of non-minors? They will be subject to lawsuits from their own children and relatives if aggrieved by overtures interpreted as physically obstructing, interfering, or intimidating. Connecticut already has laws prohibiting and restricting others from physically interfering, causing fear of bodily harm, physically obstructing another. The addition of these civil remedies, particularly to the subject of abortion, are unnecessary, and I challenge the drafters of this bill to disclose what recent activities in Connecticut would trigger this law. In fact, if this committee must vote in favor of this bill, they should include pregnancy resource centers as a protected facility and the women who seek their services from obstruction, intimidation, and interference. Across the country, pregnancy resource centers are under attack from people being stoked by pro-abortion organizations to attack. Most recently in Connecticut, a pro-life billboard was vandalized. It is these centers and the brave women who deserve protection and who are under threat in Connecticut, not Planned Parenthood. Thank you.
Thank you so much for your testimony. Representative Zupkus has a question or a comment.
Thank you, Mr. Chair. Thank you for coming today. And I just thank you for coming, and your last statement about, protecting one group and not another group is so valid, because that's what we should be doing as legislators. We should be protecting everybody and not picking and choosing. So I just want you to thank you for bringing that out. And I completely agree with you that we should be protecting everybody. And I know there was deceptive advertising and all those things are already on the books, but we tend to regurgitate things and to duplicate things. So I hope that that gets put into this also, that it's not just one specific group.
Thank you, Representative.
Representative Daphne.
Thank you, Mr. Chair, and thank you for testifying today. Can you share some examples that happened with regard to this intimidation in the pregnancy centers with us. I know you're making the
Yeah.
analogy with the two, so perhaps maybe we could get some examples.
So there's been a slew of incidents ever since the leak of the Dobbs decision last year. In fact, our sister organization, the Family Institute of Connecticut's sister organization in Wisconsin, Wisconsin Family Action, was firebombed. And there's been numerous pregnancy centers all over the country that have suffered various acts of vandalism. There's been churches, there's been this wave of seeming revenge against entities that were thought responsible for the overturning of Roe versus Wade. And there are groups that claim responsibility for this. There's a group called Jane's Revenge. There's a group called Ruth Sent Us, and they've issued ultimatums. They've been very open about their hostility. And law enforcement, unfortunately, on the federal level has been very slow. I referenced to do anything about it. I referenced one incident actually in Torrington where a pro-life billboard was defaced. So we've not seen that level of attack or violence yet in Connecticut. I pray God that we never do on either side. But the overwhelming attacks in the last year or so have been against pro-lifers.
Thank you. I appreciate your testimony.
Thank you.
Thank you so much for your testimony. Seeing no questions or comments, we'll move to the next person on our list,
Thank you, committee.
which is Janice Stoffer. Ms. Stoffer, welcome. Thank you for your patience with us today. And looks like you are in a hospital.
I am in the hospital and I had a very nice outfit picked out for today, so I'm very sorry, but good afternoon, Senator Anwar and Representative McCarthy Vahey. I've been in the hospital since Monday, but this is very important because I've been a nurse for 33 years. My name is Janice Stoffer. I am a resident of Reading, but I work at Danbury Hospital in the ICU. I also have been a union president here for Danbury Nurses Union since 2017. I'm speaking upon myself as well as the many, many nurses who are hurting and in a detrimental situation because of the poor staffing conditions. I do really, really want this to go through. I support this bill. I would like it not to wait until 2028. I know there's some issues with hospital administration, but I do want you all to understand that there is a very different measure between a registered nurse. There are registered nurses who are in administration. Those are non-patient facing nurses. They do not do the same things that the nurses at the bedside do. And I know you're going to be speaking with nurses today. Sharon Adams, who's the president of our hospital, will be speaking. So I just want you to understand that there is a difference between a nurse who is at the bedside and a nurse who is in administration. As a nurse dealing with COVID and dealing in the ICU, having more than 2 patients is detrimental. This past weekend, we had 3 nurses with 3 patients. Patients are not getting cared for the way they need to. We're not able to follow the doctor's orders. Antibiotics are late. If you have a medicine like ampicillin for someone who has an abscess, you have to give it every 4 hours. It's very difficult to keep up on that when you have other patients who are having Q15 or every 15-minute vital signs, or needing to be turned and repositioned so they don't get pressure injuries, giving medications, teaching patients, working with the families. It's very, very horrible the way the staffing has been. The nurses who are new nurses the last 2 years, their clinicals have been on Zoom. So they don't even know how to do really a physical assessment on a real body because they've done it on Zoom. So the nurses who are here, the more senior nurses, are teaching these nurses, and we are trying very hard to give them a wonderful orientation. However, if we're supposed to have 4 patients on the medical telemetry floor and they actually have 8 patients, they can't do the teaching they need to. I'm actually here. I got to talk to many of the nurses over the last 3 days, and it is like, was this destiny that I had to be in the hospital at this time? So I really urge you to support this bill, and I am happy to come to Hartford at another time when I'm not sitting in a hospital bed. So thank you so much for listening.
Thank you. Senator Marks has a question or a comment.
Hey, Janice, good to see you. I hope you feel better.
Thank you.
Yeah, so we do. We have nurses at the bedside, we have nurse administrators, and now we have nurse senators, and I highly recommend it. So I just a lot of people sent in, a lot of nurses sent in testimony, and they sent it in anonymously. Why would you think that nurses would feel that they had to do that?
Yes, it is unfortunate. And actually, 4 of the nurses came to me with tears in their eyes, and they are so fearful. They worked so hard to get their nursing license, and they've been a nurse for a very short time. And they're afraid, and they told me they are afraid of retribution. They're afraid of retaliation. I did encourage them that union work is protected, but they're young nurses. And even some of the senior nurses are like, I have a couple more years before I retire. I don't want to get pushback from administration. And we do unsafe staffing forms. We normally would have maybe 1 4-inch binder per year. We have so many unsafe staffing binders right now, and we're not getting the support from administration. We're just getting do the best you can. It's short all over. There's nothing we could do. We can't get nurses. There are nurses out there. I would like a retention bonus for nurses, new nurses, senior nurses, all nurses. Let's get these nurses back who refused to get the COVID vaccine. 21 nurses left the profession because they didn't get the COVID vaccine and they were forced to leave. Let's get those nurses back. That's really unfortunate because it's horrible that they can't be in that situation. So I don't know that maybe we can pull them back because the COVID vaccine is not, mandated at this point, or maybe it still is. At our hospital it is, but anyway. Thank you.
Thanks, Janice. And then how does your staffing committee work? Is it successful?
So the staffing committee on paper looks like it would be successful, but the things that we ask for, so we have half of our nurses on staffing committee and we have some administration on. We put up things, they say, okay, we can trial this, or okay, we can do that. But the things that we all discuss never occur, or we discuss what's been submitted to DPH and we say, well, this was submitted. It's supposed to be 1 nurse to 4 to 5 patients, but these nurses are having 10 to 11 patients. And they're like, well, the DPH that we submit, the staffing guidelines, we only try to do it. Like there's no teeth in it that they're going to get in trouble or they're going to get fined or anything like that. There's no money value. So they just say, do the best you can.
Right. Thanks, Janice. Feel better.
Thank you.
Thank you so much, Ms. Stoffer, for your testimony, and thank you for going above and beyond the call of duty to speak for the nurses, even when admitted to the hospital. I have a simpler question, and this question has been in the back of my mind for a long time. What happens when a nurses union leader gets admitted to the hospital? How does she get treated by the nurses?
Wonderfully. I mean, I actually am very blessed. I've had, people coming in there. Everyone's very respectful. They always ask. They'll sometimes text me and say, is it okay if I come and see you? But I have been blessed that I have a very good following, and the nurses at Danbury Hospital are really, really wonderful. We just need more of them, and we need administration to listen to the nurses because we are the nurses at the bedside. If we have, these people coming in, just keep in mind, like a mother, father, sister, brother of yours that are here, and you have this one nurse who has 8 patients. They're only going to see your loved one every 3 hours, maybe, because they're going to be doing care for so many. So we just want to be able to do the best we can. We all came into nursing to care for patients. That's what we want to do.
Thank you so much. We really appreciate you. Seeing no other questions or comments, we'll go to the next person on our list, which is Tiana Hawley. I hope I pronounced your name correctly, Ms. Hawley.
Tina. It's very simple, Tina.
Okay.
Just the way they spell it in Finland.
Welcome.
Welcome. Thank you. So good afternoon, Senator Anwar, Representative McCarthy and Vahey, Senator Somers, Representative Claritas Ditria, and members of the Public Health Committee. My name is Tina Hawley, and I am a resident of Danbury. And I work as a registered nurse at Danbury Hospital, and I'm actually the vice president of the Danbury Nurses Union. I offer the following testimony in support of Senate Bill 1067, an act concerning adequate and safe healthcare staffing. I have worked at Danbury for 36 years on the medical unit and the past few years on the COVID unit. Oh, are you there?
Please proceed. We can still hear you.
Oh, you can. All right. I sort of disappeared. Okay. Let me start. So I've worked at Danbury for 36 years on the medical unit and the past few years on the COVID unit. I have seen many changes throughout the years. The patients I care for in the 80s and the 90s would not be admitted in today's standards. The patients that I care for today on my unit would have been ICU patients in those days. The patients on my unit are sicker than ever, especially since COVID. The care they need can be very time consuming and much needed. I spend my first 5 minutes getting to know them and letting them get to know me. I will assess them, then administer medications and provide personal care. I want my patients to feel well cared for. This usually takes me 20 minutes per patient. I am expected to see each patient hourly. It becomes very difficult when you care for more than 5 patients. The patients need more than 10 minutes of my time. I praise my patient care technicians, as every day I could not function without their assistance. I would not be able to provide the best care that I give. We work as a team. It becomes very challenging when your patient care technician has anywhere from 8 to 14 patients, and the nurses are at 6 to 7. And I actually work the day shift, so that's our day during the day. It gets worse as the day progresses. You find yourself being more of a task-oriented machine rather than a caring, supportive human. I will not let myself become this. Patient care is my priority. Caring for 5 patients allows nurses to provide the best care. Nursing is in a crisis. We lost so many nurses when the pandemic started and now struggle to keep nurses. Nurses get so overwhelmed caring for so many patients and feeling that they are not providing the care the patient deserves and needs. They search for hospitals with better ratios, many moving out of Connecticut, which compels the situation further. The hospital is much aware of what our ratio should be. They submit them to the state yearly and yet do not adhere to them. How long do nurses have to wait to get the support needed? Thank you for the opportunity to testify. I would happy to answer any questions you may have.
Thank you so much for your testimony. Seeing no questions or comments, we will move on to the next person on our list, which is Luis Quiroz. Mr. Quiroz, you're here. Going once, going twice, and then we are going to move on to Janice Callison.
Yes, I am here.
Yes,
My
welcome.
name, thank you very much.
Your camera is off.
Yes, I can't seem to get it working. I'm so sorry.
It's okay. We'll listen to you.
Good afternoon to senators and representatives and the members of the Public Health Committee. My name is Janice Callison. I'm a resident of New Milford. I work as a registered nurse at Danbury Hospital, and I've been a registered nurse for more than 40 years on both the Practice Council and the Staffing Council at Danbury Hospital. I offer the following testimony in support of the Senate Bill 1067 and the Act concerning adequate and safe healthcare staffing. It has been 10 years since my daughter had a fatal car accident. You wonder what could possibly have to do with staffing? Well, there is a saying about short staffing is kind of like driving drunk. Some of the time everyone gets away fine, but all the time people's lives are at risk. Alcohol slows response, affects coordination, impairs memory, changes mood, decreases your ability to focus or make decisions, and lack of perception, headache, and fatigue. The other night, I had 7 patients and no nurse's aide, my colleague having the same number of patients. Let me put it into perspective. One of my patients of the 7 had 5 loose stools, incontinent during the night. Another patient in isolation had 2 rounds of peritoneal dialysis. I had a hip fracture patient who got up very slowly 3 times to the bathroom and called another 4 times because she was not comfortable. A confused gentleman took his CPAP off 3 times, was restless and impulsive all night. I had one that was grossly incontinent of urine in tears because she could not wait. That is 5 of my 7 patients. I had IV fluids running, labs to draw, medications to give, assessments to document. Doctors called, pain to alleviate, and obviously bodily fluids to wipe away. In room 14, I had a gentleman with ominous assessment signs, temperature, low oxygen saturation, low blood pressure, fast pulse. While I assessing him, beep, 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 a bed alarm. The patient getting peritoneal dialysis was dragging her exchange catheter and bags of fluid and her to the bathroom. The confused gentleman next door was hollering for help. The effects of being short-staffed is fatigue, being overwhelmed, losing focus or concentration, headache, increased blood pressure, anxiety, and depression. But for the patient, it is even worse. Obviously, each additional patient adds to the workload for the nurse. Patient survival and safety is compromised. There is a direct correlation between nurse-patient ratio with recovering survival rates, and being understaffed is associated with unmet patient needs, negative patient outcomes such as mortality, failure to rescue, cardiac arrest, patient falls, pressure and injuries, infections, sepsis, and increased readmission rates. That night, I did get back to the man in room 14. Lucky for him, I was able to get him the immediate care he needed, and he was emergently transferred to higher level care. Nursing units should not be staffed, so the quality of patient care and safety is up to luck. Let me reiterate, adequate staffing ratios improves patient safety, quality of care, and most importantly, safety rates. Like a drunk driver making it luckily to their destination, I should not be wiping my brow as I leave and think I was lucky tonight. I made it through another shift, nor should a patient's well-being, safety, air-free quality.
Excuse me, Ms. Callison, but your time is up.
I
Thank you.
just have a couple of, just one more sentence. Nor should a patient's well-being, safety, air-free quality nursing care have anything to do with luck. The SB 1067 will set nurse-patient ratios that will not leave quality care to luck. Because 10 years ago, my beautiful daughter driving home
Thank you.
was
That's more
not
than
so
a
lucky.
sentence, Janice. Thank you. All right. So with that, seeing no questions or comments, we thank you for your testimony and appreciate you being here.
I did want to say I am on the
I
staffing
think
committee.
we're done,
Okay.
Janice. So sorry.
Okay,
We
thank you.
want to be fair to other people.
I agree.
Thank you so much. The next person on our list is Amy Jodwin. If you're here, welcome. Thank you.
Good afternoon. My name is Amy Jodwin, and I'm a registered respiratory therapist in the state of Connecticut and a board member on the Connecticut Society for Respiratory Care, which I will refer to as the CTSRC. The CTSRC represents over 1,800 licensed respiratory therapists in our state of Connecticut. Respiratory therapists are an integral part of the healthcare team in both inpatient, outpatient, and home care settings, and are important contributors to the economic landscape of Connecticut as taxpayers and consumers. Respiratory therapists are licensed practitioners. In order to maintain credentialing and licensure in the state of Connecticut, we must meet and complete additional educational requirements yearly, similar in those of other healthcare professions such as nursing. Prior to, during, and currently in our post-pandemic reality, the ratio of new graduates to open positions is alarmingly low. The reasoning behind this has been outlined by the CTSRC in our submitted testimony. Simply put, our state, nation, and world need more respiratory therapists. However, our ability to produce them in a sufficient numbers to meet this demand is inadequate. The CTSRC has come to a consensus that SB 1228, representing an extraordinary opportunity to strengthen our ranks for a future in which the demand for respiratory therapy services is projected to grow. Our values lie in our ability to provide an expert level of patient care that extends across one's entire lifespan. Senate Bill 1228 has the potential to channel new interest and support our workforce. The CTSRC supports the spirit of Section 1 of this bill. However, we respectfully recommend the language in Section 1(2) be amended as complete a curriculum designed to prepare such student for higher education in pre-medicine, nursing, and other healthcare professions. This will encompass all of the respiratory therapy programs within our state. The CTSRC fully supports Section 2 of this bill and stand ready to work with the Commissioner of Public Health to study these methods and assist in developing a plan to address the shortage of respiratory therapists in the state. Previously mentioned, respiratory therapists requiring credentialing and licensure by the state of Connecticut. Given that respiratory therapists practicing today include licensure, participate in extensive continuing educational requirements, and a national credential maintenance program, we propose to amend Section 5 of Senate Bill 1228. We request that our profession be removed from this section of the bill due to these strict state statutes for our licensing. Thank you for your time and consideration of our position and testimony to bring recognition, draw, and attention to our field to continue the pipeline of new respiratory therapists. We look forward to partnering with you with these proposed amendments on this great work provided by this bill. Thank you again for your time, and breathe easy knowing the respiratory therapists in the state of Connecticut truly do care about your air.
Well said. Don't go away. First, I wanted to thank you and every respiratory therapist for all the work that you've done in the heroic manner every single day, but especially during the pandemic and even now. And you're right, the number of respiratory therapists are not keeping in sync with the needs that are going on with our aging population and respiratory illnesses that we're facing. And that's why we have a bill to look at the healthcare workforce. And I presume you have a written testimony. We will look at the specific recommendations you're making to make sure that we do right by you.
Thank you. We look forward to partnering.
Thank you.
Thank you.
And then what did you say the last sentence was?
Breathe easy knowing that the Connecticut respiratory therapists truly do care about your air.
All right. Thank you. Thank you. With that, we'll move on to the next person on our list, is Kathy Flaherty. Welcome, Kathy. We said good morning, but it's good afternoon, but I said good morning to you too when you're here.
You did.
Yeah.
I was here for the press conference earlier today. My name is Kathy Flaherty. I'm the Executive Director of Connecticut Legal Rights Project. And I'm pleased to be here today in support of Senate Bill 9, especially the sections about harm reduction centers. The reality is, and I'm sure people have been telling you this all day, I've been upstairs in judiciary, so I haven't been able to keep track, but they save lives. They do not promote use. They make sure that people who use drugs don't die. It's as simple as that. We need to give people the chance to live so that they can get connected to recovery when they are ready to stop using. But we should not let people die because we are afraid to try something new. Thanks.
Shortest and the most meaningful testimony all day. But a lot of other were very meaningful too, but very short and sweet. Thank you.
You're welcome.
I see no questions or comments, and we will leave the remaining 2 minutes and 30 seconds for another testimony another day. Thank you. With that, we have Ryan Marino. Welcome.
Hello. Thank you to all the distinguished committee members for allowing me to speak today. My name is Ryan Marino. I'm a physician and faculty member at Case Western Reserve University in Cleveland, Ohio. I have board certifications in addiction medicine, medical toxicology, and emergency medicine, and actively practice in all three full time. The focus of my work is substance use and working with people who use drugs. And I am also the medical director for one of my city's few addiction bridge clinics. I am here to give my unequivocal support to Senate Bill 9, specifically sections 4 and 5, the establishment of harm reduction or overdose prevention centers. I was asked by multiple people to speak to this group today in light of the opportunity to make a significant difference. As an expert in overdose myself, I can say with authority that every single overdose death is preventable. And until our policies work to prevent them, every single overdose death should be considered a policy failure. What is often overlooked in conversations about this topic, particularly by local community members, is that the alternative to safe consumption sites or overdose prevention centers are unsafe consumption sites and overdoses that are not prevented. I can assure you that unsafe consumption sites already exist all around you, whether you are aware of them or not. Just because they're not always visible doesn't mean they're not there. This is what's happening, and this is why people are dying. While it's easy to say that people should just not use drugs or just stop using drugs, we know very well from decades and decades of scientific study that a majority of people will try illicit drugs at least sometime in their life. These people don't deserve to die for that. We also know that policies based on those beliefs have failed repeatedly to stop drug deaths and drug use. Even in the best case scenarios for treatment and long-term recovery, we know that relapses happen. Addiction is a chronic condition that has flares like any other, and people who relapse don't deserve to die either. Please note that nobody can recover if they die. I have lost some of my best friends, family members, and too many people to count to overdose. If this crisis has not yet affected you personally, I pray that you never know the pain and regret of losing someone this way. Even dedicating my life to treating overdoses and addiction full-time, I cannot stop every single one. My colleagues and our patients need your help. We owe it to our fellow citizens to do everything we can to prevent loss of life and any other preventable harms that we can. Not only is this just the right thing to do, the science is sound from places like New York City, Vancouver, and elsewhere around the globe. It's time that we follow the evidence before more lives are lost. Thank you.
Thank you for your testimony. We appreciate you coming in and sharing your perspective. I do not see any questions or comments. We will move on to the next person on our list, which is Marcy Russo. Welcome, Ms. Russo.
Thank you, Senator Anwar, and hello to the members of the Public Health Committee. I'm Dr. Marcy Russo. I'm a Connecticut licensed psychologist. Today I'm writing as the chair of the Legislative Committee of the Connecticut Psychological Association, and I'd like to express our support for and to propose additional language for Senate Bill 1228, an act concerning the state's healthcare workforce. Access to behavioral health services is one of the top challenges for the United States healthcare system, and this has been exacerbated by the COVID-19 pandemic. The shortage of mental health care providers has been documented, especially in rural communities. Barriers to such include lack of insurance, providers who do not take insurance, inflexible clinic hours that also affect access to care, perhaps particularly in rural and impoverished communities. In part, this reflects the shortage of licensed mental health care providers, including psychiatrists and psychologists. Specifically in Connecticut, roughly 32% of Connecticut residents live in a mental health professional shortage area. And that's compared to 0.45% in New Jersey, 8.9% in Delaware, and only 3.9% in Massachusetts. As a state, we really must increase the opportunities that develop, support, and employ competent behavioral health providers that can easily move into the field of supervised practice once their educational requirements have been completed. Connecticut has had increased success in doing such for the field of social work and other counseling professions, with many temporary master's level permits currently granted. Psychologists are uniquely poised to enter the field of clinical practice as competent practitioners and scientists. While doctoral psychology students complete educational requirements to attain their doctoral degree, on average, we have already accrued over 4,000 supervised clinical hours by the time our doctorate degree is conferred. Moreover, once that doctorate degree is conferred, we then enter a minimum of a full year of supervised clinical practice, and this is commonly referred to residency or fellowship in the field of psychology. Psychologists are well poised to assist and help to address the profound shortage of competent behavioral health providers in Connecticut, and should be allowed to enter practice immediately upon graduation under a temporary license. And as such, I've proposed in my written testimony some specific language for a temporary permit that would allow doctoral level psychology students to practice under the supervision of a psychologist once they immediately graduate. So I know time is short, but I just want, for these important reasons, I would ask that you support the inclusion of the language that I included in my written testimony, allowing for a temporary permit for a doctoral level psychology license in Senate Bill 1228. And I'd be happy to answer any questions if you have any.
Thank you so much for your testimony. We appreciate you being here. I see no questions or comments. We'll move to the next person on our list, which is Dominic Marcelek. Welcome. Hi, Dominic. Go ahead.
Hi, folks. Good afternoon, Chairpersons Anwar, McCarthy Vahe, and honorable members of the Joint Committee on Public Health. On behalf of the American Counseling Association, I am thankful for the opportunity to express our strong support for SB 1228 with amendment to add the Counseling Compact. The Counseling Compact will allow Connecticut to join the 19 states that have enacted the compact, as well as the 22 states that have introduced this legislative session. Founded in 1952, ACA is the world's largest association, exclusively representing over 62,000 professional counselors in all 50 states, including Connecticut. The Counseling Compact utilizes a mutual recognition model of interstate practice, whereby compact member states agree to recognize valid licenses issued by other member states. To utilize the compact, a professional counselor must have a license in good standing in their home state, their primary state of residence, and the home state must be a member of the compact. When a licensee wants to work in another member state, the licensee must obtain a privilege to practice from the Counseling Compact Commission, the public administrative entity composed of a state counseling board representative from each member state. Commission regulatory power is strictly confined to administration of the compact and does not interface or interfere in any way with individual state practice acts or a state's scope of practice. A privilege to practice is simply an additional privilege that a Connecticut counselor can opt into after being licensed by your state. The compact is not an alternate license nor pathway to licensure. It is an optional privilege for current licensees in your state. Furthermore, like single state licensure processes, counselors provided a privilege to practice must abide by the laws of the state they're practicing within. And the Counseling Compact preserves the authority and sovereignty of each state. The compact is revenue and cost neutral. We do not anticipate substantial additional costs for states because the Counseling Compact allows member states to offset nominal administrative costs by charging an appropriate fee for the privilege to practice. These fees will substantially reduce the cost of practice across state lines for counselors. The compact also streamlines processing, thereby saving state boards further time and money. Privilege to practice through the compact will be available to counselors by early 2024, allowing for rapid verification and immediate access to all compact member states. This enhances the workforce, ensures your state remains competitive, meets increasing demands, broadens patient choice, and creates a national database and network for the first time, allowing for advancements in behavioral health while optimizing patient safety. Much like existing compacts, this compact modernizes data sharing between states, which optimizes public protections for children, families, and vulnerable clients, simplifies current interstate licensure processes with a near instant verification system, provides an expedited licensure mechanism for counselors moving from one member state to another, strengthens telehealth across each member state, eases workload for state regulatory boards through modernized verification systems, enhances mobility for counselors, increases access to care for clients, ensures continuity of care, allows military personnel and spouses to maintain certifications, and preserves and strengthens the current state licensure system. The Counseling Compact is the only valuable, sustainable.
Excuse me,
long-term-
Ms. Marsalek, but your
Yes.
time is up. Thank
Oh,
you.
okay, great. Thank you.
Thank you. You got a lot of information in there in that 3 minutes.
Had one more sentence. Thank you, folks. If you have any questions, please let me know.
That's perfect. I just wanted to confirm that you have submitted your written testimony as well.
Yes, ma'am.
Okay, wonderful. That's great. I will just make one comment about the compact. I think you've heard earlier here today that there is definitely interest in pursuing that, and the technical pieces involved in drafting compacts are part of why that's not been in drafted language so far. So we'll see what we'll be able to do going forward through the rest of this session, but it's a worthy conversation. We thank you for being here today.
Thank you.
Next on our list is, I believe, number 55, Maladi Thapa. Audie, are you here? There you go.
Yes.
Welcome. Please proceed.
Good afternoon, Senator Anwar, Representative McCarthy-Paye, Senator Somers, Representative Claridas Ditria, and members of the Public Health Committee. My name is Malti Thapa. I'm a resident of Bethel. I work as an RN in Danbury Hospital. I offer the following testimony in support of SB 1067, an act concerning adequate and safe healthcare staffing. I've been a nurse for over 10 years. I believe this bill is necessary because our patients are not getting the quality of care they need and deserve. On my floor, I can only care for 4 to 5 patients safely. However, over the past few years, I've had to regularly care for 8 to 10 patients. At times, I must care for as many as 15 patients. This is not an exaggeration. This is my reality. This is wrong, and this is not safe. This understaffing increases the risk of nurses making medication errors, delaying important patient care, and missing critical lab values. Understaffing also increases the risk of patients falling and injuring themselves. On a recent shift, I had a patient who urgently needed a blood transfusion, while another patient was having severe chest pain. And third patient had jumped out of bed and was lying on the floor. At the same time, my patient care technician was overstretched with 15 patients of her own. I face this kind of crisis several times a week. Thank you.
Thank you very much for your testimony and for being here today. The folks from Danbury have been representing quite well today. Next on our list is Connor King. Please proceed, sir.
Thank you. Good afternoon, members of the Public Health Committee. My name is Connor King. I'm a police officer and inspector and officer in charge of the Victoria Police Department's Criminal Intelligence and Drug Enforcement Unit. Victoria, if you don't know, is the capital of British Columbia. We're a short distance from Vancouver, BC, and a ferry ride from Seattle, Washington. I am speaking to you today in support of SB 9 with respect specifically to overdose prevention centers, of which I have some familiarity here in Victoria, BC. Victoria, just so you know, is the third hardest hit city with respect to overdose deaths in Canada. And we have seen an 800% increase in overdose deaths in the last decade. We've been absolutely devastated, as you have been, with overdose deaths. We have about 5 deaths per day in the province of British Columbia. In 2016, the province of British Columbia government declared a public health emergency and incorporated both health and police officers to work together cooperatively in the opening of overdose prevention sites. And I had the privilege of working with the British Columbia Centre for Disease Control, the lead agency on overdose response, and we helped create a guideline for police interaction with overdose prevention sites, we call them here, so that we would have a cooperative and collaborative rollout of these sites. But because of course, the public has concerns about public safety with respect to overdose prevention sites, and we wanted to make sure that those concerns were properly addressed. So we opened 4 sites in the city of Victoria within short order. 3 of the 4 sites we had absolutely no problem with. And the only issues we had with the 4th site was just cooperation between police and management. And that's one lesson that I would recommend that you learn from our experience, is that good engagement between police and the site managers will make these sites work so much better. The secret really is excellent communication. A couple of things that we had going for us is strong public support. I'm happy to report to you that generally we see these sites as a real positive for both public safety and of course public health. I mean, police want lives saved and deaths averted, and these sites, in my opinion, do avert deaths from overdoses. They also get people off the street, out of parkades, out of stairwells, out of restaurant bathrooms, and into the sites where they can actually access services that are going to help them and reduce public use. So from a police perspective, it's a win-win. We have a very cooperative and amicable relationship with our public health partners. That's kind of the Canadian way. We like to get along with our colleagues and coworkers, and it's working really well for us. And I hope that if Connecticut adopts it, it'll work well for you as well. And I'm happy to take any questions if you have any for a police officer on this subject.
Thank you very much. I think we do have a couple questions. First, I'm going to go to Representative Mara.
Thank you so much for giving your testimony. And it sounds like maybe our stats are fairly similar with your 5 deaths a day, and you've got about 5 million people living in BC, and we're at about 4 a day with a little over 3 million here in Connecticut. So I guess one of the things I want to ask you about is, as you started this process of working with the community, did you find hesitancy, and how did you overcome that? And I'm speaking specifically if you maybe came upon a group of people using and how you transport them to the centers.
Right. So in my city and in Vancouver, the police officers are walking the beat and engaging with the public, particularly the street entrenched drug users, people who use drugs. They already have a lot of strong relationships and good communication with these groups. Once the sites opened up, if we did encounter a group of people who are using drugs in an alleyway or in a parkade, we would 100% encourage them to take advantage of the site that literally is maybe half a block away or a block away. And that we had a lot of success having those communications, but it doesn't mean that everybody wants to use the site. Some people just have an aversion to the site for some reason or another, but that continued engagement we found pretty effective in getting people to get into the site. And of course, it's such a win when they're using the site because it's less sort of disorder for the community, as well as every opportunity, or it creates those opportunities where maybe on that one particular day, they're going to have the right conversation with the right person that's going to help them to get onto some opioid agonist therapy or into recovery. So we see that as a win.
Thank you. And then just one follow-up question. Were your police officers, were they receptive to this idea?
As you can imagine, 10 years ago, the idea of having overdose prevention sites in the city of Victoria, just like in how police officers feel about these quite commonly before the overdose crisis, we were all against it. It seemed like it just wasn't something we were supportive in the community. But then faced with staggering overdose deaths, there was really a mind shift that occurred in policing in the province of British Columbia, probably around 2015, 2016, where we realized that our enforcement efforts, 100% enforcement efforts at the street level when it comes to arresting people who have small amounts of drugs in their pockets, was doing no good whatsoever. And that we shifted our philosophy to saying, okay, high-level drug dealers that are bringing in kilos of fentanyl, that's our mission, and we're going to work on that. But somebody with 100 milligrams of heroin or fentanyl in their pocket, they are engaged in an unhealthy health practice, and that's a health concern. And we want that person to get the right health care treatment. So there has been a massive shift. So I can tell you that the Canadian Association of Chiefs of Police and the British Columbia Association of Chiefs of Police both came out in the years between 2016 and 2022 in support of overdose prevention sites and supervised consumption sites, because they see it nationally as a strategy to stop overdose deaths.
Thank you so much. I think that's really important to hear. Thank you. Thank you,
You're
Madam
welcome.
Chair.
Thank you, Representative. Senator Almar.
Thank you so much for your testimony. And I think your testimony is going to help anybody who's going to start some of the centers over here. In the broader political context, were there conversations or concerns that the law enforcement was not arresting individuals and putting more people into prison rather than rehab?
Well, I believe you've heard in previous testimony that organically the community, both the police and people who use drugs and service providers, were all kind of organically reaching a conclusion that arresting people was not helping at all. So arrests for low-level possession was already had already stopped prior to the advent of overdose prevention sites. Likely 4, 5, maybe 6 years ago, those arrests basically came to an end in large urban areas in British Columbia. And then over the last 5 or 6 years, we have essentially formalized our stance on how we deal with people who have small amounts of drugs. I hope that answers your question.
It does, and I'm sorry, I probably repeated the question. I had stepped out for a second. The other part is, do you have insight into how many people are getting rehabilitation, and have been able to change their lives, if you will?
The latest mathematical modeling that I have seen talks about overdose prevention sites, naloxone distribution, treatment, and then also safer supply. And the number is something about 6,000 deaths have been averted over the last 4 or 5 years. Drilling deeper into how many people are actually uptaking into rehabilitation, I don't have those numbers. I'm sure there are health authorities here in British Columbia that can provide those numbers for you, and that's something that you're definitely going to want to examine. But how we look at it, even if those numbers aren't as high as you want, if you are keeping people alive until such time as they're ready for rehabilitation, they're ready for treatment, as we say in British Columbia, and it's crude, but you can't rehabilitate, and there's no recovery for somebody who is dead. So this is, in many ways, this is like a bandage on a bleeding wound to keep people alive until rehabilitation or recovery is right for them.
And I just want to clarify, did you say 6,000 deaths were averted in the last 4 years?
Yes, it's mathematical modeling out of the University of British Columbia. I want to say it's about 6,000 deaths averted from the sort of holistic approach of harm reduction measures, that some of which I've already mentioned. Yes.
Thank you. That should be another good reason for us to look at this seriously. Thank you so much for your testimony. Appreciate you being here today.
You're very welcome.
Thank you, Mr. Chair. And Mr. King, I want to say thank you for being here. I'm quite familiar with not just the Seattle ferry, but the Port Angeles ferry as well, having lived in Kingston, Washington for almost 10 years. Just for context, can you tell us what the population of Victoria, British Columbia is?
Yes, so the greater population of Victoria and the sort of suburban bedroom communities is about 380,000 people.
So the 4 sites that you have, are they more in the kind of more densely populated, I'll call it downtown area? I'm able to picture it, and not everyone here is, so I'm trying to give us a little bit of a sense of what that looks like.
Yeah, you're exactly right. The 4 sites were located almost directly downtown, within about sort of 6 or 7 blocks of each other, where you have that like dense urban area where our street population or our marginalized population or hard to house population, that's where they were focused. So clearly location is really important with these sites. You don't take one of these overdose prevention centers and put it, in an empty Foot Locker in a suburban mall. That's not going to do anybody any good. You got to put it in the location where it's going to be accessible. And that's what we did. Our 4 sites were directly downtown. Those areas were already seeing lots of street level drug use. So you put the site where obviously uptake is going to be most accessed, if that makes sense.
It does make sense. I think one of the things you were talking about was the public support. And I would imagine that it's similar to when you're trying to, when you're moving into that place of being able to determine, as happens with motivational interviewing, that process of where things are getting worse than they are better. And was that public support born of the fact that people were seeing so much activity on the street that they wanted something else? I'm going to use the word drastic. It's probably not the best word, but something else more significant done to address the problem. Or if not that, what did really push the public sentiment in a different direction?
I'm confident in telling you that the public sentiment was pushed in a collective agreement by the citizens of British Columbia that the drug overdose deaths the numbers were so staggering that we needed to take bold steps to save lives. It's almost like here in British Columbia, everybody knows somebody who has died from a drug overdose. Here at the Victoria Police Department, I have 2 colleagues who are about my age, in their 50s with adult sons and adult daughters, and one has lost a son and one has lost a daughter to drug overdose. This is a widespread loss of life, and so there has been a societal shift to recognize that it's time to change our way of dealing with these drug overdose deaths. So when the provincial government decided that they were going to enact an emergency measure to open overdose prevention sites, there was a spattering of resistance from certain communities, but generally this was a movement where most of society said this is the right thing to do, and let's put them in the place where they're going to have the most benefit.
As Representative Mara pointed out earlier, the number of deaths in a population of 5 million in British Columbia does not differ significantly from the number of deaths that we have here in Connecticut at 3.5 million. But we are not culturally or societally in the same place in the conversation. And I'm wondering if you have any sense as to what the differences are. I'm trying to get at that because I know even in prevention efforts and working with youth prevention, social norms often drive behavior. Seatbelts are a great example. What do you think we can do in terms of moving the social norms and addressing it from that standpoint?
Yeah, I get it. You're entirely right, and I wanted to be very careful not to appear before you in this hearing, and you're in Connecticut and I'm on the west coast of Canada, without acknowledging that there are different societal norms, there are different cultural sensibilities, and we have a different, I think, sensibility here than you do in Connecticut. In Canada, we just earlier, I think, than you have in the United States, we have shifted away from an enforcement model where we are going to, I know people don't say this anymore, and everybody agrees we're not going to arrest our way out of this. I think that really the way to get people's minds shifted is to, and I'm going to be very bold here, is to get people to generally understand that addiction is a disease, this is not a moral failure, and that we are at a place now in society where if we follow the science, and science is generally consistent nation to nation, city to city, that the science indicates to us, it's repeatable. That's the whole point of science. It's repeatable. That if you look at what other countries, what other cities are doing, and you say, okay, well, they have different sensibilities than us. They have different societal norms, but the science makes sense. So let's give it a try, because what we're doing right now is not working. And that's what we did. We really took a cold, hard look at ourselves, particularly in the law enforcement milieu. And we said, what we're doing is not working. And in many ways, maybe what we're doing is actually contributing to the problem. Let's let the cops focus on what cops love to focus on, which is high-level drug dealers. And let's shift the responsibility to our public health partners who are really compassionate and engaged on saving lives. So, but ultimately, your local communities and your state by state is going to have different sensibilities about what's going to work and what's not going to work for them and what they're comfortable with. And opening, obviously, overdose prevention centers is very uncomfortable for some groups, and obviously will make police feel very concerned as well. But I'm fortunate. I've had a lot of conversations with American police colleagues, and after kind of tearing away some of the misconceptions, I've often been able to convince them that, like, hey, maybe you should get on board and give it a try. Maybe it might work for your city.
And I will thank you for referencing that the Canadian police chiefs and the British Columbia chiefs came out in support of these centers. That's a really significant piece, and I think would be for us here. Certainly we have federal restrictions that impact. One last quick question, and I thank my colleagues for their indulgence. I've been mostly quiet today, but I really am curious. In your community, do you find that people are able to talk more openly about the kind of deaths? I think that our New England sensibilities in general, and I think this is true in many places, there's a lot of stigma and shame. And overdose deaths impact across the board. Is that something that you find within your community? Is there an open kind of conversation about this?
think because it's so widespread, as I mentioned, because so many people are affected, that it's almost like the curtain has been flung aside, and we're taking a realistic look at the fact that, again, people are dying from drug overdoses that come from all walks of life. It doesn't mean that you're a street and trench drug user. It could be that you're a blue collar construction worker, but you became addicted to opioids because you injured your back and you got prescription pills, and we all know that story. White collar, blue collar, and everybody in between is affected by this. And so, yes, the sensibilities have changed on two fronts. One, on addiction, and that we need to be far more accepting of people who have addiction, and treat it much more like when we have a colleague who, say, is addicted to alcohol. We're trying to manage that stigma with the same lens as the stigma, or get rid of that stigma when the person is addicted to heroin or opioids or prescription pain medication. And we're also concurrently working on, and I hope you are as well, on using the same lens when it applies to mental health and mental health treatment. And we see that in law enforcement all the time, where the stigma about mental health treatment is really evaporating, and we're becoming much more engaged in that on positive fronts. So mental health and addiction go hand in hand. So I think there's a bit of like a new horizon and a new enlightenment happening in many professional circles, and certainly here in certain Canadian cities. And I hope that you're experiencing it as well in Connecticut.
I want to thank you very much for your testimony. Indeed, I think there is a lot of shame and blame when it comes to addiction, and we have a lot of work to do to continue these conversations openly. And I appreciate our colleagues here today having this conversation. I think we heard an earlier statistic from Ms. Evans that I believe it was 90% of those who struggle with addiction are currently not in treatment or recovery. And again, you've heard me do these PSAs as we have these public health meetings. Help is available, and all of us here around this table and in this room are here to help support those who are taking that journey. So thank you so much from across the miles and the time zones being here with us today. We appreciate it.
You're very welcome. Thank you.
Next on our list is Adriana Larson. Ms. Larson, we are happy to have you here, but we are having much difficulty hearing you. If you are able to adjust your sound, we would be most grateful. We'd love to hear what you have to say.
I apologize. Is that better?
That's much better. Thank you.
Hi, bud. I'm so sorry. Is that better?
Yes, we can hear you now. You were freezing a little bit. So are you able to proceed?
Yes, I am. I apologize for that.
Go ahead, please proceed.
Thank you. Thank you. Good afternoon. My name is Adriana Larson. I'm a resident of Danbury. I work as a registered nurse in Danbury Hospital, and I would like to offer testimony in support of SB 1067, an act concerning adequate and safe healthcare setting. I have been a nurse in a hospital setting for more than 15 years. I started my career for a decade on a cardiac telemetry unit and then switched gears and currently work on a maternity unit. I take a lot of pride in my job and the care that I provide to my patients. I have what I consider to be a heavy responsibility of caring for new parents and their babies. I spend a lot of time at the bedside, educating and empowering parents to ready them for the daunting task of bringing home a new baby. Last year, I was awarded the
Oh, there we go. Go ahead. We can hear you again.
Last year, I was awarded the Daisy Award for Extraordinary Nurses. The award is described as a way to honor the superhuman work nurses do for patients and families every day. It was an honor to receive the award as a result of a patient recognizing work that I had done, but I can assure you I'm not trying to be superhuman. I hug and support parents whose baby is sick and is in the neonatal ICU. I've cried with a father whose wife became unstable after the delivery of their baby and was in critical condition. I want to come to work each shift and feel I can meet and exceed my patients' needs. When my ratio is appropriate, I'm able to fully support my patients, both with excellent medical care and emotional and educational support. When staffing is not adequate, it feels as though I spend my day rushing around, only able to focus on finishing the next task, and at the end of 12 hours, feeling so defeated. With support of this bill and a move towards safe, consistent staffing ratios, nurses like myself can feel accomplished each shift, knowing I was able to meet the medical and psychosocial needs of my patients. I don't want to be superhuman. I just want to do my job really well. I urge you to support this legislation. Thank you so much for the opportunity to testify. I would be happy to answer any questions.
Thank you so much. We appreciate your persistence in dealing through those technological challenges. And again, as I said, Danbury Hospital, there you go. It's wonderful to have you here, and seeing and hearing no questions. We hope you have a wonderful evening, and we're going to go next to Crystal Myers, who I believe is here with us in person. Welcome.
Good afternoon. My name is Crystal Myers, and I'm a Doctor of Nursing Practice student at the University of Connecticut. This testimony on Senate Bill 1067, an act concerning adequate and safe healthcare staffing, is a reflection of my own beliefs and not those of my program or university. I've been in healthcare for 16 years, first as a CNA and then as an RN for the last 5. I have a picture of myself when I was 3 years old in scrubs that said nurse in training. My grandma was a nurse, and I knew from a young age that is what I wanted to do. In my senior year of high school, I took a CNA course and became a CNA at 17. I love nursing, but I left bedside because in the moral distress, burnout, and realization, I couldn't be the nurse I wanted to be. When I graduated on my floor, the nurses were there for 20 years. They taught us things that a book never could. And now you see nurses who are being precepted by nurses who have less than a year experience. It's not sustainable. Nurses are leaving the bedside because our patients deserve better. In the DNP program, we're taught how to analyze the research in the field and use critical thinking to solve the problems that we face. Hospitals in Connecticut state they have instituted tuition reimbursement plans, sign-on bonuses, retention bonuses, and pay increases. But what they have not addressed is the working conditions. It would make sense if the current recruitment and retention practices aren't working, you look for different options. If you dive into the nursing literature, this problem has been ongoing for decades. Many hospitals are placing the blame of short staffing on not having nurses to hire, but we don't have a nursing shortage in Connecticut. We have a shortage of nurses willing to work in the environment. While the state has increased the available spots in nursing programs, if we cannot retain these nurses at the bedside, the efforts and investments are wasted. In fact, many of the concerns of the hospital with this bill are addressed in nursing literature and provide solutions for them. I've submitted written testimony, so I'll just give a brief overview of the benefits of safe staffing. The research shows for patient outcomes, less hospital-acquired infections, lower readmission rates, fewer medication errors, less patient falls, lower instances of skin breakdown, and lower mortality rates. And the benefits to nurses include less burnout, less job dissatisfaction, less likely to experience verbal abuse, and less likely to want to leave their current job. They're also 31% less likely to experience an occupational injury after the nursing ratios were implemented in California. Through nursing research, it's simple to see the benefits to our patients and our communities far outweigh the fiscal burden to hospitals. While I will not ignore the additional cost to
Excuse me,
hospitals.
Ms. Myers, but your time is up. Thank you.
Thank you. If you can just finish your sentence, that would be great.
I question how research is available to support safe staffing, and yet as a society, we are putting a monetary value on human life by ignoring it.
Ms. Myers, I want to thank you. And I know that this is a hard conversation, not just for you, I think for so many other people, because it has been nurses' lived experience through the trauma of COVID, and all of you in healthcare have been through things that most of us here around this table, with a few exceptions, we can't really imagine. So I want to thank you for your courage and your time here today. Thank you. Next on our list is Jim Williams. Mr. Williams, I believe, is online.
Yes, hello. My name is Jim Williams. I'm the Government Relations Director for the American Heart Association in Connecticut.
We can't see you, Jim. I don't know if your camera's on or if you're able to turn it on, but we can, oh, well, your picture.
Yeah.
It's dark.
I
but
apologize.
We can hear you, so go ahead. Please proceed.
Okay, one second. So again, my name is Jim Williams. I'm the Government Relations Director for the American Heart Association in Connecticut. And I'd like to thank the leadership and members of the Public Health Committee for providing me with the opportunity to offer comments on House Bill 6914, which is the use of funds in the opioid and tobacco settlement funds and funds received by the state as part of any settlement agreement with a manufacturer of electronic nicotine delivery system or vapor products. First, we applaud lines 174 to 176, which propose deleting support and encourage development of programs to reduce substance abuse and develop and implement programs to meet the unmet physical and mental health needs of the state. The funding that goes into the Tobacco Health Trust Fund comes from either tobacco sale revenue or from the Tobacco Master Settlement and should rightfully only be invested in tobacco control, which is education, prevention, and cessation. Second, we recommend that the committee consider deleting line 7, which states 12 million, and insert 22,700,000. The reasoning for this suggestion is that 22.7 million is the minimum amount that the CDC recommends Connecticut spend on tobacco control, and it is the amount that was substituted in the House Bill 6488, which was passed by this committee back on Monday, March 20th. Finally, I had suggested in my written testimony that the committee consider deleting line 14, which states under 21 years of age. The reason for this consideration is that Juul, electronic cigarettes, and other vapor products have addicted adults as well as kids. However, after hearing from the Attorney General's office, we would like to withdraw this suggestion. The multi-state investigation uncovered Juul's predatory marketing to kids, and the settlement money is intended to try to undo some of the harm they caused the population. At this point, I'd be more than happy to answer any questions that you have now or either later.
Mr. Williams, as part of the big three, as I call you all, I'm grateful for your work with the Heart Association. And I also want to particularly thank you for your communication with the Attorney General's office in helping us to make sure that we craft the best bill that we can. And I hear what you're saying about us being consistent here in the Public Health Committee and asking for that 22.7 million, which is that CDC minimum. So duly noted. Seeing no questions, let me just double check Zoom here. Nope. Mr. Williams, have a great evening. Thank you so much for your testimony.
Thank you.
Next on our list is Michelle Leese. Welcome.
Good afternoon, everyone. My name is Michelle Liss, and I'm the outreach coordinator. Can you hear me? Okay. I'm the outreach coordinator for liberation programs in Bridgeport, Connecticut. I've been a resident of Milford, Connecticut for 18 years. And I'm testifying today in support of Bill 9, Section 4 and 5, the establishment of harm reduction centers. I support this bill because people are suffering and dying alone because of stigma. I'm a person with 2.5 years in abstinence-based recovery and have come to understand the need for multiple pathways of recovery, of which harm reduction is recognized by SAMHSA as one of the pathways. I work with individuals every day who are not ready, willing, or able to go to treatment. I work with those who are actively using drugs, but are embracing the safer, more efficient, and practical ways of using drugs. The establishment of harm reduction centers would greatly improve their lives and the lives of many others who are hiding drug use due to tremendous stigma. People are needlessly using and dying alone. I urge you to embrace harm reduction as a pathway to recovery, as the current system of abstinence-based recovery is missing the mark with so many people. I appreciate your time today, and I'm asking you to please support this bill. I'd be happy to answer any questions.
Michelle, I was making the face because I mispronounced your name. So
That's okay.
Thank you very much for your testimony, for your work with liberation programs, and also for sharing your personal story and reminding us of the need for the many pathways and that harm reduction model as part of it. Seeing no questions or comments, we wish you a wonderful evening, and we will go next to, I believe, number 64. And that is Amanda Hutchins Warren. Welcome.
Hello, hi. Senators, representatives, members of the Public Health Committee. My name is Amanda Hutchins Warren. I am a resident of Reading, Connecticut. I've worked as a registered nurse at Danbury Hospital since 1995. So I offer the following testimony in support of SB 1067, an act concerning adequate and safe healthcare staffing. So I'm going to start with the bad news. Let's get that over with first. So I feel that Connecticut hospitals are heading over a cliff when it comes to RN staffing. Now, I'm the chair of my hospital staffing committee, and I'm here to describe as best I can the state of affairs. Now, that view from the hospital bedside, it's not a pretty one. At my hospital, we are even a transfer center for a network of 7 hospitals. So patients come despite the fact that our nursing workforce is way overstretched. We admit them and we have to care for them. Now, the first concern for any nurse is the patient. It's just how we are wired. You know, they deserve not just minimal care or borderline care, but great care. Life should not be put at risk. Now, so many of us leave our shift, we're deflated, we're frustrated due to the volume of patients. We can only do what is humanly possible, even if we're still there well after our shift should have been over. High acuity levels and high patient ratios prevail here in Connecticut. And as I've said, I am the chairperson for our staffing committee. It's my role to be an advocate for the bedside nurse. And I'm therefore very well aware of the RN patient ratios, the plethora of documented concerns over short staffing assignments, because I read them all, and the exodus of staff. But the optics get really poor when leadership makes a choice, as they sometimes do, to take away a scheduled nurse. It's a move called downstaffing, and leave us a unit understaffed. Now, we have a staffing plan, and hence we have a staffing goal. So to choose not to meet that goal when you can is something I lose sleep over. That and a few other related issues, maybe like all those documented forms I review. So RNs can only be overburdened for so long. And then they start looking to take their skills elsewhere, and it's usually away from the bedside hospital settings. We even have Connecticut nurses going over state borders for better staffing ratios. So we need to do something. We need to bring them back to the state. We need to entice them back to the bedside and keep them there. Better working conditions are an absolute must. The
Excuse
patient
me, Ms.
safety
Hutchins
is.
Warrens, your time.
That's fine. I just want to point out patient safety is the priority. But finally, the good news, we have this bill before you, SB 1067. Let's take a stand for adequate, safe staffing. We need a qualified workforce for the future, 24/7. I urge you to support it and happy to take any questions.
Thank you, Ms. Hutchins Warren. We appreciate your work and your time here before us and your testimony. Seeing and hearing no questions or comments, we will be going back to someone who actually was here in the room with us. And is in the room with us, Steve Werlin. Welcome.
Thank you, and I apologize for throwing you a bit of a loop there. Good afternoon, everyone. My name is Steve Werlin. I'm a resident of New Haven, and I'm grateful to be here to offer my support for Senate Bill number 9, specifically sections 4 and 5, concerning the establishment of harm reduction centers, or otherwise known as overdose prevention centers, OPCs. I have the honor of working for New Haven's Downtown Evening Soup Kitchen, or DESK. DESK has been serving people experiencing homelessness for nearly 4 decades. Today, our program serves more than 900 unhoused individuals annually. Although substance use has played a determining role in our work since the 80s, the recent spike in fatal opioid overdoses has really shaken us to our core. Since early December, my heroic staff have saved the lives of 8 people in and around our building by reversing overdoses through the use of naloxone or Narcan. Among the first overdose reversals in this most recent wave involved staff who had just gotten off their shift and were heading toward the train station when they discovered a client of ours who they had just seen a few hours before sprawled out on the sidewalk. Just as they had been trained, the 2 of them assessed the situation, called 911, grabbed their Narcan kit, and administered it long before the EMTs arrived, saving this man's life. While this quick action from our team was impressive and laudatory, the situation was sadly not unique, nor was what happened the next day. The man whose life had been saved returned to our drop-in center for services. It should go without saying, but I'm going to go ahead and say it anyway. We can't improve the lives of those we serve if we can't first save the lives of those we serve. Our clients need to be alive for us to actually help them. This man's life was saved by well-trained staff, but also by dumb luck. He's alive because he was found in the nick of time. 2 nights ago, another member of our community was less fortunate. His body was discovered outside a methadone clinic where by day he was accessing services, and outside of which by night he was sleeping, trying to stay warm by the HVAC vent. At this point, it's unclear if he died from an overdose or endocarditis, a bacterial infection of the heart, which frequently occurs in those using injection drugs. In either case, a local OPC, overdose prevention center, where he could have tended to his addiction disorder in a medically supervised environment would have saved this man's life. Instead, he is now one of the nearly 2,000 people who will die in Connecticut this year because of opioids. Overdose prevention centers, as outlined in section 4 and 5 of SB 9, could be a key strategy in preventing these deaths by putting in some much needed guardrails. As is too often the case, the US lags behind its economic peers in progressive approaches to healthcare. For decades, OPCs have been saving lives across Europe, Canada, and Australia, as we've heard about today. And in the fall of 21, the first officially recognized OPC opened in New York. At the close of its inaugural year, On Point New York has saved more than 600 people. I think someone said 700 earlier today, from what would have otherwise been fatal overdose, as well as an estimated $12 million in emergency medical services. OPCs offer a proven and safe strategy to reduce deaths, improve lives, and save the taxpayers' dollars. That is why I urge you to make Connecticut a leader in progressive healthcare by supporting SB 9's call for an OPC pilot program. Thank you.
Thank you very much, Mr. Werlin, and I'm very sorry and sad to hear the loss of a member of your community, and want to thank you for the good work that you're doing in New Haven and for your time here with us today.
Thank you.
Seeing and hearing no questions, I appreciate you being with us today. And next, we are going to go to Logan Place.
Good afternoon, everyone. My name is Logan Place. I am a field representative for AFT Connecticut, where I represent healthcare workers, and I'm here to testify in favor of SB 1067. I also work for CBAC and would like to note that CBAC supports this bill as well and has submitted separate written testimony. I'm here to specifically address the portion of 1067 that relates to mandatory overtime. I'm not going to talk about how mandatory overtime is unsafe for nurses and patients alike, or how it is burning out nurses and driving them to leave the profession. I'll leave that to the nurses who can tell you firsthand. Instead, I'll testify about why the current mandatory overtime law is inadequate and how this bill will address those inadequacies and put Connecticut in line with other states with mandatory overtime laws. When our mandatory overtime law was passed in 2004, it was a step in the right direction. But nearly 20 years later, it is outdated and one of the weakest in the country. SB 1067 establishes the maximum hours a nurse can be forced to work and establishes a minimum rest period after a shift. The current law only prohibits hours above a predetermined scheduled shift. So, for example, the current law would not prevent a hospital from scheduling a nurse to work 16 hours a day, 7 days a week. A peer-reviewed study concluded that maximum hours legislation does a better job at limiting the number of hours nurses work, which in turn is correlated with improved safety for patients and staff. Including maximum hours will put Connecticut in line with other states. At least 14 of the 18 states with mandatory overtime laws place a restriction on the number of hours a nurse can be forced to work in a day or week, and at least 9 of those establish a minimum rest period. This legislation is not novel. It is common sense legislation that many states, including Rhode Island, New Hampshire, Massachusetts, Alaska, West Virginia, and Missouri, have all successfully enacted. And in fact, many hospitals in Connecticut already don't use mandatory overtime. This legislation would also remove the exception which permits mandatory overtime when permitted by a collective bargaining agreement. Patients should not be put at higher risk because an employer forces mandatory overtime into a contract. To be clear, this bill does not prevent a nurse from volunteering to work overtime if the nurse feels it is safe, but that decision should be made by the nurse, not hospital administrators. Nor does this bill prevent mandatory overtime in emergencies. Everyone understands that given the nature of healthcare, mandatory overtime is sometimes unavoidable. But those instances should be a rare exception. This legislation will simply require hospitals to seek volunteers and make a good faith effort to find a reasonable alternative to mandatory overtime when such emergencies occur. The current law works for health chain executives, not for patients or their caregivers. Connecticut will continue to lose nurses if we do not protect them from abusive practices and ensure safe patient limits. Thank you for this time, and I would be happy to answer any questions you may have specifically relating to the mandatory overtime provision of the bill.
Mr. Place, thank you very much. Representative Claritas Detria.
Thank you, Madam Chair. Thank you for your testimony today. You had mentioned at one point in your testimony that not many hospitals use mandatory overtime in Connecticut.
I believe I said many do not, but yes.
Do you have any idea which ones do?
I know of some that do. I would not be able to provide an exhaustive list of all that do. I know that Bacchus Hospital uses it frequently. I know that UConn Health uses it frequently. Up until recently, Wyndham used it frequently. I cannot, there may be more. Those are the ones I know of.
Okay. All right. Thank you, Madam Chair.
Thank you, Representative. Seeing and hearing no other questions, thank you for taking the time to be here with us today and for sharing what you did. Part of the conversation we haven't talked as much about today, so I appreciate that.
Thank you.
Next, I believe is Kathleen Nix here with us. Oh, wonderful. Welcome.
Thank you. Good afternoon, members of the Public Health Committee. My name is Kathleen Nix. I'm a resident of Bethel, and I work as a bedside nurse, a pediatric nurse in a 6-bed unit at Danbury Hospital. I offer the following testimony in support of SB 1067, an act concerning adequate and safe healthcare staffing. I support this bill because I support our community in the greater Danbury area. Most of all, I support children. Children are our future, and we must address their healthcare needs. Danbury is a very vibrant, multicultural, and diverse community, and we are growing. Our pediatric department is the only standing unit between Stamford and Waterbury. Yet children are traveling to Farmington for diabetic teaching. Sometimes families in our area do not have the means to travel that far due to lack of transportation. Sometimes their diabetic needs are not met and they are readmitted to the pediatric unit or the ED. Sometimes these children, well, what I call them, are very vulnerable. They are the most vulnerable. They need our care and they need that care. That care needs to be delivered in the community in which we live. During the recent healthcare crisis of RSV, I'm reflecting back, we worked together on our unit cohesively to give the best care we could. Sometimes we needed to take overflow from New Haven, Yale New Haven and Hartford. And at times we needed to transfer to their higher level of care. Yet sometimes beds could not be found for these children. Was it a bed that could not be found? Or was it a nurse at the bedside who could not be found? The question is rhetorical, but it does emphasize the point that we need safe patient ratios. I support SB 1067 because we need to keep nurses at the bedside. And we need to take care of our most vulnerable patients. This also includes our elderly population on the floors. I urge you to support this legislation. If this bill is passed, it will ensure that all nurses in Connecticut will have adequate patient care and adequate nurse-patient ratios. It will bring more nurses into this state. This means we can expand care to serve all our communities better. Thank you for this opportunity to testify. I would be happy to answer any questions you may have.
Thank you very much for your powerful testimony. And again, I keep referencing that Danbury team, but you clearly have quite a team there. Seeing and hearing no questions or comments, thank you for being with us, for your time. And I hope you have a wonderful evening.
You too.
We all do. Next, I believe we have Christina Captain. Is Christina here with us? Okay, if not, Mr. Joseph Lee.
Hello,
Welcome, please proceed.
my name is Joseph Lee, and I'm a critical care nurse and charge nurse at Middlesex Health. I'm here to testify in opposition to SB 1067. As a charge nurse, I have an understanding of the patient's clinical well-being, and when I make the patient assignment, I match the patient's acuity to the nurse's competency. Making a patient assignment is a complex process. It's not simply about determining ratios or numbers of patients. For example, I consider patient acuity, RN knowledge, isolation, geographic location of patients, fall risk concerns. Nursing needs autonomy to make assignments based on acuity versus ratios. Staffing is an incredibly complex and dynamic process, and nursing professionals are able to make these manage these complexities. Ratios are rigid and costly and will not improve care. The day you start off with is very often not the day you end with in critical care. There are many on-the-fly decisions being made depending on new patients and increase in acuity for both new patients coming in as well as patients currently admitted. SB 1067 sees healthcare and staffing ratios as a clear-cut and cookie-cutter type scenario, when in fact it's very much a gray area. Currently at Middlesex Health, we have 3,600 employees across the organization with 50 openings in the nursing position. SB 1067 puts pressure on the organization to create staff when there is none. There is a system-wide shortage of nurses. A bill does not change the reality of the scenario. We make it our mission to provide the safest, highest quality care and the best experience possible. Thank you for considering our position.
Thank you very much for your time and testimony today.
Thank you.
And hearing no questions, we will next go to number 73, Nancy Kaplan.
Hello, good evening, and thank you for hearing my testimony. I am here in support of 1067. I have been a nurse for over 42 years, have worked in federal and public and private institutions. I retired from Yukon Health in 2017 after 22 years there. And the reason that I left the bedside was because of lack of support from nurse management and for the moral distress that I experienced because I could not care for my patients the way that they needed to be cared for. I went into nursing to take care of people in the same manner that I would want my family member to be cared for. So when I have your husband in front of me, I'm caring for him like he's my husband, like he's my brother, like he's my father. And unfortunately, with the lack of staffing ratios, we do not have that option anymore. I was able to reset myself and realize that I am a nurse at heart. So I went back to nursing in 2021, and it was during the COVID pandemic. I found that working in a smaller community hospital gave me the opportunity to work with patients who had less acuity. And at that point in time, we had what I would consider adequate staffing. However, as the year has gone by in this small community hospital, I frequently find myself with no one to watch the monitor, no one to help me as a CNA, and also as the only nurse on the ICU and the only intensive care nurse in the hospital. Now, this has created some very, very scary events in our hospital. We have had patients who have coded with only one nurse on, where the code blue has not been responded to by administration or by doctors or by people in the ED. And this is totally unsafe. And if we had minimal staffing, I believe we would have had the 2 nurses that we needed to initiate the code, care for that patient. And I hear a lot of discussion here on this forum today about staffing committee meetings. I'm not 12 and I understand what good staffing looks like. I have spoken with administration on numerous occasions only to be told that, well, of course I could take 4 level 3 patients because this nurse director had taken them, and of course this medication that I'm giving is not a vasoactive drug. I am critical care certified. I am ACLS certified. I know which drugs are vasoactive, and I'm not receiving support from administration. And I'm not sure if it's because they have not been at the bedside for such a long period of time, or because the bottom line is they don't have the staff. I implore you
Excuse
to
me,
put in
Ms.
staffing.
Kaplan, but your time is up. Thank you.
Thank you, Ms. Kaplan, and thank you for your testimony, for your time here with us today, and for all of the work that you've done. I was struck by your comments about the moral hazard and have seen that in some of the emotion expressed in testimony today. So I thank you for taking time to be with us. Next, we are going to go, I believe, Amanda Guarnier. Let's see if I got that right.
Hello, thank you so much to the leadership and members of the Public Health Committee for allowing my testimony today. I'm speaking in support of SB 1228, speaking specifically regarding APRN collaboration, and would like to start off by saying that this is not a scope of practice issue, but rather an access to care issue. My name is Amanda Guarnieri. I am a resident of Reading, and I've been an advanced practice nurse since 2011 when I graduated from the Yale School of Nursing. I completed my education here in Connecticut and after moved out of state due to my husband's relocation. And after 10 years away, we moved back to Connecticut in 2021. When I applied for my licensure in 2021, I learned that Connecticut also has requirements for physician collaboration. I assumed I would be exempt from this requirement since I had been in practice far beyond the required practice hours and already had been approved for independent practice in the state of New York. I soon was surprised to learn that any newly licensed APRN in Connecticut needed this requirement of collaboration, regardless of their practice hours or years of experience in another state. In 2022, I connected with my former faculty advisor from Yale, who invited me to come work at her private practice part-time. She's owned the practice for many years and is approved for independent practice here in Connecticut, so she does not have a formal relationship with a physician. In the search for a collaborator for me, she reached out to several of her physician network colleagues, none of whom were interested. Meanwhile, I had a call with a company that provides collaborating physicians for a fee. I was quoted $750 per month, which wasn't much less than I'd be making in this part-time position. I was then advised by another colleague to contact the Medical Society, as she thought they were supposed to be able to connect APRNs with physicians for collaboration. I reached out several times to the Medical Society with no response. I ultimately ended up getting a per diem position, a different role that I knew provided a collaborator, and I contacted that physician and asked if I could hire him privately to collaborate with me for my other position. He agreed, though I did have to cover his malpractice insurance and pay the legal fees for our agreement. This ended up being an investment of several $1,000s, in addition to the several hundred I pay him monthly to collaborate with me remotely and formally for my 1 day a week per work. Meanwhile, the practice owner, an APRN, is my first line of defense when I have questions regarding practice here in Connecticut. She herself is on the State Board of Nurse Examiners and has been an APRN for as long as my collaborator has been a physician. Ultimately, this process has seemed completely unnecessary and has been a huge barrier to me providing access to care for patients here in Connecticut. The practice owner has offered the opportunity for me to work additional hours to see more patients, but every additional day I work, I will need to increase my fee to my collaborator per our agreement, making me question whether it is even worth it to continue this work. I strongly encourage the state to consider allowing APRNs to collaborate for each other here in Connecticut, as we have broader networks with one another. We are familiar with our own practice statutes, and we will not take advantage of those needing collaboration through requiring high fees. Thank you for the opportunity to provide this testimony. I'm happy to answer any questions.
Thank you very much for your time and testimony today. Representative Clara DeStitria.
Thank you, Madam Chair. Thank you for your testimony. Can you clarify, you mentioned that you had to pay an APRN for your collaboration monthly? Can you?
I'm sorry, no, I pay a physician monthly for my collaboration because we're not allowed to use APRNs as our collaborators at this time.
Okay, so and is that because you're coming from another state?
Right. So since I'm a newly licensed APRN in the state, regardless of how many hours I have elsewhere, newly licensed APRNs require 2,000 hours of practice and 3 years of collaboration with a physician before we can be approved for independent practice.
And you have to pay them monthly, you said?
Yes, because I couldn't find anyone who would do it without charging me, because I don't have any physician friends or any physician colleagues who are able to provide that for me.
And do you know, for the people out there listening, is that typically what happens? You have to pay a physician?
Yes. Yes, unless you work with a physician in your practice already. So if it's a physician-owned practice, or you work for a large organization that also employs physicians, sometimes they will be provided to you. But in situations like mine, when I'm working in a small private practice that also happens to be owned by another APRN, really the only option is to hire a physician privately.
Okay, thank you for the clarification. Thank you, Madam Chair.
Sure.
Thank you, Representative Clara DeStitria. Thank you so much for your time and your testimony today.
Thank you.
Next on our list is Cameron Breen. Welcome. Please proceed, sir.
Good afternoon, everyone. Thank you for having me. My name is Cameron Breen. I'm a person in long-term recovery, and I am the current harm reduction coordinator for McCall Behavioral Health and previous overdose response technician for the Waterbury Public Health Department. I'm here today to show support of SB 9, sections 4 and 5 regarding harm reduction centers. I worked with the Waterbury overdose response team for roughly 2.5 years, and attempted to connect individuals to services, responding directly to the scenes of overdoses with officers, and connecting those individuals with services after the overdose had occurred. During that 2.5 years, I responded to roughly 700 people for overdoses, most of which in person. I'm thinking about the amount of overdoses that I've seen with my own two eyes. It is not a struggle for me to support the harm reduction centers and overdose prevention centers within our state because they are a realistic approach to addressing the overdose and opioid epidemic within our state. I'm curious, when thinking about the number of individuals in this room or watching that know someone or know someone who has lost a loved one due to overdose that died alone. That is precisely where overdose prevention centers or harm reduction centers come into play. When looking at the data for 2021, we can see that 91% of fatal overdoses happen when the person was using alone. The center provides a space that acts as an intervention to the occurrence of a fatal overdose. The sites are not condoning nor promoting the use of substances, but providing a last defense for someone who has lost the power of choice in continuing to engage in substance use. Another piece of importance that these centers bring is the reduction of stigma surrounding substance use. The current systems that we have in place disconnect individuals who use substances from anything human. And when individuals have nothing left to connect with, they will use drugs until they die. These centers are spaces where individuals who use drugs can come to feel like people and be treated like people. People who use drugs have been, for the most part, entirely erased from the societies that surround them. A person can come to an overdose prevention center for clean supplies to use safely and not die from a potentially fatal overdose, access health, wellness, and supportive services. I feel that it is important to mention that the New York's current overdose prevention center since November 30th, 2021 has worked with 3,089 participants, had 819 successful overdose interventions, and not one single death. I think it is important to stress to you, and thank you all for having me here so much, that overdose prevention centers are, quite frankly, the least we can do for an entirely marginalized population that exists within a system of services that do not currently meet their needs. And this is made evident by the 4 people who died daily for the entire year of 2021. I'm happy to answer any questions, and I want to thank you so much for having me here today.
Thank you so much. Thank you for your work and for your powerful testimony today. I appreciate you again speaking to the issue of stigma and also recognizing the marginalization of many of the folks who are facing addiction. Seeing no comments Representative Reddington Hughes.
Thank you, Madam Chair. My question has to do with the OPCs obviously are serving a purpose for the addicts who are in desperate need of really connecting with people and really maybe opening that door for them to seek some help, but not necessarily. If you saw this as the first step on a road to something that was bigger and better, what would this lead to?
So what this leads to is kind of a little bit about like what Liz Evans talked about before, is that if they come into this open space where they feel connected and that all these other people care about them, when they probably have a hard time looking in the mirror, if they even have a mirror to possibly look into, that they feel connected to something. And it starts this small continuum of care that allows individuals to be connected to anything that they possibly need. That's wound care to start, that's wellness and support services, that's clean supplies, that's being treated like a human being. And then further down the line, I mean, when we look at this totally, I think everyone who exists within the addictions field doesn't necessarily feel like they only care about individuals who are not using drugs. They care about the individuals who are and the individuals who aren't. But if we do not incorporate different and new systems like this, basically, I think what we're saying is that we only care about you if you're not using drugs. And it starts this continuum for them to be connected to any sort of care that they may need to keep them alive long enough to enter those systems of care. And that is that beginning step into kind of addressing this larger concern that we have, where individuals aren't able to be connected to the services that they need.
Oh, thank you very much.
Thank you, Representative Reddington Hughes. Seeing no other comments or questions, thank you very much for your time with us today. Next on our list, I see Dr. Michael Crane.
Senator Anwar, Representative McCarthy Vahey, Senator Summers, and members of the committee. My name is Dr. Michael Crane. I'm a radiologist practicing in a shoreline town in Connecticut, and I'm the immediate past president of the Radiological Society of Connecticut. I appreciate the opportunity to offer a few comments on House Bill 6894, an act concerning certificate of need. The bill would direct the Office of Healthcare Strategy to review the CON program and report back to the General Assembly with their recommendations. As you continue to discuss this issue, I would urge you to retain the requirement that an entity obtain a CON before acquiring imaging equipment such as MRI, CT, or PET scanners. Under the current CON program, patients can get these exams at high-quality centers, many of them being full-service imaging centers, which also provide other lower-cost imaging exams, such as X-ray, mammography, bone density, and ultrasound. The current CON laws help limit the costly duplication of services and protects the small, full-service imaging centers throughout the state. These full-service imaging centers depend on revenue from the higher cost CT and MRI exams in order to provide the lower cost exams such as X-ray, ultrasound, and mammography. Without our CON laws, freestanding MRI centers, as well as MRI scanners in a van, would pop up in many communities throughout our state, putting our current full-service private practice imaging centers out of business, pushing these patients to the hospital systems for their imaging needs, both urgent and screening. Thank you for considering the needs of the small private healthcare offices on this matter. I would also like to express the Radiological Societies of Connecticut's strong support for Section 2 of Senate Bill 1228. This will task the Public Health Commissioner with ways at looking at ways we can engage more people to become radiological technologists. These employees are key to our offices. They're highly trained and competent and have well-compensated careers. But there is a shortage of these technologists, and that can truly wreak havoc on scheduling our patients. We look forward to the ideas the Commissioner will send back to you. Thank you for your time.
Thank you very much, Dr. Crane, for your testimony. And I don't know if you were listening in earlier when we heard from Kathleen Garrity from the Dental Association and the request to have a change in language there so that we can get more folks trained and in. And I think you're speaking in support, and I think it's important for us to hear that as the Radiological Society, you are supportive of this.
Yes, we are. Yes, thank you.
Thank you for that. That's very helpful. So hopefully we can make some changes to the bill in that regard. Thank
That'd be
you.
wonderful.
Seeing no other questions or comments, we are going to go next to, I believe, Theodora Serrata. Is Theodora here? Yes, wonderful. Did I miss someone? Okay, we will go back to number 79. So please come forward. Mr. Brown, just hang on. We'll get right back to you.
Okay.
Thank you.
Senator Anwar, Representative McCarthy Fahey, and members of the Public Health Committee. My name is Dr. Theodora Sirota, and I am here in support of SB 1228, requested language related to the APRN workforce concerns. I am a full professor of nursing at the University of St. Joseph, where I am also track coordinator for the master's and postmaster's certificate programs that prepare nurses for practice as psychiatric nurse practitioners. I hold a master's degree in psychiatric mental health nursing, a PhD in nursing research, a postmaster's psychoanalytic institute certification, representing 4 years of intense training as a psychodynamic psychotherapist. I have held an APRN license in my prior home state of New Jersey for over 20 years, and I conducted a successful independent psychotherapy practice in New York and New Jersey for over 40 years. When I relocated to Connecticut to assume my current academic position, I was granted an APRN license here by reciprocity. It was my intention to open a part-time psychotherapy practice in the West Hartford area. However, I was surprised and frankly shocked to discover that I could not do this without first completing 2,000 hours under a collaborative agreement with a physician, despite my years of intense training and practice experience. I eventually found a psychiatrist who said that she would sign the collaborative agreement in exchange for my teaching her more about psychotherapy. Although advanced practice registered nurses are independent healthcare providers in the state of Connecticut, under current law, this can be achieved only after completing 2,000 hours and 3 years of collaborative practice. Experienced APRNs from other states, like myself, that want to open practices in Connecticut currently need to get a new collaborative agreement with a physician, even if they already meet Connecticut's clinical experience requirements. This represents a major barrier for many APRNs to move or work in Connecticut. In my opinion, no experienced clinician should be required to undergo 2,000 hours of often very costly collaborative practice to be able to continue to provide the same quality, high quality, and desperately needed mental health services that they have been providing elsewhere for many years. I'm requesting language to be included in the statute that would grant full reciprocity for our APRNs from other states by considering clinical experience from out of state toward Connecticut's experience requirements for independent practice. Senate Bill 9, Section 2.2 proposals only address licensure and not collaboration, so it does not fix the reciprocity issues. Needed updates to the statute will remove this barrier to APRNs practicing in Connecticut and will make Connecticut more competitive with our surrounding states that do not require physician collaboration and therefore can better attract out-of-state APRNs. This
Ms.
update
Sirota?
would not change the services we provide, as psychotherapy falls under our APRN scope of
Ms.
practice.
Sirota?
Thank you.
Excuse me, your time is up.
Got it.
Thank you very much. So just to clarify that last piece that you were talking about, you're saying that what your concern is that the language addresses the licensure, but not reciprocity. So you'd like to
That's
see
correct.
amendments. Okay, thank you.
Thank
Are
you.
there questions? Comments? Seeing none, thank you for being here with us today. We are going to go back for a moment. I believe we have Mr. Brown to be followed by Megan Atencio, if I'm saying that correctly. Mr. Brown, welcome. Please proceed.
Thank you. Good evening, Chairman Anwar, Chairman McCarthy Vahey, Ranking Member Senator Somers, and Representative Clarides Ditria, and the other honorable members of the Public Health Committee. My name is Edward Brown. I'm the Chief of Service and CEO of Stanford Emergency Medical Services, or Stanford EMS. Prior to my current position, I was the Assistant Chief for 20 years. I'm here to share mine and my colleagues' concerns about Senate Bill 1067. Stanford EMS has provided paramedic level emergency medical services to the city of Stanford for over 30 years. We also provide paramedic response to the town of Darien. We're a nonprofit organization serving a population of about 136,000 people. We respond to almost 17,000 emergency calls annually. That number has grown as Stanford's population has grown. Stanford is now the second largest city in the state. Stanford EMS has been nationally accredited since 2007. Recently, we were reaccredited with a perfect score by the Commission on Accreditation of Ambulance Services, and we're very proud of our service to the community. We work very closely with Stanford Health and bring over 12,000 patients to the hospital's emergency department every year. Stanford EMS has for decades worked with the talented and dedicated nurses of Stanford Hospital Emergency Department, or ED, and have the utmost respect for the work they do. We think it is very important that they not be pressed beyond their limits to provide quality care to the patients who present to the ED. However, we are concerned about the potential unintended consequences of legislatively imposed nurse-to-patient ratios in the ED. In order to serve the needs of the community and be in a position to respond to nearly 17,000 emergency calls per year, we need to keep our ambulances within our city and promptly return our crews to the field after safely transporting a patient to the ED. Inflexible legislative imposed nurse-patient ratios in the ED carries with it the substantial risk that Stanford Hospital ED may be forced to divert ambulances to an out-of-town hospital or have extended waiting times in the ED to transfer patients to a hospital bed whenever those mandatory ratios cannot be met. That could disrupt our operations, extend our response times, and interfere with the ability of our paramedics to respond to the next 911 call for EMS services. We strongly believe the safe and efficient staffing of the ED is an issue that should be left to Stanford Hospital's professionals. We have every confidence in their judgment and ability to implement a staffing pattern that serves the best interests of Stanford Hospital's patients, staff, and the EMS services that rely on the ED nurses for assistance in handling advanced life support calls and facilitating our paramedics with prompt return to the field. To be sure, there are times where there are surges in ED volume that create challenges for all of us who rely on the ED. But in our experience, the well-managed staff, nursing staff, and dedicated nurses we work with day in and day out are more than capable of meeting those challenges. For those reasons, I urge the Public Health Committee to give serious consideration to the unintended consequences of well-meaning legislation. Thank you, and I'm happy to take any questions.
Thank you very much for your testimony. Seeing and hearing no questions, we appreciate the time that you took today to share with us, and we wish you a wonderful evening.
Thank you.
Thank you very much. Next, we are going to go to Ryan McNeil, who I think had some Zoom issues. And I think we're now connected properly.
Wonderful.
Well, please proceed.
Wonderful. Thank you. And thank you for your patience. I'm pleased to present to the esteemed committee in strong support of SB 9 around the authorization of harm reduction centers. I'm an associate professor in the Yale School of Medicine, Public Health and Department of Anthropology, as well as the director of harm reduction research with the Yale program in addiction medicine. Before moving to Yale, I was a research scientist at the British Columbia Center on Substance Use and an assistant professor in the Department of Medicine at the University of British Columbia, where I led and still do lead a program focused on the implementation and effectiveness of overdose prevention sites and supervised consumption services more generally. My work on overdose prevention sites has been published in leading substance use and public health journals, including the American Journal of Public Health, Addiction, and the International Journal of Drug Policy. And I wish to just be upfront and be really frank. The evidence is unequivocal that harm reduction centers, overdose prevention sites, or what we should decide to call them, but these sites that provide people with opportunities to engage with services in ways that address their needs, that work to prevent overdose and respond to them, are essential elements of a multi-pronged approach to managing the harms associated with substance use. There are strong evidence from observational studies pointing to their effectiveness in addressing what commonly gets referred to as drug-related disorder, with studies showing reductions in publicly discarded syringes, public injecting, and other things commonly characterized as harms associated with substance use. These sites have been demonstrated to be incredibly effective in engaging particularly vulnerable people who use drugs, with work done at Insight, North America's first sanctioned site in Vancouver, showing astounding successes in engaging folks who are marginalized on the basis of homelessness and housing vulnerability. There's strong evidence that the wraparound supports that become part of care at these centers or as part of essential referral networks are instrumental in facilitating access to care, leading to increases in access to substance use treatment and other services that are critically important. Now, in the moment that we're in right now, where we have a drug supply that's going through an ongoing transformation characterized by the increased presence of xylazine within the local supply, Beyond overdose prevention, these are essential services when it comes to managing the severe injection-related infections and harms that may stem from exposure to xylazine, which if folks are following are now presenting in emergency departments and primary care and other settings across Connecticut. The impact on overdose deaths are well documented. It's estimated that the implementation of overdose prevention centers in really the first year of their implementation, when these were scaled up in the province of British Columbia, which is roughly the same size as Connecticut, saved more than 200 lives that year, with the upward estimate being 250.
Excuse me, Mr. McNeil, but your time is up. Thank you.
Thank you very much. Senator Anwar has a few questions for you, and I will as well.
Thank you, Madam Co-Chair. Thank you, Mr. O'Neill. I'm sorry, McNeil. I just wanted to clarify, because the data is so sound and then so significant, we still have some barriers. Do you have any insight into how can we overcome some of the financial barriers to this solution? Are there any modeling for United States specifically?
Critically, and I think quite importantly, a number of cost effectiveness studies have been done looking at the actual and potential implementation of overdose prevention centers. And they consistently have found that these are cost saving in terms of the net overall public health systems. And then that's primarily achieved through a number of different mechanisms, through reductions specifically in HIV and hepatitis C transmission, through reduction in emergency department visits due to overdose, because quite frankly, most of the overdoses that I've ever witnessed in the hundreds of hours I've spent at these sites are successfully managed on site. Collectively, the sites really pay for themselves. So as an example, there's one early cost benefit analysis done of the implementation of Insight, which indicated that even accounting for costs, it saved the local health system $6 million annually. And so quite literally, these sites pay for themselves.
Thank you. Can the towns take on some of these responsibilities? Because the ROI for the towns may be easier to manage if there was a collaboration between some state funding except for the part that is not federally allowed. If the state was helping the part that's not federally allowed and the towns were helping out the remaining component, would that be one mechanism to achieve this goal?
I mean, that possibly could. And I say that at the expense of perhaps not being the best person to comment on specific sets of funding arrangements that might be possible in this setting. At the same time, cost sharing or other agreements that involve the various partners who may be involved in site implementation would be absolutely critical. And certainly the types of savings that occur can happen across a number of systems. And again, reductions in emergency department visits or overdose, likely also due to injection-related infections, engaging the various partners who would achieve savings and who could contribute to the site, I would hope would be a pathway forward for this. And certainly there has been interest expressed at the municipal level in a handful of settings around these sites. And one would hope that there's a pathway there.
And you have a written testimony as well, right?
I don't, but I could.
If you could, the reason is that you can approach is help us for the why, and then we are looking at the how. And the why, I want to make sure that the legislators, all of us, are comfortable with the science and the rationale for it, and then we can figure out the how by working collaboratively as well. But thank you for your testimony.
Thank you.
Thank you, Senator Anwar. I'm wondering if you could just speak very briefly about xylazine. I think it was a DOJ notice that just came out related to this, and if you could just share, I think a lot of people don't know about it, and I'd love for you to just give us a brief description of what it is and what's happening.
I'm sorry, I missed your question because I got briefly booted out of the room. If you wouldn't mind repeating, I'd appreciate it.
Sure. I guess that speaks to those Zoom issues I referenced earlier, but the question was xylazine. If you could speak briefly to what's happening with xylazine. I know the DOJ just put out a notice, and I think a lot of people are not aware of it. And if you could also share what you're seeing happening with xylazine.
Yeah, so certainly. So xylazine is effectively a veterinary tranquilizer that's now consistently appearing in the illicit drug supply alongside fentanyl. And so this means that people are commonly exposed to xylazine in the course of using other drugs. And thus far, certainly clinical presentations and emerging evidence are suggesting that xylazine specifically is associated with a greatly increased overdose risk. And certainly we have xylazine showing up in overdose surveillance data in Connecticut going back several years now as a primary driver in sustained and increasing overdose death rates. The other complication that's happening, and why exactly this is happening is still being examined, but the presentation of severe injection-related infections is quite common with xylazine, placing a further burden of illness on people who use drugs who are vulnerable and injecting drugs contaminated with xylazine, as well as presenting a number of clinical challenges in hospitals across Connecticut.
Thank you for that. It certainly speaks to the fact that we are going to need to do even more to make sure people aren't dying. Thank you for your time and testimony with us today, and seeing and hearing no other questions. I believe next is Megan Atencio. Thank you. Welcome.
Hello, thank you for having me. My name is Megan Atencio, and I am a clinical nurse in the float pool at Middlesex Health. And I am here to testify in opposition to Bill 1067, an act concerning adequate and safe healthcare staffing. I did submit a written testimony, so I'm just going to summarize my thoughts. I have been a clinical nurse since 2019, and I started on our medical surgical floor and then transitioned into the float pool for my most recent 2 years. Being in the float pool, that means I work on just about every unit in the hospital, so I see firsthand how movement on each unit is really dependent on each other. And I am also the chair of our clinical practice council. This council within our hospital prides itself on having clinical nurses that drive our nursing practice. Last year alone, we've approved 64 new policies. There are other various committees in our hospital that clinical nurses can be involved in the staffing decisions. But mandatory staffing ratios will take away all of our autonomy and the authority and power we have as nurses to drive our practice. We have important clinical judgment that we use at each moment of every day. Having mandatory ratios weaken our profession and the quality of care of which we pride ourselves in providing each and every day. For example, we have charge nurses who make the assignments and assign new admissions. This is a very complex process that takes into account patient acuity, fall risk concern, isolation, etc. So each nurse's assignment is not the same. A 4-patient assignment is not the same as a different 4-patient assignment. For example, you can have 4 patients who are all alert oriented, independent, maybe just there for IV medications for pneumonia, versus 4 patients who are all disoriented, all high fall risks, unable to get up, and all on various different types of precautions. This is the issue that the rigidity of mandatory ratios does not take into account. We appreciate that you are looking for ways to help nursing, but mandatory ratios are not the answer. This will result in a delay of treatment as well, which significantly impacts patient outcomes. The patients will actually be at a disservice if they are unable to have access to care when they need it due to ratios. For example, in the emergency department, if they are unable to be taken into admission because we are at our mandated ratio. Patients should be at the forefront of all of our decisions, and unfortunately, the patients will suffer from these unattended consequences of mandatory ratios. Thank you for your consideration of my position, and I'm open to any questions.
Thank you very much. Senator Anwar to be followed by Rep. Zupkis.
Thank you, Ms. Otencio. So maybe I did not hear you correct. You're saying that if we have less patients per patient, it's going less nurses per patient. And a nurse is able to care for more patients, it is going to harm the patient?
I am saying that mandating that 4 patients is not the answer. It could be that the 4 patients are totally unable to care for themselves and that nurse is still going to be overworked. That nurse is unable to still provide the safe care that if.
So I'm sorry,
Sorry, go ahead.
I'm trying to understand. So you said the patients will provide care to themselves. Is that what you just said?
No, I'm saying that there is different patients that come into the hospital, various amounts of orientation. And what I'm saying, they can't care for themselves. I'm saying that they might be bedbound. They may not be able to get up and go to the bathroom on their own. So we are constantly in that room turning, cleaning them. And that's different than having a patient who is able to get up, go to the bathroom, change themselves, wash themselves.
Okay, so the bill also talks about the PCAs and the nurses. So there's a ratio around there as well. So it is your testimony that because not all patients are the same, so one nurse can take care of 8 patients instead of 4.
I'm saying that this doesn't take into account the various levels of acuity, and that rigid numbers is not the answer. You may have people that are just waiting their ride to be picked up in an hour, where they can take a new admission. They could be bumped up to 5 for an hour because maybe that patient is ready to leave, but with mandated ratios, they could not.
And I see this at times when there's a patient who needs a lot more help, the nurses help each other out. Do you see that in your hospital too, or not quite?
Absolutely. I mean, I believe we're a very collaborative team and we do try to help people where we can. If we are, having a moment where our patients don't need anything, we will, yes, go and help others.
So if that collaboration is there for a time when a nurse is not able to, and I think if the guidance is given to in charge nurse, he or she can try to coordinate the assignments, but they can still be ratio based. And when they look at that assignment, if there is imperfections in instances, the nurses collaborate with each other, and one nurse can help the other when somebody else is in need. And I see that literally 24/7 that's happening. But
yes, I do agree. We definitely see that 24/7. But what I'm saying is if we have mandated ratios and everybody is at 4, we may still have an open bed on the unit. I might have a discharge leaving in an hour. I could take a patient coming up from the emergency room, flex myself to 5 while that patient's waiting for a ride. So then that frees up another bed in the emergency room for that patient that's been waiting in the ambulance to then come in and receive care.
so that still is a ratio.
But no, so if we mandate, say, 4 patients, 5 patients, this bill is saying that I could not flex to the 6th patient.
Okay, all right. Thank you so much for your testimony. Very interesting. Thank you.
Thank you, Representative Zupkis to be followed by Representative Carpino.
Thank you, Madam Chair, and thank you, because that's exactly what I've been thinking. Sitting here all this time, it's not one size fits all. And there has to be flexibility. So number one, I don't know how this is ever going to be enforced. And my other concern with this, quite honestly, is someone mentioned earlier that if there's a nurse out for some reason and there's open beds possibly, if the emergency room needs to put someone into the hospital admitted, they won't be able to. And so then hospitals are going to start turning away people from the ER. That's a whole nother can of worms that we don't even want to go down that road tonight.
Right, we don't have time for that, but yes.
That's right. So I get it. I mean, right now, as you know, we already have a committee that does this in the hospitals. And so one of my questions is, if we're already doing these staffing committees in the hospital, the information is being reported to DPH already, what's happening to that information? So if this is now troubling to people, why are we not talking to DPH to say, what are you doing with that information? So I appreciate your testimony, and you've hit on exactly what I've been thinking the whole day today. Thank you.
Thank you.
Thank you, Madam Chair.
Thank you, Representative Zupkis. Representative Carpino.
Thank you, ma'am. Megan, I just wanted to say, thank you. You did a really good job explaining how this is a real problem, but perhaps the bill in front of us is an overly simplistic way, which I don't believe is going to solve this very complex problem. And I wanted to answer Senator Anwar's question as a patient. So Middlesex is my home hospital. And I have wandered in via an ambulance and found myself being that midnight emergency surgery who found herself landing on one of your med surg floors. And I have walked through your ER with countless friends and family members, and I can attest of the collaborative and high quality nature of the care I've gotten from every nurse at Middlesex. So if you could do me a favor, see, they didn't know who I was, and I was very particular about that. And the care I have seen from the nurses at Middlesex to every patient who has walked through that door. And I'm a lot older than you are, so this is new emergency room as well as old emergency room has been top notch. So if you could please deliver that message, that would mean a lot to me.
Thank you very much.
Thank you, Representative Carpino. Seeing and hearing no other questions, thank you for being here with us in person and for your testimony and for sharing your experiences with us.
Thank you again.
Next on our list, we have Tracy Eberg joining us online. Welcome, please proceed.
Hi. Good evening, Senator Anwar, Representative McCarthy-Vahey, and everybody on the Public Health Committee. My name is Tracy Eberg. I am a person in long-term recovery. I am also the widow and the angel mom of the two most important men in my life. I am here to advocate for the overdose prevention centers. I believe wholeheartedly that they would be a huge asset to Connecticut. I do believe that if they were around, that possibly maybe my guys would have utilized them. There would have been somebody there to help them. They would not have been alone at their time, and they may still be here today. But with that being said, it helps out in so many different areas. The compassion fatigue that the police officers have, the EMTs have, firefighters have, the nurses have, the doctors have. Some of that can be alleviated because these people will be somewhere where they're safe. And not only that, as a person in recovery, obviously I've dealt with active addiction. It's a place where if it was around when I was active, somebody may have been able to convey that message to me that I am worth something, that I'm cared for. And in interim would have found recovery a heck of a lot sooner than I did. I know there's a lot of opposition to this, but I really, really believe wholeheartedly that it's a necessity. And because of my recovery, I'm actually blessed with the privilege to be able to bring harm reduction into my community, where I'm able to see faces light up after a little bit of time, because I'm able to talk to people and just care for them. And they know that there is absolutely no judgment towards them. People with substance use disorder are just like everybody else. They're people, they're human beings. They're not bad people. They just may be in a bad situation. And a lot of them suffer from mental health issues. And I can attest to that because I'm one of them. You know, so I beg of you to please take this into consideration. You know, together we can make this a much easier time for all people involved. Thank you for your time.
Thank you so much, Ms. Eberg. I know Senator Almore would like to ask you a question or make a comment.
Thank you, Madam Co-Chair. Ms. Eberg, thank you so much for your testimony. And as I mentioned this morning to you, it takes a lot of courage to relive your pain for loss of your son and loss of your husband. And as you grieve, we hear you. We want to thank you for your courage. Thank you so much.
I just want to say one more thing, just so you know how real this is. My son passed away July of 2021. He would have turned 39 years old yesterday. That is my firstborn child. That's the reality.
Ms. Eberg, there really are no words that can adequately address the reality of the loss and the grief that you're facing. And I want to thank you for taking the time to share that with us so that we understand what we need to do and how we need to address this moving forward.
Thank you.
Thank you. Next on our list is Rodney Alexander. Welcome, sir. Please proceed.
Hi, good evening, everybody. Rodney Alexander. I'm an intensive outpatient program for the Root Center in Norwich, Connecticut. I'm here today because I would like to start by thanking the committee for the language in HB 6913 to create a pilot program for PDTs. That's short for Prescription Digital Therapeutic in Connecticut. This would expand the access for many patients to receive care outside of office hours. Number one, health cost savings, potentially decreases overdose deaths as PDTs prove to increase retention, keeping patient and outpatient programs, and connected with their counselors and coaches. Number two, clinical support. Supports patient care during this time of significant staff shortages, down in some cases as much as 70%. It's a 90-day FDA evidence-based curriculum, provides a standard of care that all patients can use, allowing clinicians to monitor success and challenges from a distance. PDTs are remote and easy to use, which allows for more patients to be cared for and treated during a time of staffing instability. Number three, patient support. FDA approved, again, evidence-based programs provide a harm reduction tool that provides 24/7 recovery support required to support brain health to increase chances of sustained recovery. Contingency management has been around since the 70s, which proven evidence to increase chances of recovery, but is too expensive for most clinics to afford. PDTs can afford CM and evidence-based addiction lessons that work together to heal the brain and support treatment provided outside clinic hours, which is huge. We currently use a PDT program at the Norwich Root Center, and our clients who have it love it. They like the freedom to log in anytime, and the modules are very easy to work with and extremely helpful. They like the fact that they can earn virtual gift cards, and the PDT is available again 24/7. As a clinician, it's very beneficial because I can log in between sessions to see how my client is progressing, along with the fact I can check to see if they have a crisis, and I can intervene between sessions. PDT programs are a win-win for everybody.
Excuse me, Mr. Alexander.
And I
your
just
time
wanted
is up. Thank you.
Yep.
You want to just finish
Any
that,
questions?
Mr. Alexander?
Yes, sorry. PDT programs are a win-win for everyone. And as a counselor and a person who's in long-term recovery myself, we need to provide everything humanly possible to battle this opiate crisis we have, not only in Connecticut, but throughout the United States as a whole.
Thank you.
And I just want to thank you for your time. Any questions?
Thank you so much. And you're absolutely right. We do need to do everything humanly possible. I like your win-win comment. Senator Anwar.
I just wanted to thank you, Rodney, for your testimony and the work Root Center does. And I wanted you to thank Stephen for me and also Dr. Podofsky and Margot for all the work that they're doing. Thank you.
Not a problem. Thank you. Have a nice night, everybody. God bless.
Thank you very much. Same to you. And next, I believe we have in person Danielle Dufour. Wonderful. Welcome.
Thanks for having me. Good evening, senators, representatives, and members of the Public Health Committee. My name is Danielle Dufour. I'm a resident of Danielson, Connecticut. I'm in the float pool at Bacchus in Norwich, and I'm the vice president of our union. I offer the following testimony in support of SB 1067. Unsafe staffing is a detriment to patient safety and to the well-being of bedside staff. Adding just one additional patient to a nurse's assignment increases the mortality rate of the patients in their care, and mandating exhausted nurses is not a safe alternative. However, unsafe assignments and forced overtime are staffing methods utilized literally every day where I work. As a result, we are often unable to provide adequate care, not even the bare minimum. I want to do far more than that. I want to fluff pillows, hold hands, have difficult, empathetic conversations with patients and their loved ones. And in these current conditions, I am generally unable to do so. When I do, it is because I am working with an empty stomach and a full bladder, unable to meet my own needs while struggling to meet my patients' needs, your loved ones' needs. The moral injury and fatigue I live with as a result is always difficult to manage and at times is truly intolerable. At yesterday's staffing committee meeting, I discussed a recent shift at work during which I had a 6-patient assignment. After receiving a report that day, one of my patients complained of acute chest pain and shortness of breath. One had severe hypertension and another was considerably hypotensive and hypoglycemic. I could not attend to my other patients for hours because these matters were the priority. One was an actively dying hospice patient whose morphine drip ran out, causing distress for her and for her grieving family because I couldn't get there in time. The 5th patient was confused, impulsive, a high fall risk. The 6th was stable but in severe pain, not medicated promptly due to my unsafe workload. It was his birthday. A nursing student asked me, is it possible that this could be my assignment after completing orientation if I work here? I told her the truth. Yes. To be clear, this is not the most difficult shift I've worked in the past year or even in the past month, not even close, and this should scare you. Healthcare corporations want you to believe that it is fiscally irresponsible to pay for appropriate staffing. That's a lie. Hospital administrators, they'll try to convince you that the current issues are due to a nursing shortage. This is also a lie. There is no nursing shortage. There's a shortage of nurses willing to work at the bedside in the current conditions. This bill provides a framework to start holding facilities accountable and improving the conditions to lead to less moral injury, less burnout, and the retention of experienced staff. Reducing turnover by retaining staff is responsible. It is time to stop listening to the corporations and their nurse administrators because we know what needs to be done. We are more than just numbers on a staffing plan. We are human beings and we are struggling. Our patients are struggling. Our communities are struggling. We deserve better. Patients deserve better, and healthcare corporations can afford to do better. Your constituents will remember if you pass on this bill. Nurses and our unions will remember. I urge you to support this legislation. And I also want to say that those who work at the bedside who are in opposition have a poor understanding of how this bill will affect ratios, misunderstanding safe patient limits, and the effects of the proposed recommendations. I appreciate your time, and I'm happy to answer any questions that you may have.
Thank you. So, yes, I know Senator Anwar has a question. There's a lot of emotion around this issue.
I'm freaking out. I'm like,
Yes,
it's so stressful being here and frustrating.
It is, I'm sure it is. And it's always hard to testify. And especially if you've been here all day and listening to a lot of different people and perspectives. And I think that one thing that we can all acknowledge is that every nurse, whatever your position, whether you're bedside or administrator, you all have been under fire. You are under and have been under a tremendous amount of stress. over the past few years. So we're here to hopefully help support you all by listening and trying to come to solutions that will not have a room full of nurses, whatever your perspective on this bill, talking about this issue. Because what we all want is to make sure that you are able to do your job safely and in a way that feels okay and feels safe emotionally, and that our patients are protected as well. So I thank you for your testimony and time with us, and appreciate you hanging in through this difficult conversation. Senator Anwar.
I have the coolest co-chair. She actually can calm me down and calms a lot of other people all the time, which is just a blessing because I need this therapy very frequently. And she would just say, listen, it's okay. I am listening to you. And I just wanted to thank you for your testimony. And I want to thank you for the work that you do and every nurse does every day. So we really appreciate it. Could you explain to me about the prospective plan based on accepted numbers? Could you explain to me how that would work as your understanding?
So I was speaking because I was frustrated hearing, testimonies from people who disagree with me. And I do believe that, there's a lot more that we agree on than we disagree on. And I try to remember that, as somebody had said earlier. So my understanding of how this would work is that it's not going to hold the hospitals accountable to these very strict ratios because they already don't follow strict guidelines that they should be following. So I don't know. So it's really just a good start. And we're talking about staffing the floors appropriately for the recommended limits, not necessarily that if you have a patient who's about to be discharged, that you're not allowed to flex up to a 5th patient. It's that you're having enough bodies on the floor to take care of these patients. Am I incorrect in my understanding?
It is. So let's say if there was an ICU with 12 beds, and if there were 6 nurses, now there would be a situation when there would be by the exact ratios, you'll say, well, every patient will get every nurse will get 2 patients. But if there are 3 or 4 nurses for a 12-bed ICU, so you're starting with a situation which is not going to get any better, no matter how healthy and well these ICU patients are, because the patients are in the hospital because they're sick. And some people are more sick than the others. And that's where a ratio of the number of nurses in the unit would be able to help coordinate the appropriateness of coverage. But if you're so far below the numbers, there's no win situation. And that's how I saw it.
I agree. I am very pro. Yes, I'm very pro ratios and safe patient limits.
Okay. Well, thank you again for all that you do. And go ahead.
No, I was just saying thank you.
Okay, wait 1 second.
Thank you very much, Representative Zupkis.
Thank you, Madam Chair.
Oh, please stay with us.
Sorry,
Yeah.
I'm exhausted and I can't think. I'm sorry.
Oh, that's okay.
Welcome to the circus here. Thank you for coming. And I could tell it's very frustrating. And I can't even imagine working in a hospital. I have spent a lot of time there over the last few months. And I give y'all so much credit, no matter what department you're in. I actually worked in a hospital, but not patient care. So, the ED to everywhere is craziness. So thank you. And I'm sorry you're frustrated, but I do want to ask you a question on a couple of things you said. One thing you said was you don't think there's a nurse shortage. So are your hospital fully staffed? Did you say that?
No,
I think so.
there is no shortage of nurses, licensed nurses in this country or in the state of Connecticut. There is a shortage of nurses who are willing to work in the acute care setting at the bedside because the conditions are terrible.
Okay. And I know you said that you went to the committee already and they didn't listen or whatever, and holding hospitals accountable. And one thing with these ratios, when something is in law, like you were talking about flexibility, once it's in law, that is what it is. So there's no flexibility if these ratios go 2 for 1, whatever they are listed in this bill. I'm sure you probably know this, but if the bill passes with those ratios, that is the law.
Respectfully, you yourself said that you have no idea how this will be mandated.
Ma'am, just
I'm sorry.
Hang on one second. Just let the representative, I know, keep breathing. Good deep breaths are good.
Because I'm not
Um,
here. I'm
Rep-
really asking, I want to ask the question.
Okay.
So, but how the law is, if it goes into law, that's the law, right? The speed limit's 60, people don't drive 60. I get it, but it is the law. So how, if this law passes with these ratios, how will it be enforced? Because that's something, because you said things aren't enforced or people, it's not held accountable. Hospitals aren't held accountable now. One of my obstacles here is if these ratios go in, how do we, and if their positions open, how do we hold to those ratios?
So earlier today, we heard a very powerful testimony from a nurse. I think she was from Danbury. And I agree with everything that she said wholeheartedly, in that if we do have safer conditions to work in, nurses will return to the bedside, because anybody, like all the nurses that I work with, can't imagine doing anything else. And so them leaving the bedside is because they have to do it to take care of their own like physical, mental, and emotional well-being. They do not want to leave. If we have safer conditions, they will come back. We will retain them. We will retain the nurses that are currently working at the bedside. So they will be enforceable because we will have the staff there, because they won't want to leave. They'll want to stay.
Okay, thank you.
Thank you.
Thank you, Representative Zupkis. Seeing and hearing no other questions, thank you. Thanks for being here.
I'm
with
sorry
us
for my
today.
emotion.
No, emotions are a part of this process. Okay, next online, we have Lisa Capitani. Lisa, welcome. Please proceed.
Hi, thank you. Good afternoon, members of the Public Health Committee. I'm Lisa Capitani. I'm speaking in support of SB 1067. I've worked in healthcare since I was 16, and I've been an RN since 2005. Not long ago, I became unable to work at the bedside because of injuries. Being forced to leave the bedside when I felt like I was abandoning my colleagues at the worst time in the history of nursing. It spurred me to listen, to become a voice for those who are afraid to speak out. Nurses are suffering. Nursing has become a profession where the number one skill that determines one's success is resilience. Burnout and moral injury are more endemic in our field now than ever. Burnout happens when you're overwhelmed, emotionally drained, and unable to keep up with life's demands. Moral injury is when one feels they have violated their conscience or moral compass when they take part in, witness, or fail to prevent an act that disobeys their own moral values or personal principles. This is worse now because our system has prioritized finances over ethics and income over principles. And income over quality. Moral injury is a different kind of suffering than the compassionate, empathetic suffering we learn to compartmentalize and deal with in therapy. This is trauma that resumes every time we punch the clock and walk onto overstaffed units. It's a suffering so at odds with the caregivers of our nature that we live in constant pain. Nurses' experiences of working through the pandemic are now being compared in the literature to that of soldiers returning home from the Vietnam War. Nurses feel abandoned. They show up to work every day for shifts where they're being asked to do more with less, and it's not sustainable. Nurses are burning out and leaving the bedside. Nurses in Connecticut are well compensated. It's not money they're leaving for, it's the work environment they are running from. Since the slap in the face reality of the pandemic showed us how our society treats its heroes, we stopped screaming for help and started, like me, just leaving the bedside. This quiet exodus leaves hospitals with less experienced staff working with fewer resources than ever before. I do not want my loved ones admitted anytime soon. If you support 1067 today, you're saying here and now that you support nurses and our allies, that you are not abandoning us to fight this war against disease alone with only those executives seeking to benefit shareholders making the decisions. This bill gives hospitals generous timeline to implement plans and reorganize their current models to support better patient care and a more sustainable work environment. While I will not return to the bedside anytime soon, I, like every one of us, will most likely find myself in a hospital bed. And when I do, I want to go in that bed knowing that the nurse assigned to care for me has the tools, time, and energy to do so. And with the passage of safe staffing laws, she may even have some heart left too. Thank you.
Thank you very much, Ms. Capitani. I appreciate your time and testimony and also the passion with which you shared that with us as well. Seeing no comments or questions, we wish you a wonderful evening and thank you for the work that you've done serving as a nurse.
Thank you.
Next, I believe, is Jim Acabellis. Oh, I apologize. Thank you very much. I appreciate it. This is why it's teamwork here. So no, next is Ivelisse Correa, and please correct me if I got your name wrong.
Oh,
Welcome.
thank you. It's Evelise, but close enough. Okay. I'd like to thank the committee for allowing me to speak today. My name is Evelise Correa. I'm Executive Director of Good Trouble Advocates, Vice President of BLM 860, and a member of the CT Canna Warriors. I'd like to start by supporting HB, or which one is this one? No, is that one? HB? No, it's the cannabis prevention one for the youth. Okay, 6915, my apologies. An act concerning cannabis use prevention efforts related to youth. I support this bill, but would ask that the proposed council consider appointing 2 cannabis advocates, preferably one with a judicial history in cannabis and someone from a disproportionately impacted area. Most of us are parents, and my children have had those hard discussions with me. My eldest is currently in college. We spoke about the effects on mental health and why adult use differs from teen usage. Let's not repeat the mistakes from the DARE program. Instead, let's be honest with the TikTok generation. We can build strong partnerships together, and instead of turning these funds over to police and criminalizing our youth, we can fund the root causes of addiction with housing, mental health services, education, and nutrition. Let's make sure not to waste good weed on children. Next, I'm expressing any blanket support for any bills that healthcare workers spoke on. They would know better than anyone else. And finally, HB 6913. This is all about addressing an epidemic. It requires action. And that's going to take understanding and ending stigmas. While combating the opiate crisis, every couple minutes, there's going to be someone else that dies. There's going to be another family that loses someone. And you really don't know that pain of, you don't know until it hits your family how bad it can really be. And safe consumption sites are, we have bars for alcohol. Ending a stigma and just understanding that these are people, they're someone's son, they're someone's brother, cousin, friend. Someone loves them and they hope that, they're gonna be okay. You're gonna hope they have access to Narcan. You don't want them to die. You want them to eventually make it into treatment so they can be with you again. I don't want anyone to feel like this. And I hope that it gets the proper funding it needs and that we address the root causes for prevention, because it's going to take a lot to stop people not only from dying, but from falling into addiction as well.
Excuse me, Ms. Correa, but your time is up. Thank you.
Thank you.
Thank you so much. Thank you for sharing your experience with us. And I think there were a few things that you said that we stick with what we know works and not go down the roads that we know were not effective. And you also talked about some of those underlying things that we need to focus on: housing, which is a big one, mental health services, another big one. And so I thank you for that, and for also walking the walk, because you're inviting us to help get rid of the stigma. And by being here today and sharing with us, that's exactly what you're doing. So thank you. Senator Anwar.
I just wanted to thank you for the work that you do. Thank you for standing up and putting a human perspective on each and every individual. And allowing us to say that we love everybody, we care about everybody, and then we should, as a state, take care of everyone. Thank you.
Thank you.
Thank you, Senator Anwar. We hope you have a wonderful night. And I know you saw earlier how I had teams, so I appreciate that you did as well. We do this together as a team. So we are going to go next, since I had trouble counting earlier. Have a great night. Thank you. We're going to go next to Jim Acabellis.
Good evening. Since I am number 89 out of 217, I want to make sure that I add something to the conversation and not be repetitive. And I will tell you that I've rewritten and rewritten and rewrote and rewritten over and over again. And I want to start by thanking the members of this committee for ensuring a respectful conversation and one in which we can talk through what are difficult issues honestly and openly. And I think it's fair to say that we as hospitals across the state are listening here today. We believe this is an important conversation. We believe that the more we listen, the more we learn, the better off we will be and the better off our patients will be. And I think that is important. And I believe walking away today, we recognize that some of the conversation relating to the nurse staff committees and how we can work with them immediately to have them listen more, hear more, and more conversations might be an immediate part of this conversation. But in terms of ratios, I'm going to align myself with my colleagues who you have heard before and you hear after, who have concerns about and are opposed to how nurse staff ratios would work. They are the experts in this. I am not. But let me talk through a couple of other areas and try to connect some dots in my remaining time. On the agenda today, we have a bill about the EMS system, and what we're hearing are workforce shortage in the EMS system. And the EMS system is the one that starts bringing patients into the hospital. Prior to that, we had a long conversation about the emergency room physicians and what they need. Part of that conversation had to do with the pending emergency room physician shortage. This committee and almost every committee in the legislature is looking at the workforce issues. They are across committees and across industries. I believe, and the numbers will show, that there is a workforce shortage in Connecticut and one in healthcare and across the country. So what do we know? We know that there are 2,000 vacancies in Connecticut hospitals today. That doesn't include long-term care, ambulatory surgery, school nurses, VNA nurses, all across the healthcare spectrum. There is a vacancy. In 2019, prior to the pandemic, the Governor's Workforce Council, this is not numbers that we have created, have said there's about 50,000 nurses in Connecticut. 52% are age 50. And we know in the next 10 years that we will see many of them retiring. They say Connecticut, prior to the pandemic and completely prior to what we would do here in this bill, we would need 3,000 new nurses every single year. We graduate 1,900. The numbers do not work. So the response can be, well, Jim, you haven't really read the bill. It's, it doesn't go into effect until 2028. True. And I think 2028 will be different. I'm not sure it's going to be better or worse. How will it be better? Is if we begin to today deal with that pipeline. Other states are doing that. Other states are putting significant funding. Massachusetts, at the end of last year, put $300 million into recruiting and retaining nurses. Michigan is doing the same. We're seeing New York look at healthcare professions and dealing with it in terms of increased funding to the Medicaid program. We need to make sure that we solve this problem today. It takes 4 years plus to graduate a nurse. So 2028 is, I still don't think, even if we target something at 2020, is something that that we could support. And I want to end with thanking, no matter what side of this conversation we are, and I think it was said best by several of the nursing leaders and nurses today. We have more in common than we are separate. And no matter where we are in this conversation, these nurses went through what we can't even imagine. They went through 2020 without vaccines. They went through 2020 walking home, taking their scrubs off and clothes off in their house, putting them in the washing machine to make sure they didn't infect their families. We get the passion here. It's important to understand what they have been through. We just do not believe ratios is the way to go at it. But we need to work together. There are some solutions out there. There are other parts of this bill that we will have conversations about, and we're happy to have conversations about. But we do not believe the nurse staff ratios and the rigidity of that and the lack of the ability of the nurse to make decisions. I see Kathleen coming up.
Yes. Sorry, Jim. Thank you.
Thank you. And as Representative McCarthy-Vahey will say, we look forward to continuing conversations.
Yes, you've heard me say that a few times here at the table. Jim, I have to say thank you to Kathleen. And she is, for everyone here, you have to know she is the nicest person. And I'm sure she hates that she has to do this every time, cut people off, but we will continue the conversation, but don't go anywhere there.
I worked with Kathleen for 8 years, side by side, next to each other. She is one of the best.
Yes. Thank you for that. Kathleen, we appreciate you. Representative Zupkis.
Thank you, Madam Chair. Thank you for coming today, Jim. A question for you is, reports are already going to DPH on hospital staffing. What happens to that information?
When reports go into the Department of Public Health related to complaints, right? They're complaints. The department will review them and determine when and what time to go out and make an investigation into those complaints. They review and look at every single complaint that comes in. We are aware, however, that given the pandemic and their short staffing on nurses and surveyors and inspectors, that they are behind. And they'll be the first ones to say that. But anything that you pass, any requirement that you pass when the Department of Public Health comes out, they survey for it.
Yeah, thank you. Because again, this information, as I am understanding it, and I could be wrong, but in my understanding, this information already goes to DPH.
Correct.
And so I guess if the same information is going to be going to DPH, why aren't we doing something about it now?
Well,
what difference is it going to make if we're sending it again?
I think the department, my conversations with those individuals who are responsible when the Department of Public Health or the Joint Commission come in, one of the first things they ask for are your staffing plans.
Right.
And they look to them and they understand them, but they also, I think, understand, I should say it this way. They are not, unfortunately, looking at, unless it's a immediate jeopardy, which is a CMS term, something that requires immediate jeopardy in looking at the severity of it in the hospital's license and whether they continue to take Medicare. They are understaffed. If you were to call up with a complaint today, unless it rises to a certain level, they are going to have to deal with it when they get out to deal with it. And they have also prioritized, understandably, license renewal. We lost such a time frame about having hospital licenses renewed that we had to work with them. So that's the first thing they're going out, because without a valid license, you can't get any FDA prescriptions. Vendors won't deal with you. So we have been working with them. We understand they're short staffed, but they do get the information, and they will tell you that they do look at it and they go out and ask for staffing plans.
Right. But being understaffed, this is not going to change being understaffed in the DPH. It's just going to give them more work, I guess, or the same work, but just with some kind of enforcement.
I think in my 22 years I've given up sort of trying to guess on how we can ensure appropriate staffing anywhere.
Thank you.
Thank you, Rep. Zupkis. Representative Claritas Dutria.
Thank you, Madam Chair. Thank you, Jim, for being here today. What would happen if we enacted these ratios and I come into the ED with a healthcare emergency and their ratio is not where it is per state law, per state statute? What's going to happen to me?
So if I understand the hypothetical, you come into the emergency department, and so you come into what I'll think of as sort of the waiting area. But behind there is where all of the patients are being treated. Depending upon what the staffing is and in terms of the ratios, you could be waiting a significantly long time in the waiting room. And we have all, I think, heard the stories. And I think that on what happens in California, are they waiting? Are ambulances being backed up? Because you want to make sure that you are in compliance with the ratios. That is a possibility. If you don't have the nurses, if you put in the ratios, you either have, and you don't have the staff, you either have less beds or more nurses. That's how you deal with it, right?
Yes. So I get to that ED. They haven't met their staffing ratio. I'm in a health crisis. They're going to have to ship me to another hospital per this bill.
Yeah. I don't want to say that any hospital, any doctor, or any nurse, if you are within the building of the hospital, is going to turn you away. What they're going to try to do is go all hands on deck and get back in a ratio as soon as they can, right? That's because they're not going to leave you with severe chest pains waiting in the emergency department, because nurses wouldn't do that, doctors wouldn't do that, but they're going to be out of ratio. They're going to be out of ratio because of the care that needs to be provided. And what we see in Massachusetts is all during the pandemic, first of all, they had to go in and try to waive those during what they have they have ICU. They would get out of ratios, but they'd have to try to get back in during the timeframes when they weren't waived. But I don't want to leave anybody with the impression that if you walk through the door of a hospital with or without ratios, that you're not going to get the care. We're going to be out of ratios and out of compliance. But I think the doctors and the nurses would say, we'll pick up those pieces afterwards.
Exactly. And I hope that, I believe that that's what would happen, because our medical professionals would never do something like that. But then there's always the risk of them saying, well, what's the consequence if I take this patient and I'm out of ratio? At some point, am I going to get reprimanded, written up? Is the state going to take some sanction on the hospital or on my license? And we don't want to be in that situation where people are afraid now, are
Right.
second guessing themselves and helping the people that need the help the most.
Because-
That's why I think this bill, the intent is there. I just don't think it's reaching the intent that they wanted to.
Right.
Thank you.
And I think we both agree that everybody who does direct patient care, their goal is for the patient. And they will pick up the pieces afterwards, which may mean a year or two down the road, the Department of Public Health will come in and say, why didn't Dr. Jim do X? He is now, you were out of ratio for that time frame.
Thank you, Representative Claritas Dutria. Representative McCarty.
Just very briefly, I just wanted to recognize you and thank you. And I think I heard you say that there was a willingness on the hospital association to sit down and try to look for some solutions now if we can't do these ratios. And would you be able to supply us with some of your thinking on possible solutions that we could enact? You rightfully said that this is an issue across committees. We are right now in education looking at creating more pathways for training for more nurses, because we have a shortage in the nurses to begin with. So I'd be interested, because we hear these heart-wrenching stories coming forward and sympathetic, but I'd like to be able to do something sooner than later, and would depend on you to come forward with, help us with some of the solutions.
I do think that, outside of the ratio piece, there is a lot that we all agree on and can agree on. There are pieces in there in some of these bills and pieces that aren't. I think the Connecticut Nurses Association's I will commend my colleagues there that that have 5 pages of suggestions related to the nursing committees, and what they talk about is being able to solve things today. But there is this other piece that I think that you talked about, that we can't put a Band-Aid on the pipeline. Right? We know that every single state is having these issues. I think the number in California is a 40,000 person shortage. We know that we, as a father of a 27-year-old who has friends that are 27, they like to be in Boston, they like to be in Philadelphia, they like to be in New York. We need to make sure that they stay in Connecticut. We need to, so that is incumbent partly on the hospitals, but partly on making sure that we can deal with this new generation of nurses through a variety of ways to lessen their educational burden, so they don't have to sign up and be travel nurses and go work in California, right? Because as a young nurse today, you can sign up to be a travel nurse and take care of your educational debts much more quickly. But I can talk for a long time. Your time is short. I am not yet halfway down your list, so thank you.
Well, you're not going anywhere yet, I don't think. Senator Marks, to be followed by Representative Dauphiné, to be followed by Representative Palm.
Thank you, Chair. Thank you, sir, for testifying. My question is, the nurses that have come and testified that are in support of the ratio, they truly believe that doing this ratio is going to bring people back, nurses back to the bedside, because we truly do love the bedside. I've been a nurse for almost 40 years. My favorite 20 years of nursing was in a hospital at the bedside. I love what I'm doing now, and it's not quite as hard on my back as hospital nursing is. But do you feel that putting in the staffing ratios will make work-life balance better, make people feel like they're doing a better job, and then make more of some of the nurses come back to bedside nursing?
I am not going to sit here and disregard, I think, the extraordinarily emotional testimony that we heard for nurses who believe that that will happen. I guess my answer is I just can look to California, who has nursing ratios and still has a significant workforce shortage. So I don't think so, but I just think for me to come out, angrily saying, no, they're wrong, isn't right, because they are speaking their experience and what they believe. And I think we need to respect that and listen to that. I'll just point us to where I think California, who has had nursing ratios, still has a workforce crisis.
Okay, thank you for that. And just quickly, you said now, listening to this testimony, that you feel the hospital administrators should go back and work on their on the staffing committees and try to find things now. I guess sitting here as a nurse, and I'm sure the nurses that are sitting out in the audience are just thinking, well, why haven't you listened to us for the last 5 years? So I don't know if you could comment on that. I mean, did it take this unbelievable testimony of these very brave nurses and hearing one after the other, or like, why hasn't that happened already? This is nothing new that's being said here in this room today.
We have, correct. Issues related to nurse staffing are not new here today. What I do think is adding to this conversation, the intensity of conversation, is what the last 3 or 4 years have looked like. And my guess is, this is something that my nurse leaders colleagues may say that I'm wrong, but my guess is that for the last 3 years, the focus of nurses and nursing leaders has been on this extraordinary pandemic. And have they prioritized dealing with this once in a century pandemic over having more fulsome conversations with some of their committees. That may be part of this. I can't disagree with that. However, we did hear from nursing leaders who talked about the monthly conversations and the robust conversations that they have. But I think if we look past, and we are at our lowest number of COVID patients we've been in a very long time. But if we look past from March of 2020 to where we are today in the first 2 years and the spikes that went on, I think the focus was on getting through everything day by day. And that may impact why I think we're hearing the need to have more fulsome conversations and refocus our attention on these committees. So I think that's probably the best way to answer it, Senator. Probably not to your satisfaction, but I think that's the best way I can answer it.
Thank you, sir.
Thank you, Senator Marks. All the people who worked in hospitals were trying to survive. Right? That's what you're saying.
And trying to ensure that everybody who was in the hospital
right.
could
That's
survive.
Exactly.
Right.
Trying to keep people alive.
And you know what? And I think we're seeing it in Connecticut, and we're seeing it across the country in these conversations. And I think we have to respect it from everyone, is what the aftershocks of this pandemic have done to all of us outside of healthcare, but in healthcare. To have to know that when you come home from work, that you're getting undressed in the garage and putting your clothes in the washer machine, or doctors, and I know Dr. Anwar knows them, who didn't want to go home to their families right away. The aftershocks of that on them and their families is extraordinary. The first vaccines weren't until until December of 2020, the first part of this. So I think that is showing what the intensity is. Not that the issues weren't there, but beforehand, and I don't want to say that, but I think we can all learn from what we're hearing today.
Representative Dauphiné, to be followed by Rep. Palm.
Thank you, Madam Chair. And I think that Senator Marks already kind of hit on what I was going to say, but I think the takeaway here is that the shortage is real, and that mandating levels of nursing are not necessarily going to take care of the problem. So yes, while some may come back, we're still going to be faced with a huge shortage. Is that the takeaway?
Absolutely. I mean, and this is not meant to be sort of, I think if we were focusing on the fact that it is the working conditions in hospitals were the reason that we're having these issues outside of the shortage, we know that there are shortages in schools for nurses. We know there's across the continuum. So the short answer is yes. Yes.
Thank you for your testimony, and thank you, Madam Chair.
Thank you, Representative. Representative Palm.
Good evening, Jim. Thanks as always for your testimony and your expertise. I just wanted to bring your attention and to the attention of anybody listening that we do actually have a wonderful bill wending its way through the system that addresses exactly what you just said. Bill number is 6901, and it's about reducing student debt specifically for nurses and teachers, the groups hardest hit by the pandemic. So please keep your eye on that. And I'd love to talk to you further about it, because the people you represent were absolutely on the front line, and we need to put our money where our mouth is about calling you all heroes. Thank you.
Thank you.
Thank you for that, Rep. Palm. I think that reflects some of the suggestion that we heard from Mr. Accabelas as he was testifying. And finally, Senator Anwar.
Thank you so much, Madam Co-Chair. Jim, thank you for your testimony and answering questions in such a careful and thoughtful manner. We truly appreciate you. You're a gentleman. I just wanted to think aloud with you on a number of things. One of the things that I think we all agree on is that we as a state need to invest into education of our next generation of bedside nurses. We have a responsibility to take care of that, because one of the biggest impact of the pandemic, the first ripple has been the bedside nursing has been in a significant crisis. And that's what is impacting the inpatient hospital system. So I think with that acceptance of agreement between the nurses as well as with the healthcare systems, we need to probably look at, we have bills, but we need to have money about in the range of $30 million that we need to be put into this to get the healthcare workforce bill that we are working on to be able to give incentives for recruitment and retention of our healthcare workers. So that's one part that I think many of us would agree on. The other part I think it's just wanted to put on your radar is that while you're standing and sitting here and representing all the hospitals in the state of Connecticut, not all the hospitals are the same in the state of Connecticut. Some are very big, some are very small, some are at the position of, God forbid, closing in the rural parts of our state. Some have already closed, some have been made into emergency rooms. And that's the challenge. On the other hand, you have these mega hospitals, which are ever increasing and buying some new hospitals as well. So it's a whole random different patterns that are there. And not all of them are treating their healthcare workforce in the same manner. There are best practices. There are some that are doing better than the others, but not all of them are doing the good enough job. And that's why you're hearing a difference in the various nurses who are giving and sharing their experiences. I think it's important to look at the best practices, and perhaps your organization can start to say that this is how we should do it, like hospital XYZ is doing it, so that we don't have to come here and then have some of these conversations. The third thing I wanted to mention is that the committees have been in existence for a long time, the staffing committees. And the staffing committees have not been heard, perhaps in the last 3 years more so because it was not practical to hear them. But in the past, when we were having the conversations, they were still felt that they are not listening about the ratios as well. So some people may agree, some may not, depending on which hospital they are in. So I think that's something else that we have to keep in mind. And that's why we are around this circle having this conversation. And money is an issue. I know that there are many bills during this session, which are going to harm the bottom line for the hospitals even more. The question I don't know the answer to is, does the hospital finances improvement translate into taking care of their nursing staff better? I don't know the answer to that. I would presume the answer would be yes, but I can also say that when the hospitals are not doing well, they will clearly impact all the workforce in the hospital system. So I know that one for sure, but I don't know if the hospitals are financially doing well, they'll take care of their nursing staff. So we have a number of challenges around this. I do feel that this committee is committed. Hopefully many people in this committee are committed to education of the healthcare workforce. And when we do take care of that, we feel in the next 3-4 years with the investment, we will be able to improve the healthcare workforce in the state of Connecticut. And that's why we feel a timeline of 5 years from now would be worthy. But between now and then, we would be so happy if the things are working well and the workforce is there that we don't even need to implement the bill, and we can come back and say we don't need the ratios implemented because the hospital and the healthcare systems are doing so well. But we will cross that bridge when we have to. But right now we need to have a system to get you the workforce, get the healthcare systems, the workforce, and be partners in that effort, but also see the existing systems work for the benefit of our nurses, the bedside nurses who are really, really hurting at this time. So I will just stop here, but I wanted to give you the broader picture and see what your thoughts are. If you want to reflect, you're welcome to do so.
I will, and I know always when I come before this committee, I need to intellectually stretch, right? I have to be prepared and ready for your questions, but I will try to touch on all of them as quickly as I can. We are extraordinarily appreciative of the thought and the desire to invest in bedside nurses. I would challenge us that $30 million is not enough. Yes, there are differences in hospitals, big and small. I am here today and saying I'll either be here or in this building, and I'm listening to the nurses from all across the state and am hearing what you are hearing. I do believe that that listening on the nurse staffing committees is a conversation that we are definitely willing to have happen, because we do believe that there can be some best practices. Best practices work in every area, and where are the ones that people are feeling they're being listened to, and where are the ones that there are challenges. And you won't be surprised by this last comment. when we talk about investing in nurses and then we talk about hospital finances, we need to be really realistic and clear. And I know that, and I heard, and the hospitals heard the conversations when we voted out Bill 6669, that it's a work in progress and we're going to have conversations. That was $450 million reduction to hospitals, at least. 420 is what OHS predicts. The bill on insurance, and thank you for Senator Anwar for voting against it, may be numbers that have a B at them in terms of changes to hospital financing. That will impact the workforce, no doubt about it. So I just think as we look at all of these pieces, and then I start and maybe we can let other people come up and testify, we have to put and connect all of these dots together. This committee is really good at doing it. The EMS system, ED overcrowding, the financial ability of hospitals, but most importantly, how these all impact the patients, how they impact the patients and those, and it goes beyond, because I think and that's why I've been stressing what these nurses have gone through as opposed to simply calling them heroes, because I don't think that really does justice to what they have been through. But we have to look at the entire plate in the entire conversation. So thank you. And you know where to find us.
We do know where to find you, and we will. So thank you. We very much appreciate the conversation, and I would concur with Senator Anwar. We appreciate the thoughtful dialogue, as we have heard here, coming from all perspectives. It's important to listen, and we will continue to do that. Next on our list, we have also in person with us, Thomas Burr. Welcome, sir.
Yes, good evening, Representative McCarthy Vahey, Senator Anwar, members of the committee. My name is Thomas Burr. I'm the Public Policy Manager for the Connecticut chapter of the National Alliance on Mental Illness, otherwise known as NAMI Connecticut. I'm here today in support of HB 6915, an act concerning cannabis use prevention efforts related to youth. The stated purpose of this bill is to prevent cannabis use by youth. It's pretty straightforward. As the country's largest grassroots mental health organization, you should know that we have vigorously opposed the legalization of cannabis wherever it's been proposed, but we regretfully acknowledge that at least here in Connecticut, that ship has sailed. So be that as it may, we know that cannabis use can increase the risk of psychotic disorders and have previously testified before the legislature that a significant amount of any revenue generated by the state of Connecticut or realized by the state of Connecticut from the sale of marijuana should be applied strictly to these three areas: prevention education targeted towards middle and high school students, treatment by healthcare providers of mental health and addiction services, and research into the effects of cannabis on the developing brain and society as a whole. HB 6915 directs an increase to 40% of the tax received by the state be directed to the Prevention and Recovery Services Fund, up from 25%, which we believe is at least a step in the right direction to help minimize the resulting damage to our state's youth and young adults that is a direct result from the legalization of marijuana. The local prevention councils, the regional behavioral health action organizations, and the local youth services bureaus, who you should know do amazing work in their communities on sometimes shoestring budgets, will be able to further their work in delivering public awareness campaigns to help raise awareness of the mental and physical health risks of youth use and of cannabis, as well as use by pregnant persons, as well as continue to collect and analyze the data regarding substance use. So we applaud the Public Health Committee in making these needed and important adjustments to the state statutes, and therefore, in summary, we enthusiastically support HB 6915. I should also mention, because I haven't been told to stop talking, that we also, in regards to SB 1211, an act establishing a mental health crisis center pilot program, while we wouldn't necessarily oppose that, we are aware that Demas is going to very soon issue some RFPs to create these things. So I would respectfully ask the committee to reach out to your contacts at the Department of Mental Health and Addiction Services and see what they've got brewing there. I should mention, in the light of some of the earlier testimony here about the nursing situation in hospitals, we are asking for money for peer-run respite centers here in Connecticut, which could absolutely offload the bottleneck in our psychiatric hospitals. There's a huge number of peers that are trained and ready to go to work. There just isn't a mechanism to get them paid. So between the creation of the peer-run respites and the Medicaid funding for peers, that could be a real game changer, at least in that space of the current crunch with hospitals. And I urge you all to look into that or reach out to me if you need more information on that. At HB 6914, an act concerning the use of funds in the opioid and tobacco settlement funds. We support that bill and would respectfully direct the committee to take special note of Geraldine Lott from Amplify's testimony, as well as Jim Williams from the American Heart Association's earlier testimony. And finally, we support SB 9, specifically the sections related to the harm reduction centers. It was amazing listening to Liz Evans earlier tonight and her testimony. That was riveting, and wow, we need to get on that right away. And thank you for your time and attention, and I'll happy to answer any questions you might have.
Mr. Burr, thank you so much. And I'm glad it worked out that you were able to do the judiciary piece as well. I know. the
Running
juggle.
back and forth, yes.
Yes, I know. Sometimes it's the luck of the draw here or the lack of luck, but thank you for your testimony on multiple issues today. I appreciate your advocacy and the conversations that you have on a regular basis. And we certainly know of the good work being done by those regional behavioral health action organizations with their own bill to try and provide additional funding to those folks.
Indeed.
So seeing and hearing no other questions, we thank you for being here and waiting through the day and now into the evening with us.
My pleasure. Have a good evening.
Thank you. You too. Next, we have on Zoom, Pam Motti. Pam, welcome. Pam, are you able to turn your camera around and unmute? I know sometimes it's tricky on the phone.
Trying, so.
Your steering wheel. Here we go.
All right. So sorry about that. I just shut my camera off. I'm trying. It's kind of messed up, but you can hear me now. So good evening, Senator Anwar, Representative McCarty Vahey, Senator Summers, Representative Claridis Ditra, and esteemed members of the Public Health Committee. Thank you for the opportunity to offer testimony in support of House Bill 6914 and 6915. I'm the director of BH Cares Alliance for Prevention and Wellness, and also the president of the Connecticut Prevention Network, made up of the state's 5 regional behavioral health action organizations. I thank you for understanding the need to fund the RBHAOs through DEMIS, which will strengthen and support our current prevention infrastructure, which is efficient and effective in reducing youth substance use. By investing the dual settlement dollars to the RBHAOs, we will be able to conduct the work related to the abatement, mitigation, cessation, and reduction or prevention for nicotine systems by residents under the age of 21. These activities align with our work and interlace local, regional, and state efforts with national prevention strategies. Currently in the state, we have a current 30-day use rate of youth vaping of 27%, as reported by the 2019 Connecticut Youth Risk Survey behavior. Utilizing these settlement dollars through the existing structure and coordinated efforts, we can reduce these vaping rates. We need to act now to make significant changes to ensure today's youth grow into healthy adults and not addicted to nicotine. We know from our past successful work on reducing youth tobacco use that we'll be successful in reducing vaping among youth with dedicated funding and resources. I can reiterate the above with the use of the cannabis tax dollars referred in HB 6915. We integrate prevention, intervention, and recovery efforts throughout our community partnerships, which include local coalitions, but also multiple diverse sectors representing all of our community residents. We have the expertise and commitment to create healthy communities through the reduction of substance use and promotion of mental well-being. Again, these dedicated resources can be proactive, enhancing youth cannabis prevention efforts. In conclusion, I want to thank you for utilizing our existing infrastructure where there is experience and expertise in reducing the youth substance use and promoting mental wellness and building community partnerships. Again, thank you for investing in the RBHAOs as our strategic community partner. I have also submitted more specific testimony on these two bills, but I'm hoping to have, any questions being answered. And I also just want to say, I also do support Senate Bill 9 as well.
Thank you very much. I appreciate your testimony and your work. And yes, while this committee has passed that Regional Behavioral Health Action Organization bill, it still has a ways to go. So keep up your advocacy elsewhere as well. Thanks for sharing that. You said 27% for the
Correct.
youth taking number?
Yes.
That's from the Youth Risk Behavior Survey.
That is correct. And it varies, we do have local data on communities as well. And our traditional tobacco rate in the state is about 3%. And if you were to look at, when I started this work 25 years ago, and I was on the front lines of youth tobacco issues, when we interlaced those local, regional, state using national strategy, we reduced those numbers. In my community back then, it was about 24%, or 1 out of every 5 students was using traditional tobacco products, and we got that down to below 3%. So I know we can do this within the state with dedicated funding and resources, because it has worked in the past.
Thank you. We heard testimony earlier today that we amend language in one of our bills today to match that 22.7 million minimum that the CDC recommends, as opposed to the 12 million. And as was the case with the bill that we JF'd on Monday. So thank you very much for your
You're
good
welcome.
fortune for taking the time to testify here today. Seeing and hearing no other questions and or comments, we'll go next to number 92, Alicia Hines. Welcome, please proceed.
Good evening, everyone. Thanks for having me. My name is Alicia Hines, and I am a registered nurse at Danbury Hospital and also a member of Danbury Nurses Union Unit number 47, AFT, Connecticut. And I wanted to give the following testimony in support of SB 1067. So I am a rapid response nurse, which means I cover the entire hospital. So we go from the emergency department to ICU to outpatient. And I get to witness firsthand the struggle the nurses have. And I know that the suggested nurse patient ratio should be on a medical surgical unit 4 to 5. And we are doubling those numbers at times. So our nurses are handling 10 patients per nurse, and they are having to do assessments, care, med passes, trying to handle their personal needs, and also provide emotional support on these patients. And it's very sad to witness and watch the nurses very stressed, trying to, work on an empty stomach. They're not able to have bathroom breaks. They're not even able to actually take a break, because the moment they step away, something can happen. And when something happens, it's called, what we do is a rapid response. And the number of rapid responses this month that the hospital has had is 81. And that's only been 3 weeks. As of yesterday, we've had 81 rapids, which means a rapid response is when a patient's declining and they call us. So the problem is these poor nurses aren't able to round on their patients as frequently as needed, and they're not able to notice the initial signs of decline, whether it's, a lower blood pressure or, heart palpitations or something that they're having. And if the nurse was able to be there and do an early intervention, there might not have been an issue. But with this happening, there's an increase with every additional patient a nurse has. I believe it's a 7% increase in potential patient death within 30 days of hospital admission, which is a scary number, especially considering these nurses are having 8 to 10 patients on some shifts. And it happens more often than not. We do not have the staff. The hospitals are not able to staff. Nurses are leaving the bedside, as many people have stated. And because they're stressed, they can't handle it emotionally or physically now, which is really sad. I've been a nurse for 14 years, and I can't imagine being anywhere else but the bedside and the hospital setting. I love it. But we are not able to care for our patients like we were taught. We're not able to care for our patients like we want to. We can barely have a conversation with them, and we are resources to the nurses. So we try to help them, but even then we can't really do the job and give the quality care that we want. And
Ms.
Danbury Hospital is a
Hines?
huge hospital. Yes.
Find your 3 minutes have expired.
Oh, I'm sorry. Okay. Any
You. It
questions?
Thank you
Thank
so
you.
much. It goes very quickly and no need to be
It
sorry.
does.
We're very grateful for your testimony today, and that's a lot of rapid responding that you were talking
Mhm.
about. Thank you
Yes.
for your work as well.
Thank you. Thank you.
Seeing and hearing no other questions or comments, we wish you a wonderful evening and thank you for taking the time to be with us.
Thanks for having me. Have a good night.
You too. Next on our list is David Fenton.
Mr. Fenton, please unmute yourself. Thank you.
Hello, can you hear me?
Very well.
Hi, sorry, I'm in a car, so as well. So I'll be brief. My name's David Fenton. I'm an oral and maxillofacial surgeon in Bristol. And so I'm a physician and dentist. I'm going to try to speak quickly on a couple topics of the day. First and foremost, I want to provide support for Raise Bill 1228 concerning the state's healthcare workforce. Kind of as a brief summary, with support of the testimony from Kathleen Garrity earlier today, everything she had said. I'd like to support recommend that in section 2 that it be amended to add dental assistants as another career path to into the list for study methods for addressing shortages, because there's a severe shortage of dental assistants in the state as well as the entire country. Also like to support the section 5 competency testing for dental assistants for X-ray or radiation certification. That's the main reason I'm presenting today, taking the opportunity. There's no doubt that the encumbrance of the X-ray test and process for the cost and stress of it and the timing of it as making a significant issue with hiring and trying to get more people to enter the field of dental assisting, which is a great career opportunity for them. And then also I just wanted to comment on some of the nursing discussions and some of the other discussions that I've heard several times. A little disappointed to hear opposition to a bill or a potential solution just because it won't completely solve a problem. I think it's really important to recognize that most of these problems are extremely multifaceted, and just because one solution doesn't completely solve it doesn't mean it should be discounted. I think I definitely respect the concept or concern for unintended consequences, and those should always be considered, and that's where exceptions should be applied and amended. And I'll take any questions if there are any.
Thank you so much for your testimony. Seeing no questions or comments, we want to thank you for your time. Stay well.
Thank you.
Please drive carefully. Next is Nicholas Peprosky. Welcome.
Thank you. Good evening. Is my audio okay?
Yes.
All right. My name is Nick Peprosky. I'm currently a practicing paramedic and the president of the Connecticut Association of Paramedics and EMTs, better known as CAPE. It actually pains me today to be speaking in opposition to Bill 1073, an act requiring the administration of epinephrine by first responders. On its face, the intent of this bill is good. Epinephrine is a life-saving drug, and I've used it successfully many times in my 20-year career. And expanding its availability in an emergency would have a measurable benefit for patients. However, CAPE has significant concerns with the structure, language of the bill, as well as the lack of funding to support it. In general, our organization is hesitant to support legislating the medical scope of practice into statute. We already have a regulatory process through ChemSMAC and the Office of EMS that is empowered to make the proposed change under their current statutory authority. In short, the proposed change can be made without passing this bill. While the benefits of this particular change may seem obvious to all, if we enshrine it in statute, it becomes much more difficult to change in the future should industry best practices change. As medical providers, we can attest to how often these practices do indeed change. Our concerns with the bill are as follows. This change is expensive to make. EpiPens cost upwards of $500 each and sometimes have expiration dates of less than 18 months. First responders are also not allowed to bill for their services, so there would be no opportunity to recover this cost. If agencies deem that this change is too expensive to implement, they may simply choose to drop their status as first responders. In that case, this bill may have the opposite of the intended effect. The deployment of this medication presents several logistical challenges, as it needs to be stored at a temperature range that is difficult to maintain in a first response vehicle without special equipment. Police cars, for example, are often stored outside and when not in use and are not necessarily equipped with climate control technology for reliably maintaining medications at temperature. Historically and currently, there have been significant shortages of EpiPens, would requiring potentially thousands of first responders in Connecticut to carry EpiPens worsen the shortage for patients who need to carry them for their own personal use. Training all first responders in the state to be able to effectively administer this medication is a significant process, and the cost of such would end up having to be borne by the agencies. One of our organization's primary legislative priorities right now is to increase funding in general to the EMS system, which is already insolvent. This bill presents yet another unfunded mandate that will cost an already bankrupt system at least hundreds of thousands of dollars to implement and maintain. We do want to do this important work, but we simply cannot afford to do even the work that we are already tasked with. In conclusion, I strongly encourage the members of this committee to consider amending the bill to recommend that ChemSMAC consider using their existing process to change the Connecticut OEMS protocols to allow EMRs to administer epinephrine, which is in alignment with national standards, and to include funding for first response agencies who elect to carry epinephrine that could be used to provide the initial education, as well as to purchase the medications and any specialized equipment needed to store it properly. Thank you very much, and I'm open to any questions you may have.
Thank you so much, Mr. Peprosky. Good to see you again. About a couple of years ago, this Public Health Committee had passed a bill because of the cost of epinephrine to have dilutional epinephrine that is going to provide the same dose at a fraction of the cost. And that was just for that very purpose that we passed that bill, because somebody wanted to make too much profit off epinephrine from the pre-formulated one. Why can't you use that? That's literally sense.
The problem is that having EMRs, emergency medical responders, draw up IM medication is not in their scope of practice nationally. So we rely very heavily on the national scope of practice because in many ways it's evidence-based and validated. The current educational standards are not sufficient to train an EMR to do check and inject versus the EMT standards, the emergency medical technician standards, do allow for providers to do that extra skill. It's dangerous. It's very easy to draw up a fatal dose of epinephrine. And we believe that we should align with the national standards and reserve check and inject kits for EMTs and not for EMRs, which again would be in alignment with the national standard.
Okay, well, we passed the bill giving you the training and the opportunity in the state. We were able to do it, but what you're saying is that you feel uncomfortable following the state of Connecticut law around it?
No, I'm saying the law allowed for EMTs to do it. This law looks to expand that to EMRs. EMRs only receive about 60 hours of training. EMTs receive upwards of 150 hours of training, and that training is inclusive of being able to draw up from a vial a medication that would be given in the IM route. This law really looks to just allow EMRs to use auto injectors. So they wouldn't actually have to draw up the dosage. The dosage is already in there. So we would support allowing EMRs to do it. We don't agree with passing a bill and legislating the scope of practice. We have a process, a regulatory process, which the Office of OEMS and their ChemSAB and their protocol committee could allow EMRs to use auto injectors, which we do support, but we think they should use the existing process. Anytime you legislate, standards of care, the challenge is, and sometimes that's good, but if the standard of care changes, then we have to go through another legislative process to then change what we're able to do. And we've run across this, many times before, like such as the minimum equipment lists for the state. I think at one point we're in statute and not as part of regulatory language. So we're just sensitive to that. We have a process that works. I think we should just, the bill can be amended to just advise ChemSAB to use the existing process to expand the scope of practice to allow the use of those auto injectors. And again, we would not advocate EMRs to be drawing up epinephrine out of a vial. We think that's too risky, and it's not in their scope of practice nationally.
Okay, well, thank you for your testimony. I'll just say that with respect to the new medicines that are out in the pipeline for anaphylactic shock, epinephrine has been there for quite some time, and I'm not anticipating a significant change for us to come back and change the law for not having epinephrine around. So, but I appreciate your testimony. Representative Dauphiny has a question or comment. Representative Dauphiny.
Thank you, Mr. Chair, and thank you for your testimony. So I just want to clarify, so EMRs can give auto injectors, but that's in their scope of practice, but not drawing it up in a vial. Is that correct?
That's correct, in the national scope of practice.
But not in Connecticut's scope of practice?
In Connecticut, currently EMRs are not authorized to give epinephrine, according to the statewide protocols. So if we did allow them to give it, it would align us with the national standards if we allowed them to use auto injectors where the medication is pre-drawn up, and there's less room for dosage error.
Yeah, understood. Okay, thank you so much. Thank you, Mr. Chair.
Thank you. Seeing no other questions or comments, we thank you for your testimony today. And I will go back to Kimberly Lanyon. Sorry, we missed you earlier. For some reason, it didn't show up on my screen. So you're on. Welcome.
Oh, good evening. It's nice listening to all of you talk. My name is Kimberly Lanyon, and I am a nurse at Danbury Hospital, unit number 47.
Kimberly, we don't see you. Do you want to turn your camera on?
I can.
Thank you.
I don't think I can. Maybe I can.
It's in the left lower corner of your screen.
I guess I'll just speak. Can I just speak?
Yes, please.
Okay, thank you. I'm talking about the patient's staff ratio testimony. I've been an ICU nurse for 34 years at the bedside at Danbury Hospital, and I have not seen such unsafe staffing nurse-patient ratio as bad as I've seen it now. If the administration lawmakers that are making the decision on staffing are not working at the bedside within the last 3 or 4 years, they have no idea what the demanding responsibility, state of obligation the nurse has today. Patients are living longer, they're more unhealthy, they require more complicated care. Nurses' responsibilities now include bedside dialysis, more technical equipment, elaborate medications, demanding protocols. For example, some of our patients require every 15-minute vital signs, and you have 3 or 4 patients in the ICU. And of course, more endless documentation to appease the state requirement, which takes us a lot of time away from the bedside. Basically, what I want to say is, bottom line, we need more nurses at the bedside. Incentives to keep them there, and the ability to nurture new nurses, or our future is very dim for us and for the public. Does anyone have any questions for me?
Thank you so much for your testimony. We appreciate your testimony. Seeing no questions or comments, we will move on to the next person on our list, which is Jacob Pelletier, who is not here, I believe. And then after Mr. Pelletier, we have Peter Cordu. Mr. Cordu, you're on.
Sorry, can't get my camera on. There we go. All right. Hi, thank you very much. My name is Peter Cordeau. I'm president of Norwalk Hospital, but first and foremost, I'm a registered nurse. Started my career at the bedside in ICU with a full head of hair in 1987, having over 36 years of experience caring for patients, working my way through the ranks to my current position, including that of Chief Nursing Officer, which I'm very proud of. Today, I'm speaking in opposition to the proposed mandated nurse-to-patient ratios laid out in SB 1067. While well-intentioned, this legislation will interfere with the nurse's critical ability to remain nimble, negatively impact care, and decrease access to care. As an RN, I know how demanding being a nurse can be. Even before COVID, the profession of nursing was increasingly difficult. The pandemic only exacerbated these issues. A unit that's effectively staffed both satisfies the needs of the patients and plays to the strength of each nurse, and no one disagrees with that. However, rigid nurse-patient ratios only work in circumstances where care is predictable and census is predictable. What we do in an acute care hospital is not predictable. Patient care is dynamic. It's not one size fits all. Mandating nurse staffing ratios considers none of these factors and will impact critical decision-making and ultimately patient safety. As the hospital president and RN, supporting our nurses is my highest priority. I value close relationships with our staff, particularly our nurses. I'm on the ENHP board, Education, Nursing, and Healthcare Professional Board of the University of Hartford. I arrive at this hospital 6:15 every morning before morning shift each day in order to be accessible and respond to the needs of our teams. During the height of COVID, I personally worked alongside the frontline nurses, transporting patients, suctioning patients in the COVID ICU every day, had to hold the phone to a patient's ear to read last rites because family wasn't allowed and clergy wasn't allowed at the bedside. We were the family to those patients. Past few years have been difficult for all healthcare workers, with particularly burden placed on the nurses. Addressing the staffing challenges felt across the state and the country is top priority, and I support many strategies to address these issues. However, mandated staffing ratios is the wrong strategy, which potentially worsen the staffing challenges, degrade patient safety, and decrease access across Connecticut. Something I haven't heard today as related to the ratios, and this is an open-ended question, not a statement, is what happens when the census is low? I urge you to oppose SB 1067. Thanks for your time, and I'm pleased to answer any questions that you may have for me.
Thank you so much for your testimony. I just wanted to clarify, did you say you were a bedside nurse?
Yes, ICU, 1987, I started at St. Mary's Hospital in the ICU.
No, currently.
No, I still hold my license and worked alongside the staff during COVID to do all things essentially non-nursing, transferring patients, although suctioning was well within still my skill set, and being there during that time of COVID where we actually had our own staff as patients in the ICU.
Thank you.
Was
But
there.
how long have you not been a bedside nurse? I just wanted to make sure.
18 years.
Okay, thank you. Thank you. All right, we have a question from Representative Zupkus. Representative Zupkus.
Thank you, Mr. Chair. Hi, Peter. It's nice to see you.
Yeah, likewise, Leslie.
My question to you is there a nursing shortage at your hospital?
Yes, there is a nursing shortage, Leslie, at this hospital, as well as from where I am in Norwalk across the 95 corridor. So what you see is a lot of hopscotch with staff going from hospital to hospital, chasing on sign-on bonuses. So the net, I think, of the overall nursing availability is no different. People are just changing seats, but there's certainly a shortage and a lot of temporary staff across all hospitals in the state.
Thank you. And what I have heard a lot tonight is that if the ratios were as to what it is proposed in this bill, safer, because I do believe ratios make it safer. I mean, I don't think there's anyone here that would disagree with that. But if the ratios were as it is proposed in this bill, that nurses would come back. And I just wanted to know your thoughts on that.
I don't see that. As Jim Ike-Bellis mentioned, the nursing workforce is aging out. My greatest fear is that who's going to get into this profession? There's no value proposition for this. And I agree, there's no quality of life. I also take offense that I think the assumed comment that I haven't been at the bedside for 18 years doesn't mean that I truly understand what's going on in my hospital and on the floors. I think weighing in on this is very important. And there's nothing more important to me, as I spoke to many nurses a couple of weeks ago during an award ceremony, that there's nothing more than I want to have this place fully staffed to meet their needs, because then I'd decrease turnover, decrease sick time. Another thing that hasn't been brought up is, during the height of the pandemic, we had over 500 nurses out at the same time across our health system. What are we supposed to do at a time where we were mandated to increase and double our size of our beds? The work that had to be done was heroic, but at the same time, we did everything that we could to take care of patients. So, I don't think the unintended consequences are, as Jim said, if you don't have staff, your only other opportunity is to decrease your census in the hospital.
which is a problem.
Yes,
because
a
People
big
come in
problem.
and they can't get service, but thank you. And I do know when you were a bedside nurse, you were wonderful. So
Thank you.
thank you. Nice to see you. And thank you for your comments.
Thank you. Seeing no other questions or comments, we want to thank you for your testimony.
Thank you.
Move to the next person on our list, who is Stephen Fiquire. I'm sorry, I may have mispronounced your last name.
It's quite all right. My name is Stefan Fikir, if anybody can hear me.
Can you turn your camera on to Stefan,
Of
please?
course, I'm trying to do it. I'm actually currently, one moment, please. I'm trying to work this thing. There we go.
Good. Welcome.
Hello, how are you guys doing?
Very good. Thank you. Please go ahead.
All right, so my name is Stefan Fikir. I've been working with the state for about 10 years, going on 11 years now. I work with the Department of Developmental Services for majority of my career. I'm currently working with the Department of Mental Health now. You know, I wanted to join this meeting and to testify in support of the Bill 9. And you know, I really would love to ask that the committee includes in this bill a fund to at least 30 million for recruitment and retention of state healthcare workers, and in languages that will really help create and increase for understaffing in our department. So in the YAS program now, we usually have about 11 to 12 clients. Ages range from 18 to 25, sometimes 26. And a lot of our clients struggle with mental illness in our agency. And, you know, our clients have core current medical, substance abuse, psychological issues, which can make their treatment really difficult. Across our residential sites in Bridgeport, serving our clients, we only have 4 staff. Literally, we have 4 staff on my shift, which is really, really like bad for us. And it can really create a issue for us, because a lot of the times when we have, like, if one of our staff call out, it's hard to cover those shifts. And then when nobody wants to cover those shifts, we have to have our supervisor come in to, to cover the shift. And sometimes that's not even feasible because she has so much work to do herself, and with the clients we have, they have frequent behavior issues, frequent substance abuse issues. And with the low staff, it's really hard, and it makes it really unsafe for a lot of us that are working there, so that really creates a real big conflict for us as staffing to help out these residents. And we have had multiple situations where complication with medication have landed our clients in restraint in the hospital. Staff had to call 911 to help the client with the experience when they're experiencing psychosis and active suicidal situation where staff members' full attention was needed. And and it was hard for us to help de-escalate the situation. So sometimes when we having those issues, we ourselves can't even handle that. We literally have to call the police to help us with it, because we're so understaffing, We know that across the state healthcare agency, 1 out of the 3 positions are vacant. We are seeing the harm and that causes every day with us and our residents in a life or death situation. Proper staffing. Can you hear me?
Says, yes, sir, your 3 minutes has expired.
Oh, okay.
All
I'm
right.
so sorry. I'm so sorry to hear that. So I'm gonna make the last few seconds. I'm gonna make the last few seconds really quick. Proper staffing would really help benefit our client psychologically and health wise. And that's all we're asking for, to just help with that, to help with our staffing, because that is really a life and death thing, and we really want to make sure we're here for these clients to make sure they're okay and safe. That's all.
Thank you. Thank you so much for your testimony. Seeing no questions or comments, we will move on to the next person on our list, which is Vernette Townsend. Ms. Townsend, you're on. Welcome.
Well, thank you very much. Good evening, Mr. Chairman and Madam Chair. Thank you for this opportunity to testify on behalf of Senate Bill 1067. My name is Vernette Townsend, and I am the Chief Nursing Officer at St. Francis Hospital and Medical Center in Hartford, and I am a resident of East Windsor. I am here with you today to testify in opposition of Senate Bill 1067. I have been a professional nurse for 38 years. My career began as an Army nurse and has spanned many clinical roles at the bedside, as well as several leadership roles. I have held hurting patients and I have held hurting nurses. We are joined together as leaders and bedside nurses at the core of our profession. The foundation of our nursing career, my nursing career, has always been and will always be safe, quality, and patient-centered care. Again, that is what bonds us as bedside nurses and nursing leaders in administration. A foundational truth to ensuring these standards has been the knowledge that establishing safe standards for shift care or nursing staffing plans involves critical thinking on the part of the nurse and the nurse leader, as documented by care needs for these patients in their care plans. Using mandated numbers to determine staffing needs solely defies the logic of individual patient care planning based on individual patient care needs and preferences. I have significant concern that Senate Bill 1067 will have, because of the rigid staffing requirements, will have unintended consequences, including exacerbating the current workforce challenges and causing delays in care. St. Francis has a workforce of approximately 1,300 RNs. We currently have 253 open and posted nursing positions. Despite creative recruitment strategies, we are unable to bring in candidates as the pipeline is not robust. As a state, we need to partner and focus on strategies to improve numbers of nurses available to work in our state, not to exclude any of the previous mentioned strategies. St. Francis is committed to welcoming our new graduate nurses as our integral part of our new workforce. However, we recognize that their clinical preparation has delayed their transition into practice, and they require longer periods of time to become productive members in our workforce. St. Francis has a turnover rate of 34.7%. We experience an increased movement of our acute bedside staff into the travel nursing world, which gives financial opportunities greater than what hospitals can provide. And we look to our state to partner with us to arrive at solutions to stop this exodus. Patient care is a complex process, and staffing needs of patients can change shift by shift. They change hour by hour, and we look at it every 4 hours to ensure that the close coordination of nurses, doctors, and all clinicians are there to ensure that our patient needs are met. As a nurse who has worked more than 37 years for caring for patients, I know the decisions regarding patient care should be made at the bedside, not by rigid mandates that undermine the professional judgment of nurses. Staffing decisions require a high degree of flexibility and professional judgment by experienced and knowledgeable nurses and their leaders. Providing the best care for patients is not achieved through a mandated ratio. Thank you for consideration for my position. Any questions?
Thank you so much for your testimony. We appreciate your position. Seeing no questions or comments, thank you so much. Next person on our list is Jennifer Peck. I had called earlier, but I guess I missed you. Thank you. Welcome.
Hi, thank you very much. I had to leave briefly earlier.
Thank you. And you've been here all day and you leave for like 1 second and we call your name.
I had to pick up my son at school.
Welcome.
Good evening, Senator Anwar, Representative and Senators of the Public Health Committee. Thank you for the opportunity to provide testimony in support of SB 1067. My name is Jennifer Peck, and I'm glad there are so many nurses here as I'm about to have a cardiac event for going off of my testimony. I'm a resident of Windsor, Connecticut, and I have been a registered nurse for 19 years. I specifically want to address the focus on, quote, will the bedside nurses come back? And none of us know, but I will say as an old trauma nurse, if you have a bleeding patient in front of you, the priority is to stop the bleed. I think that if hospital nurses are leaving as fast as the pipeline produces them, you've gotten nowhere and the patient is still hemorrhaging, and it's time today to stop the bleed. Nurses who are stretched too thin cannot maintain the safety of their patients. We cannot safely monitor their condition or respond in a timely fashion with necessary interventions. When a patient is entrusted to our care in an acute care hospital, they deserve, at a minimum, to be safe. Safe staffing is about maintaining a minimum level of acceptable safety. Those of us in support of the bill are telling you flat out that on a daily basis, hospitals require nurses to care for more patients than they can safely take care of. We are telling you that despite their rhetoric, hospitals make operational choices on a daily basis that do not prioritize safe nurse staffing we are begging the legislature for help. As a community member, I fear to trust the safety of my loved ones to one of our understaffed hospitals. And I fear that until there is legislation establishing a minimum level for safe staffing, Connecticut hospitals will be reluctant to make safe staffing a priority. When you are a patient in a hospital, being safe should be a minimum guarantee. Bedside nurses are telling you that beyond a certain number of patients, they are unable to maintain safe patient care. I urge you to support SB 1067. Thank you for your time and wish a Ramadan Kareem to those who will be observing.
Thank you so much. I will be observing, so thank you. Any questions from anyone? Seeing none, we thank you so much for being here throughout the day with us, and thank you for the work that you do every day. Thank you. We will have the next person on our list, which is Christina McCulloch.
Hello, good evening. Can you hear me?
Yes.
Great. Good evening, and thank you for this opportunity to testify today. I am speaking in opposition of Senate Bill 1067. My name is Christina McCullough, and I am a registered nurse and also the president at Sharon Hospital in Sharon, Connecticut. I started my career in healthcare more than 20 years ago as a critical care nurse at the bedside, and have since held a number of roles, including leadership roles such as Chief Nursing Officer and Director of Quality and Safety. I deeply respect each and every nurse and healthcare worker for their commitment to the profession and am humbled by the work they do each day. Whether the registered nurses speaking today are administrators or bedside staff, we all recognize the staffing challenges that exist and have the same goal, that being a safe working environment for patients and caregivers. Enacting rigid nurse staffing ratios is the wrong decision for Connecticut's hospitals, the patients we serve, and have potential unintended detrimental impacts on patient quality, safety, and access to care. As a small rural hospital in Sharon, Connecticut, our ability to maintain top patient quality ratings is a testament to the close engagement between our leadership team and staff on the front lines. Together, we're able to make collaborative, real-time decisions about how many patients are assigned to each nurse, which nurses care for each specific patient, and we take into consideration the severity of our patients' needs and the experience level of our nurses. This collaboration will become more difficult if there are mandated ratios. I'm concerned about the lack of flexibility that would be available if a mandated ratio were passed and what that would mean for our patients, particularly as we continue to face struggles recruiting clinicians to rural areas and continue to manage a significant workforce shortage. Removing this flexibility and mandating ratios is not the solution for our state's hospitals, nurses, and patients. I thank you for the opportunity to speak this evening.
Thank you so much for your testimony. Representative Zupkus has a question or comment.
Thank you, Mr. Chair. Thank you for coming tonight. My question is, I've heard tonight, a lot about patient safety. And my question is if, and I've heard all different comments about that, patient falling out of bed, all kinds of issues with, working on a patient and having to go to another one and like the medicine is out, all of those things. Are all of those incidents reported?
Yes, in our hospital, and I assume that it is this way in all of the hospitals, we have a reporting system that anyone can go into and report any type of event. It can be an anonymous report or a report that's associated. We do encourage people to put their name so that we can, once we do our investigation and we want to close that loop back with the person that experienced the event or reported the event, to work on corrective action or work on things that we could do moving forward to prevent those sorts of things.
Right, because I don't know a lot about it, but I know falls have to be reported and submitted to the state. I know there's certain things that gives a hospital for lack of a better word, a rating for safety. And
Mhm.
so when I hear all of these things, it's very concerning, obviously, to all of us, because patient safety is first and foremost in care. And so I'm just curious of all of these incidents that make it unsafe, that they're reported and to the state, and then the hospital gets rated on it. So that was.
Yeah, so the way I initially answered your question was I was referring to like our internal reporting structure, but there is also reporting that's mandatory at the state level if there are adverse events, and there's specific criteria on which events need to be reported. So yes, that does occur.
Great, thank you. Thank
You're
you.
welcome.
Thank you. I see Senator Marks and then Representative Dauphiny. Senator Marks.
Hi, yes, thank you, Chair. Thank you for being here. So you said that there was corrective action for the adverse events, which I usually, my light isn't good, which I usually think that means that the nurse or whoever was involved is going to get written up for it usually. Is it ever written in the corrective action that this adverse event happened because of poor staffing?
Yes, so I can clarify what I mean by corrective action. It's really our approach to process improvement. So when we're looking at an event, we consider all different factors where there are process issues that caused this to occur, maybe something in the EMR. Were there staffing concerns? We look at that. Were there equipment malfunctions? We look at that. So looking at all of the potential root causes of an event, and then determining what can we do from a process improvement perspective, what corrective action can we put in place pertaining to what that root cause was to ensure that it doesn't occur in the future.
Okay, it would just seem that improving staffing would probably be why many medication errors. I know I've made one medication error in my life, well, that I know of in my lifetime. I'm sure I might have made others that I just didn't know I did, which happens a lot. But one that I still think about, sometimes you make a med error and it haunts you for a while. And it was because I was on mandatory overtime and I was rushing and I was exhausted. So if you do put that in because of poor staffing and that the staff person that made the error does not get penalized for it, bravo to you. I think that's wonderful. I don't find that happens very often. And that's really what a lot of the nurses, why it's so difficult for them, because they are being disciplined for the adverse reactions and the med errors and the falls. And it's just because they don't have the staff. So if you do that, bravo to you.
Thank you.
Thank you. I think that was more of a comment. We will go to Representative Dauphiny.
Thank you, Mr. Chair, and thank you for your testimony. You talked about divvying out the patients according to their level of need and the abilities of the nursing staff that you were assigning them to. Can you elaborate a little bit on that and how that's done? I mean, it's been a few years since I've worked in the hospital, but I do remember the level of need and how that was spread out. And so sometimes ratios look different. For example, a nurse might have 5 or 6 patients versus another nurse that might have 2 or 3. And it is always a reflection of the level of need of the patient and the skills as you described. And maybe just explain a little bit further for those that don't understand that, what that means and how that looks.
Yeah, sure. And I know this came up in a couple of different testimonies this evening. But when we make a staffing plan for a particular unit, we look at the acuity of the patients. So how sick those patients are, how much assistance they may need. Do they need one-to-one observation? Do they need frequent vital signs versus someone who may need less attention. So when we make that assignment, we're taking the number of nurses that we have and divvying that up. So it may not be that every nurse on the unit has 5 patients because of the different acuity levels. If you're a nurse and you have 1 patient who's constantly getting out of bed, and we know that you'll be in that room more, you may have an assignment with only 4 patients, or your other patients in your assignment may not have, you know, the level of needs that one patient does. So it's adjusted, and it's adjusted throughout the day. It's something, you know, as patients are discharged and admissions come, that the leaders in the hospital are constantly looking at to modify those assignments.
Thank you for that answer. And Mr. Chair, if I might elaborate one more time. So is it fair to say that you'd be concerned that these mandated ratios might not allow you that flexibility that you have now in terms of moving things around in assignments and doing it based on level of need?
Yeah, my concern with the mandated ratios is that, you know, it doesn't solve the problem. It doesn't solve the root of the challenges that we experience, and that's workforce. And that's come up a lot tonight. And we talked about pipelines and recruitment and retention. And really, though, that's what we need to address in order to solve the workforce problem. By enforcing mandated ratios, you know, it could have other effects, such as if you have all of your nurses in your hospital are at their max ratios and you just got an influx of patients, what do you do with those patients? Do you close your doors? Do you close units? Where do those patients go? That's the concern when you get to really strict ratios.
Understood. Thank you so much for your testimony. Thank you, Mr. Chair.
Thank you so much. Thank you for your testimony. Thank you for being here with us today and staying with us for, I believe, a significant part of your day. We appreciate you and the work you're doing. Seeing no other questions or comments, we will go to the next individual. But before we go to the next individual, we'll take a 1 to 3 minute break because the YouTube that we are using has run out of space. We have been doing this for about 8.5 hours. So this would be a good time to stretch your legs so you don't get any clots. But if you do, there are plenty of nurses around.